because this happened because often there is a resection, ileocecal resection due to the IBD, and there is a absorption problem of the vitamin B12 of folic acid. So there is a vitamin B12 and folic acid deficiency anemia. So if there is a macrocytosis, folic acid and vitamin B12 should be measured annually, but if there is a resection, it should be measured even 6 monthly to prevent or to treat the B12 and folic acid deficiency anemia, and accordingly you should give the folate supplementation or vitamin B12 supplementation if you can detect the B12 and folate deficiency anemia. Another is the drug-induced anemia in IBD. That is a different drug which is issued. These are the different immunosuppressive drugs such as sulfasalazine can cause the folic acid deficiency. Methotrexate can inhibit the bone marrow. Azathioprine may be associated with the pancytopenia. So drug-induced anemia also found in IBD. Blood transfusion usually not needed, but if the compelling situation there, patient have the hemodynamic instability or hemoglobin less than 7 gram%, all other treatment has failed. In that case, blood transfusion can be given. So conclusion: anemia is a very common, most common extra-intestinal manifestation of IBD, often overlooked by the physician like other diseases, and anemia can be both iron deficiency anemia or anemia of chronic disease due to the presence of inflammation or combination of the both. And there is some fallacy of using the standard parameter, usually what the physicians use to diagnose the iron deficiency anemia. Ferritin, use of ferritin or the level of ferritin or cutoff value of ferritin should be considered with caution and may be tricky, and you have to exclude the presence or absence of inflammation before using the level of ferritin as a cutoff or important evaluator for the iron deficiency anemia. So anemia of chronic disease and anemia or true iron deficiency or functional iron deficiency, these are three components to be evaluated separately and to be treated separately with cautions. And oral iron not very effective in IBD. It is a parenteral iron is more useful except the few situations. So thank you for inviting me. Thank you.
I think you can hear my voice. It is an excellent deliberation, yes, Professor Paul. Now it is open for questions from the audience. Yes, carry on. Do you have the mic? No, give him the mic.
Hepcidin is one of the important factors for the deficiency of the iron in case of the IBD. So, what did you think about the monoclonal antibodies?
Yes.
That is anti-hepcidin antibodies developed. And number one, role of interference RNA and role of antisense oligonucleotide against hepcidin.
Yes. This part I have not touched upon. Because I have talked more from the physician's viewpoint. One is the hepcidin is very important because functional iron deficiency anemia is very common entity in IBD, because hepcidin in presence of inflammation released from the liver, and what is causes it prevent the release of the iron from the ER system to the hematopoietic system. So hepcidin causes the functional iron deficiency. So there is a development of the monoclonal antibody against the hepcidin, so that the concentration of hepcidin decreases and the iron is released from the stored to the hematopoietic system. This is another is the IL-6. Hepcidin production increases in presence of IL-6. There is a cytokine. So anti-IL-6 antibody also in the process of development, so that the inflammation, the release of hepcidin decreases from the liver. This is very tight. I have not touched upon that issue.
Okay, we shall proceed to our next session. Professor Paul, please take your seat. After that, we shall have more questions. Now, the next speaker is Dr. Sandeep Ghosh. His topic is anemia and tropics, practical issues. No, sorry. Management of anemia in ischemic heart disease. I am very sorry. The management anemia in ischemic heart disease. My vision is blurred due to mask. I am very sorry.
Thank you, sir, for the organizers of BeSHCON for giving me an opportunity to speak in front of this august audience. And I also thank the respected chairperson for introducing me. And I'll be starting off with my speech regarding management of anemia in ischemic heart disease. So ACS, we all know, represents a grim challenge in the global cardiovascular health. And the situation in India is no different, and ACS, that is cardiovascular disease, has already surpassed the communicable diseases in relation to the mortality. Now, there is some difference in the, and nearly 2/3 of all the dailies and half of all IH-related deaths occur in low and middle income countries. And this is because of the comorbidity pattern. And the comorbidity pattern between the in the high-income countries is somewhat different in the, from that of the low-income countries. Also, there is anemia contributes to ACS-related morbidity and mortality. One important way in how we actually prognosticate patients with acute coronary syndromes is with a Gray score. And the Gray score actually doesn't take into consideration anemia as one of its parameters. However, various studies have been conducted, and it actually improved the prognostic performance of the Gray score once the anemia has been incorporated within this scoring system. Salisbury et al. Has shown that the prevalence of hospital-acquired anemia to be to the tune of around 57%, and of which mild anemia is around 37% of the patients, moderate is around 15%, and severe anemia in 5% of hospitalized patients with acute myocardial infarction. So what are the determinants of anemia? So in patients with ischemic heart disease, so this includes a decrease in the erythropoietin production, and that may be because of an advanced renal failure, inflammatory condition, because many the anemia in the situation in the background of ischemic heart disease dominantly because of an anemia of chronic disease. Also, there is an increase in plasma volume related to erythrocyte mass and hemodilution because of heart failure. And the other is a bone marrow failure, maybe because of vitamin or iron deficiency, maybe hemoglobin synthesis disorders, etc. And there are various other determinants like the age, gender, the BMI, race, etc. So, in anemia in ACS has three distinct types. One is on admission anemia, that is the patient was detected anemic at the time of admission with the lab parameters. And this anemia actually had a worse prognosis unless corrected, and many of these patients were older. These patients had multiple comorbidities. And it has been shown in studies from India that patients living in the rural areas, they tend to be more anemic and then from those in the urban areas. The other aspect is the hospital-acquired anemia, or the patient developed anemia at the time after the patient has been hospitalized. And the profile of these patients are similar to that of on-admission anemia. These patients were of older age, female sex. They had increased chances, these patients had cardiogenic shock, acute renal failure. They had a background history of a chronic kidney disease, and with the use of extensive antiplatelets and anticoagulants, these patients tended to be anemic. The other parameter is a new onset anemia post-discharge. So these patients had a fall in the hemoglobin concentration of less than 0.5 grams per dl, more than 0.5 grams per dl than the pre-discharge values. And these patients tended to have increased mortality and new rehospitalization rates with heart failure. So what is the effect of anemia on heart? Chronic anemia results in eccentric left ventricular hypertrophy and left ventricular enlargement. And this will result in the development of congestive heart failure. And there is a relationship with the volume load and viscosity. So with increase in with the hematocrit, there is an increase in the viscosity. And in ischemic heart, if the viscosity increases, the cardiac workload also increases. So you can see this is something like a J-shaped curve here. Coming to the cause of anemia in ischemic heart disease. So the dominant cause of anemia in ischemic heart disease is the anemia of chronic disease. The others include primary bone marrow malfunction. Patients may have an underlying renal failure, and that may cause reduced synthesis of erythropoietin. There may be hemodilution because of heart failure in the background of acute coronary syndrome. The patient may develop GI bleed due to use of antiplatelet agents. And this occult GI bleed may actually go on unnoticed, and the patient may land up with anemia. The other parameters include nutritional deficiencies, especially in patients who have multiple comorbidities, and they may include iron deficiency anemia, B12 or folate deficiencies, and these may all contribute to development of anemia in ischemic heart disease. So what are the clinical determinants of hemoglobin levels in this background? So one is African ancestry, and these patients tended to have less hemoglobin than the 0.5 grams per dl, lower than the Caucasian counterparts. Elderly patients have a lower hemoglobin level, and this is because of sarcopenia, because of the reduced muscle mass, maybe because of stem cell alterations, because of lower reserve of hematopoietic colony forming units. They have a decreased level of the anabolic steroid or sex steroid hormones in their body. They have a reduced erythropoietin induction secondary to hypoxia, and there is an impaired inflammatory answer, and there is a slowdown of the catabolism of cytokines, and minor anti-inflammatory action of the sex hormones in these patients are not so prominent, and there is and these sex hormones induce an extension of the inflammatory answer after the stimulus removal. And lastly, hemodilution. And in patients with ACS, with heart failure, they have a hemodilution, and that may contribute to the development of anemia. And how anemia influences cardiovascular risk? There is it influences a short-term risk, like an imbalance between a myocardial oxygen supply and demand. So patients with these patients with ACS already have a compromised cardiac function, and anemia will increases the heart rate and decreases the oxygen carrying capacity of the blood. And actually this will actually potentiate the ischemia in the heart. And this may contribute to development of what we call as a type 2 MI, or a supply-demand imbalance or balance mismatch type of MI. Also, there is impaired capacity of vascular healing because of decrease in nitric oxide synthesis in, as well as in anemia, in the background of anemia in patients with ACS. There is the inflammatory flux in patients with a cardiovascular disease, and that is because cytokine-mediated inflammatory response in ACS mediated by interleukin 1, 6, TNF-alpha, interferon gamma, or TGF-beta. All this will reduce the half-life of RBCs. The bioavailability of iron is reduced. This is basically a protective mechanism to ward off infections, because many of the organisms, they utilize iron as a source of food. And so in this background, in anemia of chronic disease, the bioavailability of iron is reduced, and so hemopoiesis is also reduced, and Professor Pal has already elaborated on it in my previous lecture. There is a reduced erythropoietin production, and these patients actually need increased levels of whole blood transfusion. Now, whole blood transfusion is also fraught with a lot of problems, because we all know whole blood transfusion may improve the oxygen carrying capacity. But the other downside is that the stored blood cells, they actually have a much lesser amount of nitric oxide, and that reduces the oxygen delivery to the tissues. And also packed cell transfusion may cause a hyperviscosity, and that may increase the cardiac workload in an already compromised heart. The long-term risk may include pathologic changes in inflammation, thrombosis, and other pathways that influence atherothrombosis. And also there is a provision of fewer and less intense medications because these patients are less likely to get optimal guideline-directed medical therapy. These patients tends to get lesser amount of antiplatelets or lower dose, or may skip the antiplatelet drugs may be not given to these patients, and so this may contribute to a greater cardiac risk in this subset of patients. And lastly, anemia actually may, in some studies, may serve, shown to have serve as an efficient biomarker in long-term risk predicting cardiovascular morbidity and mortality. Moderate anemia is associated with severe RBC dysfunction and reduces nitric oxide in the blood. RBC dysfunction with endothelial NOS dysfunction adversely affect the outcome in patients with acute coronary syndrome. Endothelial dysfunction along with various comorbidities and anemia might contribute to left ventricular dysfunction in ACS. And these patients of ACS with coexisting anemia along with diabetes and CKD have a worse prognosis, and they have double the risk of they double the 10 years mortality risk in these patients as compared to their non-anemic counterparts. So this actually summarizes what I have said previously regarding the interface between acute coronary syndrome and anemia. And because acute coronary syndrome ultimately leads to hypoxia in the myocardial tissue and the organs by as a background of a myocardial necrosis, there is an increased risk of anemia, pump failure, hypotension, etc. And anemia causes reduction in the oxygen supply to the organs. And ultimately, this will culminates in development of hypoxia of the myocardial tissue and organs, and thus contribute to the increase in the mortality. Coming to the management of the patients. So we should, in these patients, we should always go for workup of anemia in these patients, including the routine bloods, the reticulocyte counts, as well as the ferrokinetics, B12, and the folate levels, as that has been already described by Professor Pal in my previous lecture. So, and this should go hand in hand with the management of anemia, because ACS is basically acute condition, and so we cannot wait if the patient is hemodynamically compromised. So anemia should be corrected to provide adequate oxygen supply. So the first thing that come to our mind is a blood transfusion. So blood transfusion in this background can be either we can go for a conservative way, that is a more restrictive levels of transfusion, that is 7 to 8 grams, or we can go a more liberal way to 9 to 10 grams. So which is better? So studies have shown that more restrictive transfusion of 7 to 8 grams in patients per DL in patients with ACS will have a better outcome and than with a liberal transfusion. And this has been validated by the TRIX trial. However, the only exception is the very critically ill patients who are admitted to ICU. In these patients, a liberal transfusion to a more sicker patients receiving a more liberal transfusion have a better outcome. And also the CRUSADE registry have shown that the effect of transfusion is better with patients who have a hematocrit less than 24 than in patients who have a hematocrit more than 30. Unstable patients with ACS may benefit better with the hemoglobin levels between 8 and 10 grams per DL. So unstable patients, we go for a more liberal transfusion, and other patients, we should target more restrictive levels. And the transfusion is not devoid of any side effects, and these may contribute to the cardiovascular risk, and that includes transfusion reactions, transfusion-related circulatory overload, increased systemic inflammation, erythrocyte slugging in the capillary vessels, and transfusion-related acute lung injury. So the next thing that comes to our mind is, can you use erythropoietin? Because their animal studies have shown that erythropoietin use in these backgrounds may actually increase the hemoglobin levels, have cardioprotective actions, have anti-inflammatory actions. However, studies like the REVEAL study have shown that use of erythropoietin have actually increased the mortality, and so this drug is actually not used. Studies with darbepoetin like RED-HF trials have also shown an increased risk of thrombotic events and strokes with use of darbepoetin. So erythropoietin is not recommended in management of patients of ACS with anemia. The other thing that comes to our mind is the use of intravenous iron, because intravenous iron has been used in patients with heart failure and with good results. And it improves the functional capacity and quality of life in anemic patients with heart failure, and it has a protective immunomodulatory effect in macrophages, infarcted myocardium, etc. However, there is no data available to provide recommendation for treatment of iron deficiency anemia in setting of ACS with intravenous iron. And it has been shown, this is actually a chart how we manage iron deficiency anemia in a background of heart failure, and this is not actually recommended in patients with acute coronary syndrome. So the other aspect that we go on to manage anemia is preventing and quickly addressing complications like bleeding. So the other aspect that we should think of is we should address the bleeding risk and following the treatment with antiplatelets and anticoagulants and thrombolytic agents. So this is actually balanced with a balance between thrombotic risk and increased risk of thrombosis and increased risk of bleeding. So the thrombotic risk can be calculated with the use of a DAPT score, and the bleeding risk can be calculated with the use of a Hasbled score. So the various authorities like the ESC in the 2020 guidelines, they have incorporated the bleeding risk in patients in the management of NST-ACS patients with patients with a high or a very high risk of bleeding, having a more shorter duration of the dual antiplatelet agents, and with the optimization of antiplatelet, like in patients with low risk of bleeding, they have advocated ticagrelor, which has an increased propensity of bleeding, whereas they have recommended only aspirin and clopidogrel with a bleeding risk of high bleeding risk, and for 3 months. And for very high bleeding risk, the duration has been curtailed to 1 month, with use of clopidogrel in the very high risk groups and use of aspirin in the high risk group as maintenance therapies. Similarly, in patients with NSTEMI with atrial fibrillation, in patients in which the cardiologists recommend oral triple therapy, that is oral anticoagulants with dual antiplatelets, they have also taken into consideration patients with a high bleeding risk with triple therapy followed by a dual therapy, that is a NOAC plus single antiplatelet agent for 6 months, and then NOACs alone, in contrast to patients with a lower risk in which the triple therapy, that is NOACs plus single antiplatelet therapy is continued for 1 year. So what will be our approach in these patients? So the approach is the measures should be taken to minimize risk of bleeding in these patients. So we should always go on to minimize the risk of patients bleeding in this background. The next thing is we have to integrate the bleeding risk algorithm like Hasbled score within the usual care pathways. Next is transradial access. So transradial access, in contrast to the transfemoral access in patients with ACS, decreases the risk of bleeding. So this is the picture of a transradial access. The next is use of vascular closure devices. There are now lots of devices available like a ProGlide or a Manta. These actually are used when we use a very big diameter catheters in patients for management of ACS. And next is dosing of the antithrombotic therapy. That should be weight adjusted and according to the renal function. Restricted transfusion threshold of 8 grams per DL appear to be reasonable, in contrast to a more liberal approach, the only exception being patients who are very sick. And primary angioplasty for ST segment elevation ACS should not be delayed because of pre-existing anemia. And trials from Israel and from UK have shown that these patients actually, these anemic patients with ACS who receive a primary angioplasty actually fare similar to those patients who are not anemic. So thank you all for your patient hearing.
Thank you, speaker, for your very informative presentation. I think this can invite a number of questions, but it has been decided that after the next session, there will be combined question answer session. Okay? So let us go to the third part. Third part is anemia in tropic, practical issues. There will be a panel discussion. Before formal starting, I just say one thing, that whenever we say these two words in the same breath, anemia and tropic, that we feel sentimental because it reminds us of Professor J.B. Chatterjee. With this introduction, I think we can start this session. In this session, I am asking the presentators, moderator Dr. Soumitra Ghosh, and the other panelists are Dr. Kaushik Pal, Dr. Jyotirmoy Pal, Dr. Arijit Sinha, and Dr. Sanchita Saha. I request all of you to come to the dais and to monitor the presentation.
With respect to the chairpersons, I must thank the organizers of BeSHCON for incorporating this topic, because in most of these conferences, these tropical issues, our own issues, are often not highlighted much. So they have given a beautiful topic as a panel discussion on what are special about Indian subcontinent and particularly the tropical countries. So we have 4 eminent panelists here. So without wasting much of time, I can start the discussion. So I will first go to Dr. Kaushik Pal. Sir, what actually we mean when we talk about these? So when we talk about this anemia in tropics, so what actually we mean about this? Because anemia is not something which is special about tropics, but what are the etiologies which may actually signify special about tropical countries, particularly India?
Basically, in clinical terms, anemia, we basically defines anemia in tropical countries as when in male patients, when hemoglobin falls below the level of 13 gram per day, and in female it is less than 12 gram per day, and in pregnant women it is 11 gram per day. So in clinical terms, when patient's hemoglobin level falls below the range, this cutoff part, then we define that it's a case of anemia.
Sure. Now, what are actually the common etiologies associated with this anemia in tropical countries? So what actually do you come across more frequently?
In tropical countries like in India, mostly we have seen that mostly the cause of anemia is nutritional deficiency, mostly iron deficiency anemia, megaloblastic anemia. These are most common. There are lots of causes of anemia in India, but considering the iron deficiency anemia, which is most common in Indian population, it basically occurs due to 3 to 4 causes. One is due to poor dietary intake. This is the very most common cause. Patient basically nutritionally very poor. And other causes are increased loss, such as like GI loss, and in pregnant women. Like
So keeping apart these causes of deficiencies like iron deficiency, so nutritional deficiencies like this, other than this your, I mean your megaloblastic anemias, do you consider some kind of infestations like helminths or other infections very common in tropical countries?
This can be due to poor absorption also, and the bookworm infestation is very common. Patients commonly present with pain abdomen. So, and another one is increased loss, and there is increased demand, such as in adolescence and in pregnancy. Basically, iron demand increase, but if we take poor dietary iron, so definitely there will not be the proper replenishment, and as a result, iron deficiency anemia will occur.
So do you also consider some kind of hemoglobinopathies or, more common in the tropical countries?
Hemoglobinopathies will come next. Mostly a nutritional deficiency after that, especially in very young children and in young adolescents. Hemoglobinopathies, thalassemia, sickle cell anemia will come, especially in West Bengal, eastern part and as well as western part of West Bengal and Assam and Odisha also. In India, this is very thalassemia prone zone. So it will vary upon this. The diagnosis will be dependent on the basic clinical presentation.
So thank you, sir. To show what Dr. Pal said, summarily, it is the nutritional deficiencies related to iron and these other B12 and others, these megaloblastic anemias, some kind of infections and infestations, and some kind of hemoglobinopathies, which is special about these tropical countries should be discussed in this panel, because these are the special issues related to our country like India and the tropical countries. So I will next come to our very special Dr. Sanchita Saha. Huh?
May I add something?
Yes, yes.
Because another very important factor is the socio-economic condition of the tropics. Basically, the Indian subcontinent, East Asian country, Latin American country, there is a peculiar rainfall, humidity, temperature that causes there is the more proliferation of the different, very suitable environment for the organisms, and also huge population lies in this region. That is why in one side, though there is a more production of the grains, but at the same time, due to the overpopulation, there is a poverty more in these tropical countries. So poverty leads to anemia. This is one part, and due to the overgrowth of the different organisms, and so there is a more infection, and due to the poverty, and there is a many of the diseases remain neglected. So WHO termed as a neglected tropical disease that lead to the anemia of this country, apart from the different hemoglobinopathy.
Yes, certainly. This poverty leads to nutritional deficiencies and some infections and some tropical diseases. Yes.
One thing is important, that the tropical countries, the socio-economic status is low than compared to others, and the health consciousness is also poor. There are some foods, vegetables, which are usually we take in the tropical region. The general people is not conscious about the quality of foods and which will be helpful for them or not. Some foods are, if taken at a time, some iron may be absorption may be hampered with some foods. So the awareness of the foods with their good quality of irons and vitamins, and it is important. And most important is, I think, there will be dietary counseling for the general people. So the vegetables are available, but which would be beneficial for them, it should be discussed with the general people. So the role of dietitian in the rural areas particularly is very much important to avoid these dietary deficiencies.
Okay, thank you, sir. Very important comment. I will come to Dr. Sanchita Saha. So what are the factors associated with iron deficiency anemia related to the tropical countries? Highlighted many points already. So what special other things you want to comment on?
Thank you, sir, for the question. Actually, already discussed that the socio-economic status, the availability of the foods are there, but the awareness of the common people, especially in urban, those in the slums areas, and as well as the village people. And if I especially discuss on the women part, I mean feminine, but the young women, they are like pre-pubertal age, they are morally nutritional deficit. They do, as well as the infection, hookworm infections, most common in our setup, and some genetical diseases which are prevalent among them, with some hemoglobinopathies, some chronic disease like chronic malaria, maybe malaria endemic areas. Those are prone to develop hemolysis and some sort of disease. So these are in the pre-pubertal and pubertal. In reproductive age group, they are, as we are having multiple number of consequences of pregnancy, and the gap between the pregnancies is very less. So the nutritional deficiencies are more prominent among them, especially iron deficiencies, and they frequently have history of PPH, blood loss due to PPH, and again the requirement is more in pregnant state and lactating state, which is not fulfilled. And as our social the pattern of our family pattern, that the male should get the first and the good things, this will again lead to deficient state in female. Again, some sort of chronic disease which persists in this age group, and in postmenopausal again the multiple drugs, all these hampers iron absorption, again the nutritional status, and some malignancies also leads to this sort of which ultimately lead to iron deficiency state.
Thank you, madam. So I will.
The very important issue is in the village area, the Indians, more people walk in the barefoot. That causes the more hookworm infestation, and also vast majority of Indians are vegetarian. That also one leading cause of anemia in this country. These are some predisposing factors.
Very important.
Yes. So that is the deworming is.
These are the very important points, definitely, sir. So next I will come to Dr. Arijit Sinha. So what are the common causes of this megaloblastic anemia, as Dr. Pal was telling, Dr. Kaushik Pal. So what are the causes of megaloblastic anemia special about these tropical countries?
So megaloblastic anemia is due to some dietary deficiencies, or due to some absorption problem or deficiency of intrinsic factors, or that there is any pathology in the absorption sites. Some tropical sprue, pernicious anemia, and some infective disorders, tuberculosis and inflammatory bowel disease, all can cause impaired absorption of vitamin B12 and folic acid. And these are the more or less common causes, but it is when a patient came with anemia in an institution or teaching hospital, it is easy to diagnose. But most of the patients in the periphery, in the rural areas, there the diagnosis of megaloblastic anemia is late. Sometimes we see in the ward that patients with severe anemia with symptoms of heart failure admitted with the mala of jaundice. They thought that, the relatives thought that patient is being pale due to jaundice. They have forgotten to think about anemia. This happens, and sometimes it also happens that the patient presented or admitted with features of heart failure. The patient was in the rural area treated by some coax for heart disease with some aspirin, nitrocontin, etc. drugs. So diagnosis in early is important, and to the cause, exact cause to be evaluated for further progression of anemia, and adequate treatment to be done. Early diagnosis and proper diagnosis and etiological diagnosis is very much important, which is sometimes lacking in our rural areas.
So other than these, do you think that these nutritional factors related to our cultural, these other religious factors, many people in our country are vegetarian. Many aged women who are particularly widows are vegetarian. So these may lead to sometimes deficiencies of quality proteins, which are the rich source of B12, folates, etc. That may contribute to these megaloblastic anemias in tropics. Okay. Next, yes. I will come to Dr. Jyotima Pal.
Another point is, so much use of pantoprazole. Pan40 is now the most common over-the-counter drug, and it increases the pH. And one day may come that it will be the most leading cause of anemia. This acidity is very important for absorption. So, so this will in future we physicians should be cautious about.
We are coming to the drugs later. So I will coming to Dr. Professor Jyotima Pal. So you are talking about these neglected tropical diseases. So what are the common infections or infestations which may lead to this anemia in tropical countries?
Yes, most important infection is the worm infestation. Due to basically the socio-economic issues. The one point I already there is a barefoot. People walk in the barefoot and hookworm infestation. Another people in many villages till now people have no pure water. They take the water from the pond or bath taken in the barn, that time they swallow the water. And unhygienic condition, unhygienic cleanliness, lack of cleanliness, all this lead to the worm infestation and go in the families and all the mohallas after mohalla. This is one issue. Another is a very common malaria. Malaria is rampant. And in the 60s and 70s, malaria, so many stories are there with the outbreak of malaria. So many life has lost due to the malaria, but after the malaria eradication program, this problem to some extent had decreased. And and due to the high endemicity, many people have the malaria and anemia without any history. If you take the history, patients say, I have never had the history, but you will get the anemia and large spleen. Because of the asymptomatic and febrile malaria, this is very common in the rural, because of the presence of antibody, much antibody, the fever often not manifested, but patient had the malaria. So this is one infection very common that leads to the anemia in our tropic, and another is the worm infestation. These two are the most two common, apart from all the, even the tuberculosis, high prevalence of tuberculosis for the thousands of years in India, and often undiagnosed, untreated, and anemia is a very common common association with the tuberculosis, and because of the malnutrition. And our ex-Prime Minister in 1971, Mrs. Indira Gandhi, in Sweden, in a conference of environmental science, she told very nice word. Among the all pollutants, poverty is the highest pollutant. So if you cannot remove the poverty, we cannot remove all these tropical diseases.
So other than these, common infections and protozoal infections, do you think this tuberculosis, which is also predominant in tropical countries like India, these may also have some role on this anemia in tropical countries?
Not only poverty, poor hygiene also.
Yes.
Poverty is always associated with poor hygiene, and this is also the another cause.
The poverty leads to this education and other health issues may be related to the socio-economic conditions as well. So these are usually linked with all this sense of hygiene comes from this health education and other issues that may have some relation with the economic issues, other social structures, availability, etc., other things. So these are all interlinked. Yes?
This is a vicious cycle.
Yes, this is a vicious cycle. So how do you think this tuberculosis in our country, Dr. Sinha?
Tuberculosis is more prevalent in our country, though the incidents are decreasing. The tuberculosis and tuberculosis associated with HIV infections, those are more susceptible for anemia. If intestinal tuberculosis is there is chances of malabsorption, and due to tuberculosis and poverty, there is poor intake of the mineral, vitamins, etc., or irons, minerals, for RBC development. But one thing is important, the behavioral abnormalities, the pica, the eating of soils, particularly during pregnancies or in some rural areas, clays, that may cause infestation of the worms, and sometimes the contain lead in the soils that may cause lead induced anemia. And another infectious disease is now COVID. COVID is also a cause of anemia due to interleukin surge. There is a hepcidin mediated iron deficiency anemia, and it is seen that patients with COVID with anemia are more in risk for worse prognosis.
So I will come to Dr. Jyotirmoy Pal. You have worked in the field of HIV for a long time. So how do you think this HIV may have some role which is also predominant in the tropical countries like India? So what may be the relation with HIV and this anemia?
Yes. HIV anemia is a very common association due to the so many factors. One, HIV is a chronic infection, it's a chronic inflammatory state. Like any other chronic inflammation, that can lead to anemia. It can be iron deficiency, it can be functional iron deficiency, or it can be anemia of chronic disease. Anemia is chronic disease and iron deficiency, both are very more common in HIV. Iron deficiency anemia basically due to when the patient has HIV, he loses weight, loses appetite, have the chronic diarrhea, so have the poor appetite, and also the socio-economic factors. He loses the job. All these factors lead to the iron deficiency anemia. And due to the inflammation, there is the bone marrow suppression, that erythropoiesis is suppressed, that lead to the anemia of chronic disease. Another factor, the many drugs is what we use, though nowadays we are not using so much, but with the zidovudine, that can cause the bone marrow suppression and very common when in the early first 2010 to 2000 around 12 or like the last 10 years we are not using much zidovudine, but before that zidovudine anemia was very common. Patient used to come with heart failure or severe anemia, we have to transfuse the blood.
So, thank you, sir. I will come to Dr. Jyoti Kaushik Pal. Sir, you are talking about these hemoglobinopathies which are predominant in these tropical countries. How do you think these, what types of hemoglobinopathies are predominant in tropical countries, particularly India?
In India, mostly thalassemia, and among thalassemia, HBE beta thalassemia is most common, most commonly seen. Besides this, there are some Punjab variant is also there, beta thalassemia major is also there. So mostly these three, HBE beta thalassemia, especially in
different
India,
other parts of the country like Maharashtra, Chhattisgarh.
It varies.
Sickle is also very common.
Yes, sickle, especially in Odisha and in East Mednapur, West Mednapur area, sickle cell is very common. So but in West Bengal, mostly we get HBE beta thalassemia, followed by beta thalassemia major, and sickle cell anemia. We found is very less amount, less in number. Mostly it is seen in East Midnapur, West Midnapur district areas, as well as in Orissa.
So one common question is actually faced by these medical practitioners, these general practitioners as well, that when a child comes with say anemia, these hemoglobinopathies is one of them who presents with microcytic hypochromic anemia, and this iron deficiency anemia, as all the panelists have been common in projecting this nutritional and the iron deficiency anemia, these two things may present with microcytic hypochromic anemia. So how to take decision, because in one situation we will give iron and in one situation we will avoid iron. So how to decide that whether it is an hemoglobinopathy or it is iron deficiency at the outset, at the very beginning of seeing a microcytic hypochromic anemia in a child?
It is based on two things. One is patient's clinical presentation first, then after that we proceed for investigation. First is age of presentation. It is the primary thing. So suppose a 6 months or 7 months old baby is presenting with anemia requiring frequent transfusion, definitely we should keep in mind that this can be a case of transfusion dependent thalassemia. And suppose a case of in case of non-transfusion dependent thalassemia, these are mostly presents after the age of 2 years, mostly after 5 years, or in any stressful condition. Suppose in pregnancy, often incidentally detected that during pregnancy, transfusion of PRBC is increased, and at that time, after seeing the reticulocyte count and MCV, especially gynecologists proceed for hemoglobin HPLC. And these are mostly non-transfusion dependent thalassemias.
Okay. Does this RDW may help to differentiate between these two things?
Yes, this is lab diagnosis, but I am coming from the very clinical presentation, and we have to see another one thing, that whether there is history of any family history is present or not, whether the patient has any jaundice or not, whether patient is any complaint of any, we have to ask that whether he is passing any warm stool, any warm in stool is whether it is present or not. Patient can present with abdominal colic as warm colic, which is, and it can present as periumbilical abdominal pain. So we have to take the history. And the very first thing, especially I have seen in district areas, the physicians do a basic mistake. They have seen anemia, hemoglobin 5 or hemoglobin 8, first they transfuse. And this is the basic mistake, I think.
That is a common, yes sir.
I can say something actually.
Yes sir.
The thing is that I have my
On করে নিন স্যার একটু মাইকটা।
The clinical, we have said, the moderator, that we are getting a patient of microcytic hypochromic. So we have thoroughly examined the patient clinically. At the very outset, after examining a patient clinically, he will be able to come to a conclusion that whether he is suffering from thalassemia or iron deficiency anemia. Now after the microcytic hypochromic, other parameters in the peripheral blood. I can experience my share, my experience actually. Tufan is here, so many hematologists are there. I have seen in my own experience that if the MCV is in between 70 and 80, mostly it is due to the hemoglobinopathies. And if it is less than 70, the more it is less, the more chance of iron deficiency anemia. This is my practical experience.
Very important
actually.
point, sir.
Sir, another one thing in parameters, when we come in parameters, we have to see two things. One is RBC count. In iron deficiency anemia, RBC count will be low. And in thalassemia, the RBC count either will be normal.
That is also a very important
and
parameter.
another one distinctive point is the RDW.
Yes.
RDW in case of thalassemia, it will be normal. In case of iron deficiency anemia, it will be increased. As well as in case of megaloblastic anemia also.
Yes.
The RDW will be definitely increased.
So that is a very common pitfall in the childhood. So I will come to this pregnancy. In tropical countries, pregnancy is an important factor associated with anemia also. So what are the factors, particularly in tropical countries, with pregnancy related with anemia? Dr. Sanchita Saha.
Yes, sir, already as discussed that
Yes.
the gap between the pregnancies is less.
Excuse me, we have only 1 minute more.
Okay, just to look for the search for the all in details, as well as having a exclusion of all the clinical chronic diseases, especially chronic malaria and hookworm infestations and any other. I mean, the general physician should look over this matter, sir, with a complete, basic complete blood count will guide the physician.
Thank you. Multiple pregnancies, postnatal care, these are also important. So Dr. Jyotirmoy Pal was talking about the drugs. So I will come to Dr. Kaushik Pal. So what do you think, what drugs actually has to be kept in our mind, particularly in tropical countries? Like diabetes is a very predominant factor. Which drugs may cause these, or these pantoprazole, like, which are commonly used for a pretty long time? So how do they interfere with these nutritional factors and other things related to anemia in tropics?
We have 1 minute more.
This will depend upon the disease. Mostly we have to look into the matter that in tropical countries and in India, what are the diseases that are very common and what are the drugs commonly the general physicians prescribe. So the common drugs we have to see for pantoprazole. In India, rheumatological disease is very common, so we use methotrexate. Then so definitely we have to look for megaloblastic anemia. In India, Septran is rampantly used, and this can cause megaloblastic anemia. These are the mostly and diabetes. Diabetes is also very common. Metformin. Metformin is a notorious drug causing anemia. And in case of HIV, in HIV, girobirin, as sir has said, HIV is very common in India, and girobirin is the notorious drug for causing
thrombosis. Girobirin is not much used, Dr. Pal already said.
So these are the drugs we should commonly look for.
So I will not now come to the chairpersons as the expert. Do you have any comment or any question to the panelists, sir?
And actually excellent discussion, because the putting of questions is so important, and you did it very well, being the moderator, and everybody has contributed a lot in discussion. We have learned more. Now it is open for question and answer. Now the speakers, Ajay, would you please place a chair over here so that Dr. Sandeep Ghosh can come and sit here? Would you please send a chair over in the podium? Dr. Sandeep Ghosh can come and sit over here. Now, another question and answer session. Now, you please introduce yourself, then you ask the question.
No, I have got no question. I am coming from North Bengal, okay, and working over there for pretty few years in anemia as well as hemoglobinopathy. And few lines just I want to comment. First of all, already Dr. Kaushik already mentioned this part, that the one problem is that whenever we are getting any patient of anemia, particularly in the rural setup, first whenever they are seeing that patient is suffering from hemoglobin low, okay, give some blood or some hematinics. This is the one of the blunder they are doing. Okay, that is to be taken guard there. Proper therapy, detection, everything is jeopardized. In rural area, it is, yes, megaloblastic anemia is there, but one, my personal study is also there, that it is not the vitamin B12 so much. It is segregated mostly in some population group, those who are non-veg like that, but otherwise in the true rural area.
So what is your question?
No, I am just want to put some comments. I have already told. It is the folic acid deficiency. Number 3, hemoglobin E is very, very common over there, be it trait or be it homozygous or in double heterozygous state. Whenever we are thinking of your hemoglobinopathy or thalassemia, we used to discuss about thalassemia, hemoglobin E beta thalassemia. But one thing is to be kept in mind that homozygous hemoglobin E are also presenting with anemia.
Sir, one.
Can you hear me? Actually, I am interrupting you. Please take your seat. The thing is that the anemia, we are discussing about.
Mic turn করে নিন।
No, as because there was one point that how to differentiate between this hemoglobin E.
After the session, we shall discuss after the session. Next session is there. Actually, we are already running late. So the next question I want to ask, please introduce yourself and ask the question. You please come, take your seat. We shall discuss after the session between ourselves.
I am Professor Pranav Bhattacharya, Principal of Chakda Medical College, now, at present. Now, my questions to previous speaker who spoke on the SCS in relation with the anemia. Can blood donation can reduce IHD? Those who are donating blood, the incidence of IHD becomes less. My first question. My second question is, what is the role of damage of endothelial cell by reduced by the iron? That is.
We cannot listen from that mic properly. Give him a hand mic, please. The mic is defective. I think we cannot listen to him properly. We cannot hear him.
স্যার পিছনেরটা চলে যান না, একটা পিছনে মাইক আছে।
আচ্ছা, ওকে, আই এম প্রফেসর।
আপনি মাস্কটা খুলে নিন। এবারে বলুন। ও প্রণব, হ্যাঁ বলো।
হ্যাঁ ঠিক আছে, আমাকে আর ইন্ট্রোডিউস করতে হবে না। আচ্ছা, সেকেন্ড হচ্ছে যে আমার প্রশ্ন হচ্ছে যে এসিএস নিয়ে বলেছে তার কাছে যে ব্লাড ডোনেশন যদি কেউ করে কিছু ক্ষেত্রে সেটাকে আইএইচডি কমায়। নাম্বার 2 হচ্ছে যে এন্ডোথেলিয়াল সেলসের সাথে কি রোল এসিএস এর রোল, মানে উইথ দ্য অ্যানিমিয়া, আয়রন ডেফিসিয়েন্সি অ্যানিমিয়া। মাই কোয়েশ্চেন টু দ্য প্যানেলিস্ট।
No. Sort of one after another. We shall get confused. Okay. Let us have the 2 questions answered by the Dr. Sandeep Ghosh.
Okay, blood transfusion may actually is beneficial for the patients. Blood transfusion, periodic blood transfusion can decrease the hemoglobin level a little bit, but it doesn't actually directly won't cause a reduction in the ACS per se. ACS has a lot of multifactorial causes of ACS are there, and therefore.
যারা ডোনেট করছে তাদের কি কোনো রকম ভাবে কম হবে আইএইচডি?
না, সেটাই বলছি যে আইএইচডির অনেক কারণ আছে, তার মধ্যে একটা ব্লাড ট্রান্সফিউশন করলে কিছুটা হয়তো টেম্পোরারি কিছু বেনিফিট হতে পারে, কিন্তু লং টার্মে কোনো বেনিফিট হবে এরকম
না। যারা ডোনেট করছে
তার কথাই বলছি স্যার,
রিসিভ করছে তারা নয়।
আমি বলছি স্যার তার কথাই বলছি যে টেম্পোরারিলি তার হেমোগ্লোবিন যদি কিছুটা তো হেমোগ্লোবিন হয়তো একটু কমলো, তাতে হয়তো তার ব্লাড ভিসকসিটি কমবে, টেম্পোরারিলি কিছু বেনিফিট হতে পারে। লং টার্মে তার কোনো লং টার্ম বেনিফিট আছে এরকম আমি কোথাও পড়িনি স্যার।
কিন্তু ঘটনা হচ্ছে যে ব্লাড ট্রান্সফিউশন যারা করে তাদের আইএইচডি ইনসিডেন্স অনেক কমে যায়,
মানে তাহলে রেগুলার ট্রান্সফিউশন রেগুলার নিতে হবে।
Hello. Let me interfere, please. Professor Bhattacharya, please take your seat. Now, No, no, we shall discuss it later on because we have so many sessions. Now we conclude the sessions over here. Now I thank everybody, my co-chairperson, Professor Soumitra Ghosh, Professor Jyotirmay Pal, all my juniors.
All the
They have
panelists
spoken.
here.
And also to the Dr. Sandeep Ghosh. Okay,
Thank you,
thank
sir.
you so much.
Thank you.
I think with this we can say that the session is concluded. Thank you all.
Thank you, Chairperson and speakers, for your influential messages and presentations. Next, I go ahead with our session 2. The topic is platelet disorder based on the theme tiny but critical. For this, I would like to invite our first chairperson on the stage, Dr. Sambit Samanta, Associate Professor, IIHTM, Kolkata. And our second chairperson, Dr. Vidyut Goswami, Professor and Head Department of Pathology, North Bengal Medical College.
Can we start?
Hello.
I would request our first chairperson to introduce the speakers.
A very good afternoon to everyone. So after a session from anemia, we are now entering into thrombocytopenia. And the first topic is the diagnostic approach in thrombocytopenia in elderly geriatric patient. This is very one chapter, in fact very important, I thought. And our presenter is Dr. Pooja Prasad. She is going to present in virtual mode. So this is now open.
Good morning, everyone. Thank you, Chairperson, for inviting me for this talk. And I have pre-recorded my session as I was unable to be present there. So the organizers will now play the session.
Share your screen. Please share your screen, PowerPoint.
It is a recording.
Is my screen visible now?
Yes, ma'am. Okay, ma'am.
very good morning to all and welcome to BeSHCON 2022. At the outset, I would like to thank the organizers for giving me the opportunity to present at this conference on a virtual platform as I'm unable to be there. I will be talking about how to approach thrombocytopenia in older individuals. So without any delay, let's begin. Thrombocytopenia is one of the commonest reasons for a hematology consult. It is associated with a variety of conditions. The risks from thrombocytopenia ranges from life-threatening bleeding or thrombosis to no risk at all. Establishing the cause and determining the platelet count trend is very important for clinical management. Now, what is thrombocytopenia? It is defined as platelet count below the 2.5th lower percentile of normal platelet count distribution, which comes between values 2.5 to 97.5 percentile in normal individuals. So any platelet count below 150 into 10 to the power 9 per liter is defined as thrombocytopenia. It is further subdivided into mild, moderate and severe degrees. Mild is 100 to 150, moderate is 50 to 99 and severe is less than 50,000 platelet count. Now these are just numbers and these numbers should always be interpreted in the context of the underlying disease. The correlation between the degree of thrombocytopenia and bleeding risk is not linear. It is unpredictable and it varies according to the underlying conditions. There are few clinical predictors like prior bleeding episodes, presence of wedge purpura and hematuria, which can point towards a higher bleeding risk. So when should we worry about bleeding? It is a concern in severe thrombocytopenia, but it is platelet count, as I said, it is not a precise surrogate marker for the risk of bleeding. Clinically significant spontaneous bleeding usually doesn't occur till the platelet count is less than 10 to 20,000. However, even mild to moderate thrombocytopenia can be problematic. It can aggravate surgical or traumatic bleeding, and in certain conditions, it warrants treatment disruptions. For example, thrombocytopenia may hamper the initiation or maintenance of interferon-based therapy in chronic hep C infection. Even chemotherapeutic agents may require dose modifications or treatment interruptions in view of thrombocytopenia. So, and there are few conditions of thrombocytopenia where the patients are at a risk of thrombosis rather than bleeding, either in addition or only thrombosis. So these conditions should be kept in mind as these require urgent and immediate action to prevent life-threatening bleeding. These include heparin-induced thrombocytopenia, antiphospholipid syndrome, disseminated intravascular coagulation, thrombotic microangiopathies, paroxysmal nocturnal hemoglobinuria, and vaccine-induced immune thrombotic thrombocytopenia, which has been in the news after the use of COVID-19 vaccines, which were adenovirus-based. Now, the major pathophysiologic mechanisms for thrombocytopenia are decreased platelet production and an accelerated platelet destruction. Two less common causes include dilutional thrombocytopenia, seen in the setting of massive fluid resuscitation, or platelet sequestration due to congested splenomegaly through portal hypertension. But in several conditions, multiple mechanisms may be at play. This is a table showing the causes of thrombocytopenia in adults. On the top, we have primary and secondary ITP, followed by drug-induced immune thrombocytopenia. Infections, there is a list of infections like viral infections as well as intracellular parasites, hypersplenism due to chronic liver disease. Even thrombocytopenia can be seen in chronic renal failure in nearly 20% cases. Nutrient deficiencies, autoimmune disorders, and primary bone marrow disorders like myelodysplastic syndrome, bone marrow infiltration, bone marrow failure, or thrombotic microangiopathies. Now, why are we so concerned about the elderly population? Now, as the world population is increasing, so is the number of people aged more than 60 years. And it has been predicted that by 2050, they will comprise nearly 22% of the total population. And an increasing number of these older individuals will be found to have abnormal peripheral blood counts, including cytopenias. Now, these cytopenias will frequently pose clinical challenges in the older population. They also precede the development of hematological malignancies. as the 5-year cumulative incidence of hematological malignancies was 0.6% in these patients, in these individuals, and a higher incidence was seen when they had concomitant anemia or thrombocytopenia. The older population also has significantly higher major hemorrhagic complications in comparison to individuals who are less than 40 years, even at the same platelet counts. Thrombocytopenia in this population is associated with increased bleeding complications, increased transfusion requirements, increased use of multiple drugs, and morbidity. And this is especially true in those people who have a previous history of bleeding or who have cardiovascular diseases like stroke and hypertension, renal dysfunction, severe gastritis and peptic ulcer disease, or patients who are on medications that impair hemostasis like anticoagulants or antiplatelet drugs. The causes for thrombocytopenia will differ and depend on the clinical setting. So, a patient who is asymptomatic coming to the OPD with an isolated thrombocytopenia will likely have ITP or an occult liver disease or any nutrient deficiency, MDS, or HIV. In nearly 10% of HIV patients, the first manifestation is an isolated thrombocytopenia. A patient who is presenting with severe thrombocytopenia and symptomatic, the likely causes include ITP or DITP. In acutely ill hospitalized patients, multiple pathophysiologic mechanisms may be at play. Thrombocytopenia has also been reported in a wide range of patients at the time of ICU admission, and many will subsequently develop it. The thrombocytopenia correlates with severe illness, sepsis, and organ dysfunction. This is a table showing the clinical scenarios for thrombocytopenia in outpatient as well as inpatient setting, as I have told. Now, a practical approach to thrombocytopenia entails us asking few questions and taking few steps. Now, the three most important questions that need to be asked and answered are, is it true thrombocytopenia? So, to answer this, we need to repeat the CBC and check the peripheral blood film. If any platelet clumps like these are found, this is indicative of artifactual or pseudothrombocytopenia. The second question that needs to be asked is whether this is a new onset thrombocytopenia or is it a chronic one. So for that, a thorough history has to be taken and all previous reports and records should be accessed. The third most important question that needs to be asked is whether it is isolated thrombocytopenia or other cell lines are also involved. So again, review the CBC, check the peripheral blood film, check all cell lines, and rule out any thrombocytopenic emergencies like schistocytes seen on the peripheral smear, which will point towards a microangiopathic hemolytic anemia and thrombotic microangiopathy. Any dysplastic changes seen in the WBCs, which will point towards MDS, presence of blasts on the PS, indicative of acute leukemia, any suspicion of DIC or heparin-induced thrombocytopenia should be first seeked. So to evaluate the patient, a thorough medical history is of paramount importance. So the temporal profile of thrombocytopenia, all the prior platelet counts have to be asked for. The types of bleeding manifestation the patient has been having should be elucidated. The medication exposure should be taken in detail, which will include new prescriptions, any intermittently taken drugs, any over-the-counter medications, herbal supplements. In hospitalized patients, the drug chart should be reviewed extensively. Information about alcohol ingestion, any infectious exposure or travel to endemic areas, the dietary habits, other medical conditions, and history of transfusion must be asked for. Just a few words about drug-induced immune thrombocytopenia. There are various mechanisms which can be associated in this condition, and the list of drugs associated with DITP is exhaustive and an ever-increasing one. But usually this condition resolves in 5 to 10 days after drug withdrawal. The patient may present with moderate to severe thrombocytopenia and have bleeding manifestations of varying degrees of severity. So after history, physical examination for the type of bleeding manifestations must be looked into. Patients with thrombocytopenia usually have mucocutaneous bleeds with presence of petechiae or purpura, of which red purpura within the mucosal cavities is a harbinger of severe disease. Ecchymosis should be noted, and evaluation for an ischemic limb or skin necrosis can point towards heparin-induced thrombocytopenia. The bleeding characteristic helps to distinguish between the type of bleeding disorder, whether it is due to thrombocytopenia or clotting factor. So mucocutaneous bleeds with PTK and small and superficial ecchymosis are commonly seen in thrombocytopenia. These patients usually have excessive bleeding after minor cuts and immediate bleeding after the surgery or invasive procedure. After examination of the skin, examination of liver, spleen and lymph nodes to give some pointers to the underlying causes must be done. Coming to the third part, that is lab testing. So, review of complete blood count with indices and peripheral blood smear along with reticulocyte count will help in elucidating many causes. So, pseudothrombocytopenia is ruled out, platelet morphology is seen, RBC and WBC morphology is seen. Now, newer automated analyzers give us some newer platelet indices. So, of which platelet distribution width and mean platelet volume, PDW and MPV, are helpful in telling about the pathophysiologic mechanism causing the thrombocytopenia. Both of these are high in the thrombocytopenia occurring due to destruction, increased destruction. Another index is immature platelet fraction, IPF, which reflects the thrombopoietic response of the bone marrow. This is also higher in thrombocytopenia due to destruction in comparison with the thrombocytopenia due to decreased platelet production. So a combination of a low platelet count and a high immature platelet fraction is indicative of thrombocytopenia because of increased destruction. This marker is also a valuable predictive marker for platelet recovery, along with another marker, that is absolute immature platelet count, which resembles the absolute retic count. So, a decrease in the immature platelet fraction and an increase in the delta AIPC. Delta AIPC is the change in the absolute immature platelet count from baseline. If there is an increase in this and a decrease in the immature platelet fraction, this suggests that the bone marrow has recovered and has already produced a sufficient amount of new platelets. So, on the analyzers, the evaluation of isolated thrombocytopenia or combination of anemia with thrombocytopenia, combination of leukocytosis with thrombocytopenia or pancytopenia can give us pointers to the underlying conditions. So this is an algorithm based on the evaluation of thrombocytopenia after a peripheral blood film. So if peripheral blood film shows us platelet clumping, we know we are dealing with a case of pseudothrombocytopenia. If there is no clumping, it is true thrombocytopenia, after which platelet morphology and other cell lines should be assessed. If the RBCs show presence of schistocytes, then a workup for thrombotic microangiopathies and DIC should be done. If WBC shows changes like blast, dysplastic changes, or leukoerythroblast blood picture, bone marrow disorders, primary bone marrow disorders like leukemia, MDS, or bone marrow infiltration, MEDS, should be thought of. If there is presence of microspherocytes along with RBC agglutination and NRBCs on the smear, think about Evans syndrome. And workup for hemolytic anemia should be done. If there is presence of lymphocytosis, atypical lymphocytes, neutrophilia with toxic granules, then think of infection. If there is isolated thrombocytopenia, ITP and DITP are the common causes. So to confirm this algorithm, other investigations include hepatitis C virus and HIV testing, B12 folate levels, liver function tests, hemolytic anemia workup, coagulation profile, and autoimmune profile. Thyroid function tests and H. pylori testing are optional. Ultrasound abdomen should be done to look for liver, lymph node, and spleen. Always be on the lookout for red flags. Red flags include presence of blast or dysplastic changes indicative of malignancy, any evidence of hemolysis, associated coagulation abnormalities, recent use of heparin or skin necrosis, patients requiring urgent invasive procedure and having severe thrombocytopenia. These require an urgent referral to a hematologist. Now, bone marrow should be performed to rule out a primary bone marrow disorder in all older adult patients with thrombocytopenia. The underlying causes can include MDS, which is seen in nearly 12% patients of isolated thrombocytopenia. ITP, of which around 22% of patients are further reassigned as MDS after exhaustive evaluation. Other bone marrow failure syndromes like aplastic anemia and PNH. Also in patients who have nutrient deficiencies but do not show a response even after substrate depletion. So in those cases, a bone marrow should be done. So the bone marrow examination includes the process of aspiration and biopsy, which will highlight the morphology of the bone marrow, the dysplastic changes, presence of any abnormal localization of immature precursors, any collection of blasts. This will be seen on the morphology. Along with aspiration and biopsy, cytogenetics and molecular studies should be done. Molecular studies can be done using a FISH NBS panel or an NGS myeloid mutation panel. Now, the NGS panel has increased the diagnostic efficiency for detecting clonality. NGS has identified somatic mutations in some leukemia-associated genes like DNMT3, ASXL1, 1XT1 in the peripheral blood in up to 20 to 40% of individuals who are aged more than 80 years. Now, these mutations are not indicative for a malignancy per se, but these can be precancerous. So, in a patient with unexplained thrombocytopenia, who after even an exhaustive assessment, no cause can be identified, whose bone marrow shows some dysplasia but insufficient to make a diagnosis of MDS, that is less than 10%, and does not have any MDS defining cytogenetic alterations and does not meet the criteria for a bone marrow failure, is categorized into this entity which is known as idiopathic cytopenia of unknown significance. There are other entities as well. So we have certain new entities like ARCH, that is aging related clonal hematopoiesis, then clonal cytopenia of unknown significance, and clonal hematopoiesis of indeterminate potential. Now, if the NGS detects certain mutations and the variant allele frequency of those mutations is more than 2% and the patient also has cytopenia, then patient is categorized into the entity of clonal cytopenia of unknown significance. In patients who have a VAF of more than 2% but normal counts, has clonal hematopoiesis of indeterminate potential. And in ARCH, the VAF is also less than 2%, there is no dysplasia and no cytopenia, but certain mutations have been detected. These are important because there is a risk of transformation of these entities to MDS at a rate of nearly 0.5 to 1% per year. Hence, the evaluation by bone marrow along with the use of FISH or NGS is important in determining causes or predicting the transformation to hematological malignancies and clonality in patients with unexplained cytopenias. So, to summarize, thrombocytopenia in older patients presents with a different set of problems than in younger patients. Platelet count is not a precise surrogate marker for bleeding risk. Life-threatening causes should be considered initially in any case of thrombocytopenia and always be on the lookout for red flags, as I have told. Examination of the peripheral blood film is important to exclude spurious as well as serious causes. A structured approach to the diagnosis involves an integration of the clinical findings from a thorough medical history and physical examination and appropriate support from lab investigations. Common causes of a low platelet count in the absence of other hematological abnormalities and no evidence of a multisystem disease are ITP, PITP, and bone marrow failure. In hospitalized and critically ill patients, there may be several potential etiologies. Bone marrow examination should be done in older adults with thrombocytopenia to rule out clonal hematological malignancies. Thank you.
Thank you very much for exhaustive discussion on this thrombocytopenia in elderly. Few comments can be done. In differential diagnosis of elderly thrombocytopenia, senile purpura could have been mentioned because this is very, very common presentation. And in diagnosis, I think in case of platelet, it is the pre-analytical variables which is very, very vital. Often it is found that lot of platelet counts problems are there due to arising from the pre-analytical variables problem. And platelet count itself is another area which needs more emphasis, particularly it is the not the cell counter or the peripheral blood film. It is a manual count is to be also done, and better there should be one composite approach that is taking all under consideration. And thank you very much that you have already discussed some new entities in elderly thrombocytopenia with new acronyms. Tomorrow they will be more known to us. And now the session is open for questionnaires.
So I had shown the photograph of phenylketonuria and the bleeding manifestation. And yes, platelet count has to be checked properly, and pre-analytical variables play an important role.
Yes.
These new entities are coming into picture, and because the number of people with these unexplained cytopenias is going to increase, and because we are catching MDS and catching these cytopenias at an earlier stage now as compared to previously, so all these new entities are coming into play. And there is a modest but poorly defined risk of transformation or progression to MDS or AML as of now. But yes, let's see further studies what this is.
Yes, yes. Thank you.
Bidut, can I comment one thing? That we have talked about NGS, etc., etc. One thing I have not listened, that one cause of thrombocytopenia very common in our country is the dengue fever. Dengue causes much more thrombocytopenia, one of the commonest cause of thrombocytopenia. And when actually the platelet has to be transfused, there is much controversy. Some say it is 20,000, some say it is 40,000. That is not still...
Sir, thank you very much. Actually, this was, the topic was in the elderly, and I think she has already mentioned the causes of thrombocytopenia, I think so. Yes, yes, definitely.
So dengue has been mentioned
yes.
In the list when infections were mentioned.
Thank you, thank you. So, if there is no question, then we can end this session in this topic. Now, next.
Thank you, sir.
Our next presenter, Dr. Asif Iqbal. He is from Assam, that is Guwahati Assam Medical College, Guwahati Medical College, and in fact he is IHTM alumni in DM Haematology. He is very young and energetic. In fact, I met him in last.
Now he is assistant professor.
He is assistant professor DMG Adult Hematology Lymphoid and in the Department of Medical Oncology, affiliated to B. Borua Cancer Institute, Guwahati. And in fact, I can remember that I met him in Hematocon at your institute. Okay, and he has got one huge award within his pocket, that is Assam Gaurav Award. I thank you very much. Congratulations, Asif. And his topic is relapse and refractory immune thrombocytopenia, another big problem in case of platelet disorders.
I would like to thank Bengal Society of Haematology, my school from where I learned hematology, for this opportunity, and I thank my chairpersons for this gracious introduction. Without wasting any time, I would like to start with the topic that has been assigned to me, relapse and refractory immune thrombocytopenia. What are the therapeutic choices that we have today? So what is refractory ITP? This is the international working group definition This is persistence of thrombocytopenia after initial therapy, including splenectomy, with the need of active treatment to maintain a safe platelet count and avoid bleeding symptoms. But since many patients will not undergo splenectomy, and since splenectomy may not be a preferred choice of therapy for many patients, ASH has modified these definitions for all those patients who have not had a response or who had a relapse of symptoms with thrombocytopenia, even without clinically significant bleeding. So what are those symptoms? This can be purpura, they can be mucosal bleeds like wet purpura, or it can be small petechiae as well. Now, interestingly, the platelet counts, we know that there might not be a very linear correlations, but still we know this as the platelet count decreases, the symptoms and the severity of the clinical manifestations also changes. So we can expect wet purpura to develop when the platelet counts are below 10,000, and there is a very high chance of having intracranial bleeds when platelet counts goes below 5,000. There is actually a linear correlations with platelet counts with cerebral microbleeds, as you can see this graph also suggests the same. Now, what is the course of ITP? When we say refractory ITP, we are actually addressing a minority of the patients, because approximately 80% of patients, pediatric patients, will go into early remissions. But the problem is there in the adult patients, because adults will, many of these adults will have relapses. These proportions will respond well to if they stay on therapy, but a proportion of that will develop a progressive and increasingly refractory disease. This is the second line therapy for ITP, which is currently we are following. We have to confirm the appropriateness of the second line therapy. So how can we do that? We have to confirm the diagnosis of ITP, and possible causes of secondary ITP should be reviewed and treated. If the platelet count is below 10,000 and the patients have an ongoing bleeds, probably even after restarting steroids, or the patients will have a dependent on steroids, particularly a high dose of steroids, then we should consider for a second line of treatment. Now here the patient's preferences will also count. If the patient wants a definitive curative therapy, if it is a splenectomy candidate, then we can rule these factors out. If the ITP is present for more than 1 year, the patient can tolerate the procedure. If immunosuppressions and the VTE risk of splenectomy is acceptable, then we can go for splenectomy. Otherwise, we can confirm if the patients can undergo splenectomy after a while. So in that scenario, we can go for a TPO receptor agonist. If no, then we can go for rituximab. Similarly, if the patient wants to avoid these adverse effects of splenectomy and rituximab, then, and if the surgical morbidity and immunosuppressions is more than the benefits, then TPO receptor agonist can be considered as a second line in those patients as well. This is the ASH ITP treatment algorithms on similar lines. Here, if patients have an ITP, mean thrombocytopenia, for more than 3 months, and they are dependent on or unresponsive to corticosteroids, then in those categories, between 3 to 12 months, which we call as persistent ITP, we can go for primary treatment options with rituximab or TPO receptor agonist. Here again, the patient's value and preferences will count. If the patient places high value on achieving a durable response, then TPO receptor agonist will come. If the patient places a high value on avoiding a long-term chronic treatment, then rituximab will come. If the patient has been suffering for more than 12 months, then again, patients, depending on the patient's value and preferences, you have these following treatment options: splenectomy, TPO receptor agonist, and rituximab. So what are these second line agents in ITP? Splenectomy, TPO receptor agonist, and rituximab. The patient's value will depend upon these following factors. If you see, the early response is very high in splenectomy, maintains a very durable responses, financial burden is low. The positive clinical effects are that these patients have a long-term remissions in most patients, and they do not need any chronic treatment. Major side effects is that they are prone to infectious complications, venous thromboembolic events, and usually there are no other issues, so no other issues other than that. For TPO receptor agonist also, the early responses are good. patients will maintain a sustained response if they're on TPORAs. And off TPORAs, there is now some data to suggest that patients can be put on without a long-term TPORAs. Clinical aspects are that they are well tolerated without major side effects, and they avoid surgery. Potential adverse effects is for eltrombopag, you can have hepatotoxicity. Venous thromboembolisms is a risk factor with TPO receptor agonist. And there is a very small potential side effect of bone marrow fibrosis with this TPORAs. Quality of life issues for eltrombopag, you have a chronic dietary restrictions. And for romiplostin, they need to undergo weekly injections. Rituximab is a short-term therapy without surgery. However, the problem is that the early responses are good, but sustained responses are in the line of 20 to 25% only. There is not much financial burden. Again, the positive aspects are that they do not need chronic therapy and it avoids the surgery. Potential adverse effects, infusional reactions, and this B cell, the potential side effects of B cell depletion. Coming to the TPORAs in ITP, the platelet counts over time, I am comparing this to eltrombopag with romiplostin. If you look into these two curves, both these produces a very good and similar responses. Romiplostin produces a more sharp increase in the platelet counts during the initial weeks as compared to eltrombopag, but ultimately both of them have equal initial responses. Going to the romiplostin data, this is a 52-week open-level single-arm studies showing 93% platelet response in patients. And as I mentioned, one of the advantages of Romi is that it has a rapid onset, and the median onset of response is 2.1 weeks. In chronic primary ITP, the median platelet count steadily increased within the first 6 months before reaching a plateau, and during the romiplostin treatment, platelet counts rapidly normalized, and the incidence of bleeding declined to approximately 1/3. Again, if you see the median on-study dose is 2.62 microgram per kg per week, which is much below the vials. That is also one thing that you should also look forward to before prescribing romiplostin, because keep on 5 microgram per kg, then there will be an undue high risk of thrombocytosis and thrombosis. Look at the long-term extension study. In the treatment category, you see if the patients followed up for 5 years. This is in regard to the long-term safety. There is no increase in the adverse effects on long-term exposures of romiplostin. And if you continue the weekly treatment, then you can provide a long-term stability in the chronic ITP patients. This is one regard to the treatment-free remissions of romiplostin. If we keep continuously, this is one such idea that if you can continue for 1 year and then gradually reduce the dose by 1 microgram per kg every week, and after the 5 weeks, if we stop this drug and observe for 24 weeks, then there is a possibility that around 30% of patients may not require any more of drugs. So this is one possibility that we can actually give TPO receptor agonist for a definite period of time. Treatment of children in ITP. This is a result of the integrated database of 5 clinical trials, again suggesting that romiplostin reported a beneficial tolerance, and they maintain responses for at least 6 months, even while withholding all ITP therapy. Regarding the dose titrations, start with a 250 microgram or 3 microgram per kilograms, and if there is no response, we can give an incremental dose of 5 microgram to 7 microgram to 10 microgram, and there will be a minority, like 20% of patients, who may not have a response, and in that case, we can go for adding glucocorticoids, or we can either stop the drug and add a new immunosuppressive agents like rituximab or other agents. For chronic ITP, for refractory ITP, and even for patients who have preoperative thrombocytopenia, the doses will remain the same. If we compare romiplostin and eltrombopag in immune thrombocytopenia as a second-line treatment, we can see that the responses are almost comparable, and as compared to placebo, both these agents give a marked improvement in the platelet counts. And this is, however, a very big data, so we can clearly see that this may cater to the large number of populations that we treat. Regarding the second type of TPO receptor agonist, L-Trombovac, and look at the elevations in the platelet counts. This is in regards to the dose that we give. It's available in 25 milligram and 50 milligram. So we can see that the dose at which it works maximally is 50 milligrams, and possibly this 50 and 75 milligrams are comparable doses, and the suggestion is to give 50 milligram OD as the preferred treatment of L-Trombovac in chronic ITP. What about the long-term tolerability of L-Trombovac in chronic persistent ITP? I would quote this EXTEND study. The thromboembolic events in respect to both the in hepatotoxicity as well as the thromboembolic events, there it does not look like any patients who have experienced this drug requiring withdrawal of study. So that itself means that the suggested side effects of hepatotoxicity and thromboembolic events may not be very severe, which does not require withdrawal of therapy. This is one area where L-Trombovac probably has problems, because we have to keep the patients at least 1 hour off calcium-containing foods on the either side of taking the drug, and that might be very difficult in patients in all kinds of calcium-containing food products. So that includes tea, that includes sweets and antacids as well. Coming to the splenectomy. Splenectomy is indicated for patients with persistent or chronic thrombocytopenia, severe bleeding. However, the role of splenectomy is decreasing after arrival of this TPO receptor agonist, and in adults it should be delayed for at least 12 months. So first 3 to 12 months it's not recommended. If the patients have persistent, chronic ITP, which is persisting for more than 12 months, then we should consider it if the patient is fit to tolerate this procedure. In pediatrics, it should be probably delayed until and unless the patient is more than 5 years of age. So these are the risks and contraindications. If you see postoperative morbidity, that can probably complicate 10% of patients, including local wound infections and pneumonia. Postoperative mortality is low. Generally, there is an increased risk of infection which can stay throughout, and there is a risk of overwhelming post-splenectomy infections. There is a chance of postoperative rise in platelet count, sometimes very high, and that can cause undue high risk of venous thromboembolism. There is a risk of pulmonary hypertension, and it's usually contraindicated in patients who have an active infections. Other lines of therapy include rituximab. It leads to a selective depletion of CD20 positive B lymphocytes. Rituximab can be also used as a third line of therapy after the failure of TPO receptor agonist, and 60% of patients will achieve a short-term platelet response. However, there is a lot of relapses after this rituximab, so in long-term remissions can be expected in around 1/4 of patients. Researchers have established that children, women, and girls respond better to rituximab compared to the adults, respective, and this may be attributed to difference in the metabolism of rituximab. It is effective before or after splenectomy, and standard dose is 375 milligram per meter square once a week for 4 consecutive doses. What are the ITP advances? This is one molecule, fostamatinib. It's a Syk inhibitor, and it is recently approved by FDA for use as a third-line therapy in chronic ITP patients. As you can see, patients' responses by the lines of therapy, if you look into the third line of therapy, then you get statistically significant responses of 86% of patients if the platelet counts are more than 30,000. If you consider the durable responses to be more than 50,000, then the responses will be around 89%. These are some additional molecules which are still in the experimental phase, efgartigimod and rojonolazumab. They work against the neonatal FC receptors. I can quote few phase 2 studies comparing them with the placebo. This is also a phase 2 study. new lines of therapy, which has been published just recently. There are two molecules, BTK inhibitors. One is ibrutinib and one is rilzabrutinib. We know ibrutinib causes thrombocytopenia, but because of selective inhibition of BTK inhibition by rilzabrutinib, it can work for immune thrombocytopenia. As you can see, this selective BTK inhibitions in B cells, plasma cells, monocytes, and macrophages, rilzabrutinib is used. In fact, it is now coming up in an experimental trials. Whereas, if you can see ibrutinib, it also works against other BTK inhibitions and hence causes thrombocytopenia, drug-related thrombocytopenias. So phase 1-2 trials, which was published in the ASH 2019, they showed around in very low number of patients, they have shown in where rilzabrutinib was continued for more than 12 weeks, there is a responses in around 54% of patients. This is a platelet response for patients with ITP who was initiated in rilzabrutinib 400 milligram BD. Again, the responses are in line of 40 to 50%. And please note that these are multiple lines, failure of multiple lines of therapy. And if you can see, the duration of ITP also is more than 3 years in majority of patients. In 29 patients, out of this 45, the ITP duration was more than 3 years. So our response rates of somewhere around 40 to 50% is remarkable. This is daratumumab in adult ITP. Again, very small number of patients. It's coming up to be used probably in next few years, 21 patients. And the primary endpoint was considered to be 50,000 in 2 consecutive measurements. It was used as a rescue medicines, which is allowed after 8 weeks of initial therapy. And at least now there has been some promising results. There is not much differences since 2019 regarding the treatment of ITP. So in short, I can say that the management of ITP has changed over last decade. Since 2019, we have almost the same lines of therapy that we currently know. There remains some room of improvement. We can see those clinical, those experimental drugs being carried on. It's important to do the mechanistic study to better understand the immune landscapes to different ITP syndromes, and we can see that some new targeted therapies are coming up. Agents that induce long-term remissions of adult ITP still remain elusive. We still have large number of relapses in adult patients. All ITP trials should include a translational research component to allow better understanding of disease pathogenesis and probably allow more development of effective therapies. So this consort still holds true. Adult ITP, if it is more than 3 to 12 months, then their treatment, depending upon their patient values and preferences, we can choose TPO receptor agonist, either Romi or Romiplastim or Eltrumpobag or rituximab. And if it is more than 12 months, and again, depending upon the patient values and preferences, we can choose TPO receptor agonist, splenectomy, and rituximab. It's important to also note that a patient who fails one therapy can be always treated with the other. Thank you so much.
They work nicely. So that part is omitted, I think. Otherwise, you have discussed very nicely. Thank you. Now, question from the audience. Any question?
So if there is no question.
So no question, huh? So if there is no question, we'll now move our next part of the session. Yes, that is panel discussion. Panel discussion, bolo.
Thank you, sir.
Okay. So, next part of our session is our moderator is Dr. Sandeep Saha. He is now Associate Professor in NRS Medical College. And panelists are Dr. Kollan Khan, Dr. Shomir Behera, Dr. Trivikram Panda. Dr. Trivikram Panda is AIMS. He is now in AIMS, New Delhi. Dr. Kollan. Dr. Shomir Behera. Dr. Shomir Behera is Associate Professor of Pathology, MKCG Medical College, Berhampur. And Dr. Sandeep Saha.
Very good afternoon, and thank you for kind introduction. And very good afternoon to chairpersons, my seniors, colleagues, and friends. So we are discussing the platelet disorder, and here now we are dealing with a very rare cases, but because we are hematologists, we deal with very frequently this kind of cases. And I am very delighted we have very eminent experts, panelists. So we think we should start the session. So now start with the platelet disorder, which is inherited. So the true prevalence is really undetermined, and many lack the family history. Many de novo mutations are there, 20 to 30% in MH9, and variable bleeding tendency, not all present in childhood. Yes, really, these facts are really very true, because in our day-to-day practice, we deal with many patients. Sometimes we deal with the normal patients, or sometimes with the other kind of disorders, but on investigations we get the low platelet count. Sometimes we find that it may be suddenly discovered, or sometimes it is there since childhood. Now the platelet disorders we can divide into according to function or according to count. Now, what is the percentage or what is the incidence or prevalence in a society? So we have a data of UK populations. It's really very rarely found it is. That's Glanzmann thrombocythemia. Out of only 125 cases out of 66 million population. So it's very rare. BSS, Werner-Solier syndrome, this is also very rare, only 85 out of 66 million population. Now these are the inherited thrombocytopenia mutations altogether put in a pie chart. It's very difficult to read out everything now. So let's come into the facts. Now first we discuss the reduced functional problem. Before we start into the cases, just have a brief discussion on what the components we usually get on the surface of the platelet. So according to that defects, we divide the diseases. Like in Glanzmann thrombocythemia, here we get the GP1B9, 2B3A deficiency. In BSS, 1B9. Platelet type VWD, we usually find in this kind of disorder. These are the surface component defects. Scott syndrome, decreased prothrombin conversion. These are the examples. And what are the intracellular component defects? Usually alpha granule defects, dense granule defects, these things. Alpha granule defect, for example, gray platelet syndrome, and dense granule, Hermansky, Padalecki syndrome, or Chidiac-Higashi syndrome, or Gracilis syndrome. These are the examples. Now coming to the real cases. So first, the question goes to Trivikram. A 17-year-old female presented in an OPD. Nothing is coming into the screen. Please look at that.
ডিস্টার্ব করছে এটা। স্ক্রিনটাতে কিছু নেই, আসছে না।
কেউ দেখতে পাচ্ছে না, স্ক্রিনটা ঠিক করো। Dr. Tribikram, are you comfortable to look at the screen?
Yes, sir, we can carry on. Okay.
17 years old female presented with ecchymosis and petechiae and also the menorrhagia. And obviously the patient is having iron deficiency anemia, and in CBC on examination we got 70,000 platelet, and also we got the large platelet, but further process of coagulopathy examinations we get the PT and APTT both are within normal limit. So how do you look at the cases? How do you approach?
Basically, am I audible? Basically, in any case of young patient with features of bleeding, as in this case, initially we have to look for clinical examination. Then we have to see whether there is any family history of bleeding. Then we have to look for any facial and morphological dysmorphism in those particular cases. Then we have to calculate the ISTH BAT bleeding score. Basically, the total score is 56. If the score is more than 4 in case of males and more than 6 in case of females, then it is a screening tool. It points towards there is more predictability for inherited bleeding disorders. Then subsequently, depending upon the clinical examination and the result of ISTH BAT, then we would move forward for CBC. And in this CBC, there is thrombocytopenia and presence of large platelets. And subsequently, our next plan of action will be the screening coagulogram. As we can see, PT, APTT, serum fibrinogen, D dimer, everything is normal. So mostly we are dealing with a case of maybe inherited platelet defect. And as we can see in PS, here there is presence of large platelets. And in conventional light transmission aggregometry, we can clearly see there is aggregation. There is primary and secondary wave of aggregation with ADP, collagen and epinephrine, but there is absence aggregation with ristocetin. So basically, my diagnosis will be, it can either be a case of Bernard-Soulier syndrome, since there is presence of large platelet, but in the absence of large platelet, this type of aggregation pattern can also be observed in case of von Willebrand disease type 2.
Exactly. Can we consider it's a VWD type 2?
Yes, yes,
it
definitely.
should be a closed differential diagnosis.
Definitely.
So it's very difficult to conclude whether we are dealing with BSS or VWD.
Yes, sir.
So that's why, so how can we differentiate? This is, then we further proceed for the, after adding the von Willebrand factor, we get this kind of curve. So Dr. Bikram, please.
Basically, as we can see, this is a curve of conventional light transmission aggregometry. In light transmission aggregometry, ADP, collagen and epinephrine, they are platelet agonist. They cause platelet aggregation. But ristocetin is also a platelet agonist and it causes platelet agglutination. Ristocetin usually causes bonding between von Willebrand factor and platelet GP1B receptor. So in case of Bernard-Soulier syndrome, there is absence of GP1B9. So even with addition of von Willebrand factor, the platelet aggregation is not happening and there is no correction. But in case of von Willebrand factor, when we add ristocetin and subsequently von Willebrand factor to the PRP sample, we can see clearly there is correction of that abnormality and there is platelet aggregation curve is normalized. So the curve B after addition of von Willebrand factor, that is von Willebrand disease, and even after addition of this von Willebrand factor to ristocetin, there is no correction, as we can see in option A, that is a Bernard-Soulier syndrome, where the defect lies in the GP1B9 receptor itself.
Exactly. So this is a von Willebrand type 2 chart. I'm not going into the details, but what the Dr. Tribikram explained, superficially we conclude in this way. Now, the Dr. Tribikram already explained the Bernard-Soulier syndrome. I'm not going into the details. It's a giant platelet disorder, but this abnormality in platelet is usually glycoprotein deficiency of the glycoprotein 1B9, And how it is treated, it is usually either by platelet transfusion and recombinant factor 7A if the severe bleeding is there. I will come into later. Already explained this kind of platelet aggregation study. This is the typical curve we get in BSS, already explained in our earlier slides. Giant platelets, already we have seen this. Now coming to the case 2. This is a 15 years male presented in OPD with a bluish or blackish spot on and off over the skin, and the CBC and peripheral blood smear almost within normal limit, and the other PT-APTT coagulopathy tests were normal. So the question goes to Dr. Behra, please. What do you suggest? In which case we are dealing with?
Yeah.
Just DD, differential diagnosis.
Patient with the black coloration of the skin, no soft tissue bleeding, is think of either there is a decrease in platelet count or defective in platelet, or any skin blood vascular disease, but most common is either there is a decrease in platelet count or a defective in platelets. So when there is aggregometry, this is defective in aggregation. ADP, collagen and epinephrine is defective, ristocetin is normal. So the point goes to the 2B3A is the defective, and most commonly in the cases of Glanzmann thrombosthenia.
Exactly. If we get this kind of cases, we used to suggest further the platelet aggregation study.
Platelet aggregation study.
So the provisional diagnosis is most probably we are dealing with Glanzmann thrombosthenia.
Sir, actually I have a comment. So basically whatever picture we have, we are now observing in this particular platelet aggregometry study. Can we go there? Actually there is one other differential diagnosis also. So there is absence, one is afibrinogenemia. That is a close diagnosis of GT. Basically there is absence of platelet aggregation with ADP, collagen and epinephrine, and there is a presence of platelet aggregation with ristocetin. So thrombin time should also be
very important.
In this particular type of curve.
Exactly. So first step is coagulopathy screening, and then we proceed for platelet aggregation study.
Here I should just add one thing, that is, it is always said that this aggregometry, the standardization, although after 2014 onwards, we are seeing ISTH coming up with standardization protocols. So even after we have a diagnosis with aggregometry, we should go for a confirmatory test. We should go for a confirmatory test regarding the surface molecules, so that we are not again doing the same what the benefit we have while thinking about this inherited disorders, is that we don't overdiagnose or overtreat the patient.
Exactly.
So in that case also, here also, after aggregometry, because it is always there that it's the second line test definitely, but it's a screening test basically. So normal screen doesn't mean a normal hemostasis. At the same time, this whatever we are getting out of aggregometry, there are so many differentials, close differentials. As even in the peripheral blood of an afibrinogenemia patient, we won't be getting in a direct smear, we won't be getting any platelet clumps. In Glanzmann's thrombosthenia, the same thing is happening. So we can suspect the thing, but to confirm it, we should go for further tests. Then only we can stamp it as GT.
Exactly, sir. We are coming into that part later on. Okay, the Glanzmann thrombosthenia, we have already discussed it. What is this? This is the deficiency of the platelet glycoprotein 2B3A, and if bleeding is there, then we can give the platelet transfusion, or in severe cases recombinant factor 7A. Already discussed this one, the classification of Glanzmann thrombosthenia 1 and 2 and variant types. Most common is 75%. Type 1, this is found in 75% cases. And most common presentation in female is menorrhagia, and otherwise epistaxis and gum bleeding is there. This is the most common presentation in Glanzmann thrombosthenia. Pregnancy in Glanzmann thrombosthenia is a very critical part. That is the risk of bleeding at delivery also, and risk of the affected baby is there. and that will depend if there is a consanguinity. During pregnancy, the baby platelets, that is heterozygous, cross the placenta, and it causes antibody development in the mother's body, and finally this will cross the placental barrier and will finally destroy the baby's platelet. So mom with platelet alloantibodies will not respond to platelet transfusion, and antibodies cross the placenta, risk of bleeding in the baby also. So now coming to the case 3, this is a 20 years female with postpartum hemorrhage, and the CBC we got, the hemoglobin was 7 and total count was 12,000, neutrophil was around 60 to 70%, and platelet was adequate. And the few large platelet was also found, and the coagulopathy screening was almost normal. PT, APTT, TT all within normal limit. So the question goes to Dr. Khan, please.
Here we have a case where there's bleeding with a challenge, hemostatic challenge was there, and in that case we got this thing, and initially coagulation studies should be done because
already done almost within normal limit.
Those were
PT, APTT, TT all done within normal limit. So
exactly.
what do you suggest?
So in this case we should go for the second line of this thing, that is an LTA should be done. LTA should be done. And here in LTA we are getting that in the with ADP and first line collagen we are getting only the primary wave, and the secondary wave is missing in most of the cases. But in case of ristocetin we are getting the primary wave, and the secondary wave is also not there. So in this case we for the storage pool disorders we should be thinking of, because if we go by the algorithm, the 3 arms of the algorithm, the middle arm it deals with the storage pool diseases, both the alpha and the dense granules we need to consider here.
Exactly, Dr. Khan. This is the basic storage pool disease is a deficiency of dense granules or the alpha granules or both the granules. So we already know that the granules degranulate and finally releases the components of the granules, which helps in our hemostasis. Now the platelet storage pool disorder usually present with mild bleeding disorder, usually normal platelet count and morphology is variable. You may get normal or maybe the large platelets, and it can be isolated often due to FLI1 mutations, and often associated with disorders affecting the granules in other cells. And it is usually seen in syndromic, that is Hartmann-Pudlak syndrome, Chidiac-Higashi syndrome, Wiskott-Aldrich syndrome, associated with this kind of syndromes, the platelet storage pool disorder. And the platelets are usually small in Wiskott-Aldrich syndrome, we already know it, and the treatment is usually desmopressin, tranexamic acid or platelet transfusion according to the severity of the bleeding. This is a typical platelet storage pool disorder aggregation study, platelet, already explained by the Dr. Khan. Usually you don't get the secondary wave. Now Hartmannsky-Pudlak syndrome, it is the symptoms usually, how do you identify this kind of cases? Usually present with albinism, platelet dense granule deficiency, pulmonary fibrosis, granulomatous colitis, nystagmus. As we know, this is the syndrome. So other features is also there. Gray platelet syndrome, usually why this kind of name is there, because on examination of the peripheral blood smear you get the typical gray types of color, and if you do the platelet aggregation study you will be able to pick it up as a storage pool disorder, and it is usually due to NBELA2 mutations. Other platelet function defects is also there. These are usually mild and not always well defined. That's why we don't sometimes we are not able to pick it up as a platelet disorders, because many of people are suffering from this kind of mild disorders, and we used to get in our society also if we test it properly. And precise definitions only for a minority, and often mildly abnormal platelet aggregation is there. Mild abnormal, not the what we actually discussed earlier. Usually no treatment is required, and treatment if it is at all required due to bleeding disorders. Now coming to the platelet function test, what kind of platelet function test is there? Not only the only aggregometry or aggregation test is there for functional tests, different kinds of functional test is there. Dr. Bikram, just a name please.
So coming to the platelet function
Just
test,
name.
It can be platelet aggregation test with, as we have already shown, platelet light transmission aggregometry, then Lumi aggregometry, then platelet function analyzer, that is also one thing. Then we are using currently flow cytometric platelet surface CD markers analysis, that is also one thing. Then for rarer diseases, then we can see for electron microscopy. Then for release defect or storage pool defect, we can also have some release assays and
Exactly.
all these things.
And Dr. Khan, you already told that for further tests, this is actually the further test we require to confirm the cases. The other functions.
In this particular case, that is case 3, we should go just after LTA, we should go for Lumi aggregometry, because that is a better test to define this storage pool disorders.
Now coming to some screening test, that is bleeding time. We should do or not, Dr. Behera, please?
The
Because
bleeding time nowadays,
many times we don't do the bleeding time usually.
Because the procedure is technically very, what we usually do a thumb prick and do the bleeding time. This is not the actual procedure. The procedure is a proper procedure, what is shown in the picture, and it's difficult, it's need a proper technician and proper training to do a bleeding time. That's why you should have a cuff of 40 my hemoglobin of 40 millimeter mercury, and they will have a proper lancet of depth of 2 millimeter, breadth of 3 millimeter, all these things, and thin skin thickness has to be proper. So that's why nowadays nobody is doing. Also, this is a platelet function screen. Some years back, this came as one of the game changer that we can do the platelet function test by the PFA assay, PFA screening. But nowadays, hardly people are doing in this way. Some emergency or the cardiothoracic unit, they are doing this. Otherwise, nobody is doing this. Then came the what is called as platelet function assay or screening test. What is
Here we have a very good chart. How can you differentiate with the help of PFA? The two types of agents they have used, the API and ADP. This is a very good chart. You can differentiate the other congenital inherited disorders.
Yes. Aspirin induced.
Exactly,
this is in the emergency procedure they used to do nowadays. Not as a regular diagnostic test. I don't think that.
Now, because the time is shortest, we are going into the advances of the flow cytometry. Dr. Khan, please, do you want to highlight the flow cytometry?
Yes,
role
actually,
in the platelet disorders, functional disorders.
Functional disorders. See, whatever we are having, the gamut of this hereditary platelet disorders, it usually affects either the surface molecules or the cytoskeletal molecules, proteins. At the same time, the storage, that is the granules, that can be a problem, or the biochemical mechanism of the platelet can be at fault. So in flow cytometry, for this surface molecules as well as the cytoskeletal proteins, that is a very nice method. But at the same time, fluorescence methods, if it can be used with flow cytometry or even on the peripheral smear, that is also an alternative, and it can diagnose most of the cases. Even in case of functional disorders like the signal transduction mechanism, when it is at fault, there are also certain molecules like CD63 and all, which can give an idea that there is activation proper and the signal transduction mechanism is working or not. So flow cytometry is definitely a good method, but at the same time, what I would suggest at this point of time, that there are more than almost 75 genes and 60 entities we have got, and it can have this in different literatures it is published that it can have a prevalence of 3 in 1000, where it is reported, right, 1 in 10 to the power 4 to 6 cases right now. But 3 in 1,000 we should think of, as you were telling, that it can be a very common disorder. So in that case, if every other things permit, we should go for a molecular diagnosis to clinch the diagnosis.
Exactly. Here, just to highlight, the Brauner BSS Glanzmann, with the help of flow cytometry, we can diagnose what thing is deficient. Here, the
advantage of
these last two pictures, the bottom line pictures are showing that what kind of GP protein is deficient, and here the above panel showing what kind of expressions after the ADP stimulation. So here we can see the deficiency part, and how much deficiency we can also measure that one. So
and
next
also
thing,
you can quantitate the markers.
Quantitatively,
yes,
exactly.
You can quantitate, and it requires little amount of blood. Little amount of, even thrombocytopenia patients can have in the flow cytometer.
Exactly.
Whereas
and further we can
to
confirm it with the gene mutation. We have already seen the gene is there. We can identify that gene part.
And if we compare these two, agrigometry and flow cytometry or the other methodologies, in that case, as sir said, that small amount of blood is needed, so we can even send the sample to a higher facility to get up.
One more advantage of flow cytometry is that even in patients of thrombocytopenia, because for platelet agrigometry, the minimum platelet count should be at least 2 to 4,000. So, in case of thrombocytopenia, we can go for flow cytometry also.
Exactly. The platelet agrigometry disadvantage is if the platelet count is too low, we cannot perform that one.
And also,
but with the help of flow cytometry, even in a thrombocytopenia, if it is below 50,000, we can perform it.
And also, if a transfused patient also, platelet transfusion, it differentiates between the abnormal and normal platelet also.
Exactly. Dr. Bikram, can you please explain the last one? This is MH19 thrombocytopenia disorder. What is this?
So, this is a case, this is a entity of hereditary thrombocytopenia with giant platelets. Basically, MYH9 is a gene
Dr. Shah, we have already crossed the time.
Myosin. So, it encodes all these three syndromes, so Meiglin anomaly, Fechner and Epstein syndromes. So, there is, as we can see, speckled pattern. In case of MYH9, speckled pattern of loss of non-muscle myosin, 2A myosin component with neutrophilic inclusions and giant platelets. So, basically, in all these cases, there is syndromes of early renal affection and sensory neural hearing loss, young cataracts with macrothrombocytosis and bleeding predisposition. All these factors they occur. So
now thank you, Dr. Vikram. Now coming to the last part, that is treatment. Usually we treat it with the, already we have discussed with the individual cases, but the message is we can also use the TPO agonists like romiplastin and L-thrombopag in this kind of inherited disorders in thrombocytopenia cases. This is very effective treatment. The study shows that even 50 and 75 both can be used with a successful result. And there should be a preventive measures to lifestyle modification. These things is required. I'm not going to the details of each and individual entity of the treatment modalities, but we can use the tranexamic acid and desmopressin also in these cases. So, in a summary, we can tell that what should be the algorithm. If we get the bleeding history, we should first do the screening test like platelet peripheral blood smear, then the coagulation parameter should be screened, then we further proceed for the platelet agrigometry, and further to confirm the flow cytometry and the latest mutation study we can perform. So these are the nutshell of the platelet inherited disorders. This is really very difficult to cover all these things in a very short time, but that's all in a short time, in a nutshell. Thank you.
Thank you, Dr. Shah. Actually, this topic is so big, and within this very short time, it is really very tough. In fact, I was trying to tell Dr. Khan that qualitative platelet disorders, inherited platelet disorders, they take always some time. But in the meantime, under your guidance and moderation and all the other Dr. Kullan Khan, Dr. Shamir Behera and Dr. Trivikram Panda, they have nicely explained many of the things, and the usage of that flow cytometer. In fact, now this is being used in several, in virtually, I have read one article that flow cytometer is coming to replace even mutation study. Sometimes they are trying in that way. So thank you very much. I think as because already we have crossed the time, so question hours can be.
I would like to do a final comment. Basically, in an Indian setting, as far as this inherited platelet defect is concerned, we should go for a, whenever there is any opportunity, we should go for a targeted gene panel sequencing to look for the proper to clinch the proper diagnosis, because it helps in prenatal diagnosis, it helps in diagnosing the myeloid neoplasms with germline predisposition like ETB, RUNX1, ANKRD26, all these features. Then other inherited bone marrow failure syndromes with extra hematological manifestations like hepatic involvements, pulmonary fibrosis, that can also present like these features of inherited platelet defect and bleeding in families with family history. Then in any case of a young patient with bleeding with or without thrombocytopenia, with family history of either thrombocytopenia, leukemia or myelodysplasia, in all these cases we should go for a targeted panel so that we can clinch the diagnosis.
Absolutely, absolutely.
At the same time, what I should just 1 second, sir. That is, we should keep in mind the ethical issues also. Because of the fact that RUNX1 or ETV6, there is a possibility of this malignant diseases in 10 to 40% cases. So that might lead to psychological morbidity also. So we should keep in mind, at the same time, the cost-benefit ratio that should be worked out at the same time. Thank you.
And of course, this point of care test, in particularly this type of disorders, till date, which is not very much, we are not getting. That is also another point we are facing. Anyway, thank you very much. So we can now conclude this session?
Yes, sure, sir.
No question,
Thank
please.
You.
Thank you very much, sir, for sharing your deep knowledge. Now the lunch break. Now it's the time for the lunch break. I would like to request all of you to move towards the lunch. Is waiting for you at outside. We will resume after here. We will resume here after 40 minutes. Before we have a poster assessment walk at gallery, I request all the guests kindly enjoy our assessments. And two, I request all our poster participants to be ready for the poster assessments, and for this, judges are Dr. Jashmita Dash and Dr. Abhijit Fukan. Thank you.
Hello. Hello.
Sir, I can't see the slide.
Good afternoon, Dr. Ankita. Are you able to see your slides? Dr. Ankita? Am I audible to you?
Yes, ma'am.
Okay, so can you see your slides?
Yes, ma'am.
So you have 5 minutes to present the poster. Please start.
Good afternoon, everyone. I am Dr. Ankita Singh. I am going to present my poster presentation on the topic histopathological evaluation of endometrial lesions with AUB in Tertiary Care Center, Sitapur. AUB is considered as the most common and challenging problems presenting to the gynecologist. Heavy bleeding may affect the woman's health both medically and socially, causing problems such as iron deficiency in the developed world and chronic illness in the developing world. I can't read it now. Okay. Next slide, please. Postmenopausal bleeding is the danger sign for malignancy. Aim of my study is to find out the common histopathological diagnosis for endometrial samples and to categorize in relation to the age and the histopathological pattern seen. Histopathological examination of endometrial biopsy is the gold standard diagnostic tool in evaluation of AUB. Next slide. Now the methods, inclusion criteria, it includes patient more than 18 years of age, samples from the endometrial curettage, biopsy hysterectomy. Exclusion criteria, it excludes the patient with bleeding due to cervical pathology, authorized specimen in situ or intrauterine contraceptive devices. Next slide. The results, I studied a case 70 patients, and the most common pattern, which was normal cyclical endometrium, proliferative and secretory, 65%. The other patterns are as follows. Next slide, please. Now, this is the distribution of cases according to the age. The most common age group that was in my study was the perimenopausal age group, that is 41 to 50 years of age. Next slide. The distribution according to the histological patterns are as follows. The proliferative and the secretory were the most in the 65%. The rest were 28, 6, disordered proliferative endometrium 4%. Next slide. Now this is the first figure is the H&E stain section shows of the disordered proliferative endometrium. It shows the endometrial glands and stroma. Some of the endometrial glands are cystically dilated, and then it also shows the abundant hemorrhage. The dilated glands are irregular. The next figure is the proliferative with chronic endometritis. Proliferative with chronic endometritis. The H&E same section shows the endometrial glands round to tubular and a compact stroma. The next slide, the next is the endometrial adenocarcinoma. Each H&E stain section shows the viloglandular structure of the endometrial glands and very little intervening stroma. So the conclusion of my study was a histopathological evaluation of endometrial biopsies and curettage revealed various patterns ranging from physiological to pathological reasons of the endometrium, especially in the perimenopausal and postmenopausal age group, to rule out the possibility of any pre-neoplastic conditions or malignancy. There was an age-specific association of endometrial lesions, hence it helps in correctly managing the cases. Thank you, ma'am.
Thank you, Dr. Ankita. So, in your series, I saw that endometrial hyperplasia was seen in 10% of the patients and carcinoma was seen in about 2 patients. So, did you correlate the age group of the patients with the lesions seen? Because
yes, ma'am. Most commonly, endometrial carcinoma. It is mostly seen in the elderly women above 60 to 50, 70 years of age.
That is the
And
general
endometrial
norm.
hyperplasia.
Have you noticed in your series what was the age group in which you saw endometrial hyperplasia or endometrial carcinoma?
Yes, ma'am.
Ankita, it's a question. So what was the age association in your series? So you told us that you had patients starting 21 to around over 50 years of age. But what was the association of endometrial carcinoma and endometrial hyperplasia with age? Okay, so you had patients of chronic endometritis also?
Yes, ma'am.
So what is the feature that tells you that you are dealing with chronic endometritis?
Mostly, we see the plasma cells in the chronic endometritis.
Good. So the presence of plasma cells becomes very important to screen for in endometrial biopsies.
Yes.
Okay, so this was your thesis work or an add-on paper?
Ma'am, thesis work.
Thesis work. So you've taken patients starting October to January of which year?
No, ma'am. Actually, I have by mistake I have done October, but it was a 1-year study.
Okay, it was a 1-year study. Okay.
And I have also in my thesis work I have also included ISC, but because my slides were not ready for ISC, that's why I am not added this.
Okay, thank you. Thank you, Dr. Ankita.
Thank you, ma'am. Thank you, ma'am.
Hi, Dr. Rumika.
Good afternoon, ma'am.
Okay. So you're all set to
Ma'am,
present?
slides are not visible.
It's okay, relax. Till the time they are visible. It will take some time for the slides to be shown. Dr. Rumika, can you put your mobile on the horizontal mode?
Yes, yes, ma'am.
Okay. Thank you. Are you able to see your slides now?
Yes, ma'am.
Okay. So please start, Dr. Rumika.
Yes, ma'am. Good afternoon, everyone. Myself, Dr. Mika. I am here to present my poster on topic role of fine needle aspiration pathology in assessment of head and neck lesions, a study at tertiary care centers. Next slide. FNF is a very simple, quick, inexpensive, and minimally invasive technique used to diagnose different types of swelling like lymph nodes, thyroid, soft tissue, and salivary glands in head and neck regions. Swelling in the head and neck may be due to various causes. These swelling can be divided into midline and lateral neck swelling and are frequently encountered in general practice. It may be inflammatory, reactive, cystic, and malignant lesions. In this study, we included 200 cases of head and neck swelling performed predominantly either as outdoor procedure or as pre-operative assessment in our institute during January 2021 to December 2021. Diagnosis was correlated with clinical findings and investigations. Patients aged between 1 and 80 years were included in this study. The area to be aspirated was clean and material was aspirated, and aspirated material was smeared on clean glass slides. Later smear was stained by ginseng, pap stain, and other stains as and when required. In this study, we total include the 200 cases, aged ranged from 1 to 80 years, in which 34% were male and 66% were female. Maximum incidence observed in the age group of 16 to 30 years. Among the diagnostic outcome, higher incidence of lesions is in the neck region, which is accounting for 139 cases, then in the head region, in which 42.5% were associated with lymph node lesions. In soft tissues, basal cell carcinoma was the only malignant lesions we found. The lesions from soft tissue, scalp and nape of neck, epidermal intrusion cyst was the commonest finding, while from the lips and oral cavity, lipoma were the common findings. Next slide. This is the table in which we age-wise distribution of cases will be seen. In this, the maximum cases were seen in the age group of 16 to 30 years, which is accounting for 38% cases. Table 2 shows the sex-wise distribution, in which the 66% were female and 34% were male. Next slide. This is a table showing the distribution of cases according to the region of head and neck. In there, the lymph nodes were the commonest swellings we found in a hospital, which accounted for 42.5% cases, followed by thyroid gland swelling, which accounts for 27% of cases. Next slide. Distribution of cases on the basis of organ and lesions. In lymph node, the most common swelling we found are the granulomatous lesions, which account for 15.5% cases, and followed by the reactive lymph nodes, which accounts for 13% cases. In thyroid swelling, we found the most common cases is the simple colored goiter, which accounts for 12.5% cases. Next slide. In salivary gland, most commonly lesion is the stellidinitis and pleomorphic adenoma. And nape of neck and soft tissue swelling, the most common finding is the epidermal intrusion cyst, and in the lips and oral cavity, most common finding is the lipoma and inflammatory lesions. Next slide. This is the pictures. First figure shows the epiphyllary granuloma. Second picture shows the sheets of SNR cells on a fibromyxostroma, that is the pleomorphic adenoma. Third picture shows the adenoid cystic carcinoma, which consists of the hyaline globule, as shown in the picture. Figure 3 shows the oncocytic carcinoma, and figure 5 shows the ethnic cell carcinoma, and figure 6 shows the papillary cell carcinoma of the thyroid, papillary thyroid carcinoma. Next slide. In the present study, 200 cases of various head and neck swellings are included. Granulomatous lymphadenitis was found to be the most common pathology, accounting for 15.5% of the cases, followed by reactive lymphadenitis, found in 13% cases. Out of 200 cases, 42.5% were of lymph nodes. Tissue in present study, also commonest site of malignancy in head and neck region. Squamous cell carcinoma is one of the commonest tumors in the head and neck region. It presents laden with nodal metastasis, and metastatic squamous cell carcinoma is the earliest diagnosis on FNAC. The primary sites are lip, tongue, oral cavity, tonsil, and larynx. Among other lesions, thyroid and soft tissue, scalp, and nape of neck lesions were 27% and 9.5%, while lesions from salivary glands from lips and oral cavity were 12.5% and 8.5% respectively. Our study found that FNAC is simple, quick, inexpensive, and minimally invasive technique to diagnose different types of head and neck swelling. It could differentiate the infective and benign process from neoplastic lesions and avoid unnecessary surgery. Thank you.
So, Dr. Umika, how does your data compare with the rest of the world of series reported on head and neck swelling FNACs?
सर मैम एक्चुअली मैंने डेटा इसको कंपेयर किया था दूसरी स्टडी से, बट पोस्टर में शो नहीं कर सकते थे.
So the next time in your poster,
मैंने इसको शो नहीं.
So Dr. Umika, next time in your poster, in your discussion, you're repeating results. So instead of repeating results, concentrate on the actual discussion part. That is one. The other thing is, in how many cases did you have a corresponding histopathology available? So in your 200 cases, there would have been some patients who at least underwent surgeries for your thyroid lesions, for example, or cancers that you reported.
No, ma'am. Actually, we have only FNAC, and we could not receive the histopathology specimens for these cases.
So definitely not for all of 200, but try and see if you have histopathology available even for 40 or 50 of these lesions. Okay?
Okay.
So, for example, a reactive lymph node, tubercular lymphadenitis, nobody would do a biopsy for, but pleomorphic adenoma or papillary thyroid carcinoma, in those cases you may have corresponding surgical specimens available.
Okay. But we have not, ma'am, only we have basal cell carcinoma specimen for biopsy we received.
Okay.
But other than, we could not receive the other specimen.
Okay. Thank you.
Thank you.
এখন তো লাগবে না
Welcome back, everybody. Now we are move forward with our third session. Topic: lymphoproliferate disorder, based on the theme of bright future with timely therapy. For this, I would like to request on stage our first chairperson, Dr. Moshumi Nondi. Welcome, ma'am. And our second chairperson, Dr. Ashim Mollik. From Dr. Moshumi Nondi, she is the professor and head department of pediatric medicine, Medical College, Kolkata. And Dr. Ashim Mollik, professor and department of pediatric medicine, NRS Medical College, Kolkata. Now I would like to request our first chairperson to introduce our speakers.
Good afternoon. So this is the post-lunch session, the third session. I would like to thank the organizing committee for giving me the scope to be the chairperson in this lymphoproliferative disorder. We have today our first speaker, Dr. Ashutosh Panigrahi. He will speak on pediatric Hodgkin's disease and how does it differ from adults. There is a lot of recent advances in the management of pediatric cases with lymphoproliferative disorders, leukemia, lymphomas. We need a multidisciplinary approach, and there are also specialists in this subject, and pediatric oncologists have also developed. Also in the investigations, diagnostic specialties are needed, hematopathologists, molecular pathologists. So now it is over to Dr. Ashutosh Panigrahi, who will speak on Hodgkin's disease and how does it differ from adults in children. And children are not just miniature adults. The treatment, the response to treatment, all this differ. So it is over to him.
Thank you, madam. Thank you for this introduction. First of all, I will thank to the organizing committee for giving me this opportunity, and the topic is also a good one. How Hodgkin's lymphoma differs from adults. Is it actually the pediatric or incorporated into adult, or adult incorporated into pediatric? Now coming to the epidemiological difference, lymphoma is the third most common cancer in children. Most common cancer in adolescent is the Hodgkin's lymphoma. Hodgkin's lymphoma accounts for 6% of childhood cancer, where it is 1% for adult malignancies. Incidence varies with age, sex and race. We all know that there is a bimodal distribution of Hodgkin's lymphoma with an initial peak at adolescent and childhood group, and another is late adulthood. There is a female predisposition predominance in adolescents and young children, but it do not occur in adults. There is a male predominance, and as the age increases, the incidence also goes on increasing. Three things are important in pediatric Hodgkin's lymphoma that can be differentiated from adults. One is infectious agent, that is most commonly is EBV, familial predisposition and association with autoimmune conditions like autoimmune lymphoproliferative disorders, ataxia telangiectasia, chromosomal breakage and post-transplant conditions. So immune dysfunction association. Pathologically, Hodgkin's lymphoma for both adults and pediatric we classify as nodular lymphocyte predominant Hodgkin's lymphoma and classical Hodgkin's lymphoma. The incidence variation in both adult and pediatric are similar, though the different classifications of Hodgkin's lymphoma varies between adult and pediatric. So there is also biological difference between adult and pediatric. That's why probably the most common variant is in pediatric is a mixed cellularity type. What are the biological variations? That is the tumor microenvironment, the cytokine milieu of the tumor, and the exomes and the viral predispositions. These are the target of research. Till now there is no therapeutic implications for this. Probably in near future these will be the therapeutic targets. Something about EBV and Hodgkin's lymphoma, it occurs in 30 to 50% of cases. Mixed cellularity is the most common histological variant associated with EBV. Patients typically are less than 10 years or more than 45 years old. Prognosis is conflicting data. Someone tells that it is associated with bad prognosis, some tell it is inconclusive. Anyhow, the nature of the disease is associated with some adverse outcome. Coming to clinical manifestations between adult and children, in general, the presentation is lymphadenopathy, mediastinal mass, systemic complaints, and paraneoplastic syndromes. In children, cervical and supraclavicular lymphadenopathy is the commonest manifestations. Infradiaphragmatic isolated lymphadenopathy is very rare in children. If at all we are facing these unusual findings, we should think of again. In adolescents and adults, mediastinal mass is more common. There are common manifestation. In 70% cases, mediastinal mass occurs. Less than 10 years, in 35% cases, it is associated with bulky disease or superior mediastinal syndrome. Symptoms are similar in adults. Non-specific symptoms like fatigue and anorexia are same for both the groups, but B symptoms is relatively more prominent in adults in comparison to the pediatrics. Pleural effusion, pericardial effusion, and pulmonary involvement, if at all present in either children or adult, is associated with bad prognosis. Liver, spleen, and bone marrow involvement occurs both in adult and pediatric Hodgkin's lymphoma in adult stage. Paraneoplastic and other manifestations, if at all present with Hodgkin's lymphoma, is more common in adults. These are dermatologic syndromes, nephrotic syndrome, polyarthritis, dermatomyositis, idiopathic cholestasis, autoimmune hemolytic anemia, cerebellar degenerations, and hypercalcemia and other endocrine syndromes. If at all it is present, these are more common in adult. So in summary, pediatric Hodgkin's lymphoma, commonest age is 0 to 14 years, prevalence is 6 million per year, male predominance, mixed cellularity is the commonest manifestation, commonly present as stage 2 disease, painless adenopathy involving the cervical area is the most common manifestation, 80% cases associated with Hodgkin's EBV infection, and is the best outcome with treatment in comparison to adults. Now coming to the diagnosis, probably there is no much difference in diagnosis part of adult and pediatric age group, but one pre-assessment importance is baseline pivotal status assessment. So other parameters that we evaluate is same as for the adult population. Investigation baseline is same. One thing, many a times we face that in children will not go ahead with extensive surgical excision for biopsy, but if at all possible, that has to be done for proper diagnosis of the disease. If it is not possible, then a guided true cut biopsy can be an alternative, but not FNAC. Other pre-therapy considerations that is associated with some implication in children is a bone scan. If at all it is associated with severe bone pain, elevated ALP, then probably we may go ahead with a bone scan, otherwise it is not recommended. But for all adult and pediatric, we need a pulmonary function test, cardiac function test, thyroid function test, and fertility preservation assessment before going to treatment. Now coming to the prognostic scores, how it is important in adult and children. These are the different studies that have taken different parameters into consideration for pediatric prognostic risk stratification. But there is no consensus which one need to be followed. This is the COG group study in 2017 that has developed four parameters that is important in prognostication, that is stage of the disease, mediastinal mass either as a diameter or as a volume. Diameter is taken into consideration in COG group, volume in Euronet group. So they tell that these parameters are mostly associated with a adverse outcome. So coming to the most important part of our assessment is FDG PET. Now it is a standard, whether it is an adult or a pediatric. The standard staging system starts with a FDG PET CT scan. When FDG PET CT scan is not available, we can go ahead with a CT scan because it can delineate the extent of involvement very good, and it also negates the need for bone marrow transplant. It is a good paper that is telling that if at all your bone marrow involvement is reported by a PET CT scan, you may not need to go ahead with a bone marrow aspiration. But one thing is important in children, that is there are some physiological FDG uptake in some tissues. In that condition, you have to compare with the surrounding tissue and compare with the baseline to interpret the result. So this is one important difference. If at all CCT you are doing, it is also a good alternative, but one important issue in pediatric patient is that it is associated with radiation exposure. So whenever you are planning a CCT, please consider that whatever and how frequently you are going to do, and do it very judiciously. Staging workup is done by same Ann Arbor staging classification that we do, that take into consideration the supradiaphragmatic and infradiaphragmatic lymph node involvement and extranodal involvement, and we also tell A, B and E that is known to all, and it is same for adult and children. One thing important in pediatric is the definition of bulky disease in Hodgkin's lymphoma. In COG, it tells that the maximum diameter of more than 6 centimeter, or if the internal diameter of the mass is more than 1/3 of the intrathoracic diameter, then probably it is a bulky disease. But Euronet tells that the volume of the lesion should be more than 200 ml. Lugano recommends more than 10 centimeter, and it is mostly associated, it is applicable for adults, not for children. So based on this PET CT and all these criteria, these are the groups which classify or stratify the Hodgkin's lymphoma group into 3 risk groups. One is low, intermediate and high. What are the parameters they have taken? Extranodal involvement, bulky disease and risk factor, that is ESR more than 30 millimeter per hour, and age of the patient. So taking into consideration, these are the different classifications, that is low, intermediate and high. So we follow Euronet or COG protocol for our risk stratification and subsequent treatment. Now treatment has been well established that for these 3 groups there are different protocols followed. Both are PET driven. So Hodgkin's lymphoma is considered most curable neoplastic disease, 90% overall survival rate. In adults, ABBD and BACOF are the frequently combination chemotherapies that are used, but it is not applicable for children. Prognostic factors and indices for both adult and pediatrics are different, that are available in NCCN guideline and German guideline, and other guidelines are there for adults. And in pediatric, I am going to discuss something about these factors. So issues with pediatric Hodgkin's lymphoma are cardiotoxicity associated with anthracyclines, pulmonary toxicity associated with bleomycin and radiation, gonadal toxicity, and secondary malignancy with alkylators and radiation. So now in outside India, most of the centers are going away from ABBD for pediatric Hodgkin's lymphoma management. The management is now risk adapted and response based treatment. Though several risk factor associated treatment strategies are available, but in general practice, patient preference, disease characteristic, geography, treatment center and physician's expertise make a difference in selecting what treatment is required for a pediatric Hodgkin's lymphoma patient. So how treatment has evolved? Only radiotherapy was the initial treatment for Hodgkin's lymphoma. Later combination chemotherapy came in 60s and 70s. Then in 70s, clinical trials were started to evaluate the drug treatment. Next came the ABBD type of treatment, where it was found that there is prolonged toxicity or late toxicity with procarbazine, radiation, etc. That's why people try to replace procarbazine with etoposide and doxorubicin. Now reduce the dose of treatment, now reduce the field of radiation. Now we are targeting towards a concept of using early response to tailor therapy based on the PET CT. So this is the evolution. Now we are here. Now what is the philosophy behind pediatric lymphoma treatment? There is no, one thing you should know, that there is no standard treatment protocol for pediatric Hodgkin's lymphoma. It varies from center to center. What are the factors that take into consideration while treating Hodgkin's lymphoma? Restratification, response to initial chemotherapy, age, associated comorbidity, stage of the disease, and treating center. Goal is to minimize the treatment related short-term and long-term toxicity without compromising the cure. So these are the different groups that are studying. In India, we have pediatric hemato-oncology group. In POG is now working on early stage Hodgkin's lymphoma, relapsed refractory Hodgkin's lymphoma, and the different statistics related to that. Sorry. They classify early stage, that is stage 1 and 2A disease, where 2 to 4 cycles of ABVD are given and radiation to the bulky disease. Advanced stage is stage 3B to 4, where 4 to 6 cycles of ABVD followed by RT. So in summary, low risk disease are treated by these type of chemotherapy regimens like VAMP, COPP, ABVE, this type of regimen. Intermediate risk is treated with 6 cycles of COPP, ABV plus low dose radiation, involved field or involved node radiation, ABVE PC, and 2 cycles of COPPA. And there is also a variation in male and female children because procarbazine is gonadotoxic. So that also makes a variation. So these are the different regimens for high risk disease. But when we search the literature in what is happening in India, the median age is around 9 years, male-female ratio 4.4:1. Majority has stage 2B3 disease at presentation. Most common histologic type is mixed cellularity in children. PET-CT was not used in any of the centers, and most of the centers I mean. Treatment consists of chemotherapy and radiotherapy with considerable variations, and in around 75% cases ABVD is used as the treatment plan. Review of literature from India suggests that multi-agent chemotherapy without radiotherapy may be sufficient. This is one important thing I came to know, that in selected cases only we have to use radiation. Radiotherapy may be reserved for patients with bulky disease only. In India, the management of Hodgkin's lymphoma will be influenced by the availability of the PET-CT and radiotherapy facility because it increases the cost of the treatment. Therefore, most of the centers PET-driven treatment is not possible or feasible. These are the different trials that has been conducted in India with a good outcome. Based on this, ICMR in 2017 has recommended that whatever treatment protocol you are using, adhere to that protocol, don't mix with it. After 2 to 3 cycles, assess either by PET-CT or CT. If there is good response, then it is good. Otherwise, all other subsequent results are taken as poor responders and they need aggressive treatment like HSCT or salvage chemotherapy. Management of relapsed refractory Hodgkin's lymphoma basically are adult protocol based treatment in children. Means adult data has been extrapolated to management in pediatric age group. That's why there is not much difference because of high cure rate. We are not going to in detail to the discussion of relapsed refractory. Newer agents that has been tried in Hodgkin's lymphoma in children are same as those tried in adults also. So one most important part is here is the less complications associated with Hodgkin's lymphoma treatment. This is a 24-year data, 25-year follow-up data that is associated with thyroid dysfunction, gonadal dysfunction, cardiopulmonary toxicity, secondary malignancies. And cardiotoxicity and secondary malignancies are the predominant cause of death in Hodgkin's lymphoma patients. Something about NLPHL, it is an indolent disease, early stage at presentation, excellent prognosis. If at all it relapses usually very late. Overall survival with minimal treatment is about around 95%, though in 5% cases there occurs a transformation to a high-grade lymphoma. In adults, there are 3 modalities of treatment: surgery alone, radiation therapy alone, or combined modalities of treatment. But high dose of radiation is usually avoided in children. So what is there for NLPHL in children? COG group has done a study that only surgery in 1A disease is sufficient, no need to do a residual radiation following surgery or any chemotherapy after surgery. That's why only surgery will give around 79% EFS and 100% OS in early stage disease. 2 chemotherapy regimens that are helpful in advanced stage disease of NLPHL in children, but it is not applicable in adults because now the recent guideline tells that for all NLPHL in adults, the best regimen will be a R-CHOP or R-CHOP-like regimen. but that is not applicable for children. So what is data showing? That CVP is a good option for treatment of early stage disease. In advanced stage disease, AVPC can be considered, followed by only 21 gray radiation to the residual disease. That will give a 83% overall survival, event-free survival, and 100% overall survival. That means with minimal chemotherapy, we can salvage many NLPHL pediatric patients. So coming to the summary of my talk, Hodgkin's lymphoma is relatively more common in children compared to adults. Nodular sclerosis subtype is significantly more common in pediatric age group. In adult age group in comparison to pediatric, less than 10 years, mixed cellularity is the common variant. Systemic symptoms were reported in 48% of adults, but in 39% of children. EBV association is common in pediatric Hodgkin's lymphoma. Primary immunodeficiency should be considered while dealing with pediatric Hodgkin's lymphoma. Hodgkin's lymphoma presenting as isolated subdiaphragmatic disease is rare in children, so that interpretation should be very judicious. PET-CT is the standard mode of investigation for staging and response assessment. Risk stratification is not standardized till now, but still whatever risk stratification is available, based on that we are doing risk adapted and response based treatment, and treatment varies from the center to center. Children and adolescents had a good prognosis with around 96% 5-year survival. Key issues associated with pediatric Hodgkin's lymphoma treatment are use of radiation, use of drugs like anthracycline, procarbazine and bleomycin, development of secondary malignancies, and late effect on growth, development and fertility. Thank you for your patient hearing.
Thank you for your excellent speech, Dr. Ashutosh Panigrahi. Any questions?
Yes, sir.
So we can move to the second one. Oh yes, one question.
So what is the role of the antibody to CD30 in the treatment of the Hodgkin's lymphoma in pediatric age group?
So it is now reserved for two settings. Brentuximab vedotin is being used in pediatric Hodgkin's lymphoma. One is high risk disease not responding adequately before transplant as salvage therapy, number one. Number two is as a maintenance, that is the COG is now taking a phase 2 trial post transplant, refractory for 2 lines of treatment, autologous transplant, then brentuximab vedotin maintenance. So these are the two places where now it is incorporated in the standard of care. In high risk disease not responding to standard of therapy, and multi-refractory Hodgkin's lymphoma post transplant maintenance.
So if there isn't any question, we will move to the second one. Thank you.
Thank you, madam. Thank you.
Okay, thank you. Then our next speaker is Dr. Souma Bhattacharya. She is a senior consultant hematologist. And the interesting topic Dr. Souma Bhattacharya discussed, that the follicular lymphoma and what is the recent advance in management protocol. Okay, over to Dr. Souma.
Thank you for inviting me to speak at this venue, and I thank the organizers and the person sitting on the dais. Our topic today is treatment of follicular lymphoma, what is new. So what is follicular lymphoma? Follicular lymphoma is the second most common form of NHL in United States and Western Europe. There are estimated 13,960 new diagnoses in the United States in 2016. It's a disease of the elderly. Median age at diagnosis is about 63 years. And despite most patients presenting with asymptomatic lymphadenopathy, majority is diagnosed with disseminated disease. And there's a small risk of follicular lymphoma transforming into an aggressive lymphoma like DLBCL. And if we look by stage, it's fairly evenly distributed. Stage 1, about 25% of patients. Stage 2, about 15%. Stage 3, 26%. Stage 4, 27%. And the 5-year relative survival by stage is pretty good. How do you prognosticate a newly diagnosed follicular lymphoma? The FLIPI score has been there for a long time. It basically deals with 5 risk factors: nodal sites more than 4, stage 3 or 4, LDH more than the upper limit of normal, hemoglobin less than 12, and age more than 60 years. And depending on that, you can have a low risk with a score of 0 to 1, intermediate with a score of 2, high at 3 to 5. And it has been shown that with FLIPI score, the curves do separate of survival probability between low, intermediate, and high. And subsequently, there has been further refinements of this score. FLIPI 2 has been developed, and then there is this M7 FLIPI. So what these scores incorporate is the mutations. So apart from the FLIPI score and the ECOG performance status, we are also looking at different gene mutations which can show whether the follicular lymphoma is low risk or high risk. And when do these follicular lymphoma patients need treatment? People generally go by either 2 criteria. One is the JELF criteria and the other is the BNLI criteria. In JELF criteria, the high tumor bulk is defined by tumor more than 7 centimeter in size, 3 nodes in 3 distinct areas, each more than 3 centimeter, symptomatic splenic enlargement, organ compression, and ascitic or pleural effusion, systemic symptoms, and serum LDH or beta 2 microglobulin above the normal values. And then again, there are the BNLI criteria as well. So, on to treatment. Whenever we are treating follicular lymphoma, we first try to see what stage it is and what tumor burden it is, and that is usually, that information is given to us by PET-CT. So for advanced stage low tumor burden follicular lymphoma, what are the options? So, and we come to the celebrated paper by Kirit Ardeshna in Lancet Oncology back in 2014, where he said that instead of the traditional wait and watch, let's give rituximab, single agent rituximab. And what was the upshot? Ardeshna showed that the time to next treatment, the curves are separating. So those who are getting single agent rituximab are having longer time to relapse, and progression free survival is also better. But he couldn't show any improvement in overall survival. So for patients with follicular lymphoma who are advanced stage low tumor, if you give if you treat it with single agent rituximab, or if you are just waiting and watching, overall survival doesn't really change. And on the same principle, the RESORT trial was designed, where a single agent rituximab was given for 4 injections, and then that was followed by maintenance and versus retreatment. And what was found was that the curves didn't separate whether you were giving maintenance or retreatment. The results were the same. And these trials, which were in mid-20s, about 6-7 years later, there has been some updates. In ASH 2021, what they showed after median follow-up about 8.7 years is that at 7 years, 83% of maintenance rituximab and 63% who received rituximab on relapse were free from chemotherapy. And at 10 years, 66% of the maintenance rituximab and 30% of RR were still in first remission. But importantly, at 10 years there was no difference in overall survival, 84% versus 83%. There was a trend towards lower histologic transformation with the maintenance rituximab arm, and some data is still to be presented. So, what should be the approach to a low tumor burden advanced stage follicular lymphoma? Wait and watch therapy is still acceptable and encouraged, often at least for some time, to allow patients to understand the disease biology and to get a sense of disease space over time. If the patient desires therapy or has got minimal symptoms, then rituximab can be tried, but that is actually an individual decision which should be taken between the patient and the physician. What about advanced stage high tumor burden follicular lymphoma? This again classified by PET-CT. Here there are two choices. Would you give R-CHOP or whether would you give BR or bendamustine rituximab? And this is the basis of the STILL NHL-1 study. What it shows is that if you are giving bendamustine rituximab compared to R-CHOP, the progression-free survival, the curves are separating. So BR is doing better. But in case of overall survival, the curves don't separate. And what about if you give maintenance rituximab post R-CHOP or R-CVP? Because a lot of us, inspired by this PRIMA trial, have put patients on maintenance rituximab after giving R-CHOP chemotherapy. Here it shows again that over time, the progression-free survival in the maintenance arm, rituximab maintenance arm, separates from observation arm, but the overall survival is not different. Now, if you want to avoid rituximab and use one of these newer kids of the block, if you want to use obinutuzumab instead of rituximab, what is the data? This is the basis of the Gallium study, which is a randomized phase 3 trial where adult patients with untreated CD positive, CD20 positive advanced follicular lymphoma, more than 1,000 patients were randomized, were given either obinutuzumab plus CHOP, CVP or bendamustine in one arm, about 600, and rituximab plus CHOP, CVP, bendamustine in the other arm. Another 600 patients, followed by maintenance in the obinutuzumab arm with obinutuzumab maintenance, and the rituximab arm, rituximab maintenance every 2 months. And MRD assessments were done during maintenance and follow-up. Primary endpoint was progression-free survival. Here again, in the obinutuzumab arm, the progression-free survival separates, it's better. But overall survival curves don't separate. What is the latest update about this Gallium trial? The chemo backbone choice of CHOP, CVP and bendamustine is based on a center level decision, and analysis included 134 cases with DNA and transcriptosome sequencing data available, and 96 of 129 genes from EZH2 gene expression profile signature is evaluable. So what is suggested is that those patients who had the EZH2 mutation or EZH2 mutation signature may do better with CHOP or CVP, and those without may do better with bendamustine treatment. But these findings are with many caveats. What about if you don't want to give chemotherapy? A lot of people have got inhibition for chemotherapy. Can you use lenalidomide along with rituximab in advanced follicular lymphoma? So this is the basis of the relevance trial. Multicenter open label randomized phase 3 superiority trial where adult patients with untreated CD20 positive advanced follicular lymphoma requiring treatment as per JELF criteria were randomized into either lenalidomide with rituximab, the so-called R2 protocol, or rituximab with chemotherapy arm, followed by a lenalidomide rituximab maintenance or a rituximab maintenance. And the primary endpoint was CR. And if you look at the intention by treatment analysis, basically the response rates are reasonably similar. And if you look at the 3-year duration of response, 77% with R2 versus 74% with R chemotherapy. PFS and OS rates, overall survival rates are similar in both the arms. What about the safety outcome? If you are giving rituximab with lenalidomide, then there is more frequent cutaneous reactions, tumor flare or diarrhea. But if you are giving chemo along with rituximab, there is more febrile neutropenia, growth factor usage, nausea, vomiting, neuropathy and alopecia. So the chemotherapy arm has more side effects. And so maybe in elderly frail patients, this may be a way forward, the lenalidomide rituximab protocol. What about the latest update on this trial? After a median follow-up of about 6 years, the progression-free survival in both the arms are rather similar. 60% in R square, 59% in R chemo. Transformation rates are similar. Similar overall response rate and overall survival with subsequent therapy in both groups. Similar rates of secondary primary malignancies and 6-year overall survival, 89% in both groups. So to summarize, if you have in 2022, if you have a high tumor burden advanced stage follicular lymphoma, what would you do? Bendamustine with rituximab induction would be the most common protocol to be used. Less toxicity, possibly greater stroke similar efficacy to R-CHOP. And however, if there is concern for occult transformation, may consider R-CHOP. Maintenance rituximab unfortunately is of limited value. Progression-free survival, yes, it improves, but not overall survival. Lenalidomide plus rituximab is a good protocol, and if the toxicity profile is important in the patient, then it may be preferred. Adding obinutuzumab is not adding any extra value. There are also some ongoing trials with newer drugs. For example, should we start with an anti-CD20 and then add a P13K inhibitor only if response is suboptimal? So basically, if we want to do away with the chemotherapy bit and just use the newer molecules, there is one trial where ublituximab has been used, 900 milligram IV weekly for 4 doses. If the patient reaches complete remission, then stop therapy. If no complete remission is achieved, then you add umbracilib to it, 800 milligram daily, and then continue. So this is one of the ongoing trials, results are still awaited. Now we come to relapse. Because early relapsed follicular lymphoma defines a higher risk group needing better therapies. And those who relapse early, within 2 years, the overall survival suffers. So how do you treat a recurrent follicular lymphoma? You can use rituximab retreatment, obinutuzumab combination, radioimmunotherapy. There are lots of choices. I will come one by one. I will first deal with the augment protocol, where rituximab with lenalidomide has been compared to rituximab monotherapy in relapsed refractory indolent NHL. Obviously, this is for patients who has relapsed after some time, say 4, 5, 6 years post rituximab based chemotherapy. So you can consider them to be not rituximab refractory. In these patients, you can, this trial compared rituximab with lenalidomide with rituximab alone. And not very disingenuously, the rituximab lenalidomide arm was found to be better in producing progression-free survival. And the response was also better in the rituximab lenalidomide arm. So yes, if someone has received rituximab long time back, you can retry them with rituximab along with lenalidomide in a case of relapsed follicular lymphoma. Now, those who are rituximab refractory, suppose someone has relapsed after say 6 months post rituximab chemotherapy, what do you do? This is the basis of the gadolin trial, where bendamustine plus minus obinutuzumab has been used. And in one arm there is obinutuzumab with bendamustine, in the other arm it's only bendamustine, and in the obinutuzumab bendamustine arm you give obinutuzumab as maintenance. And not surprisingly, addition of obinutuzumab to the bendamustine improves both progression-free survival and overall survival. So in a relapsed refractory follicular lymphoma, obinutuzumab with bendamustine is a reasonable proposal. What about stem cell transplantation? So autologous stem cell transplantation in second remission for follicular lymphoma has been tried and with reasonable results. And what about allotransplant? Allotransplant, actually overall survival is better in autotransplant compared to allotransplant, and 3-year overall survival is 87% in auto versus 61% in allo. What about the newer drugs? Idelalisib, selective P13K inhibitor in double refractory NHL. So follicular lymphoma where rituximab doesn't work, alkylators don't work. There you can use idelalisib 150 milligram twice daily. You have to used continuously until progression. There is this new drug copanlisib, which has been used in relapsed refractory indolent lymphoma. And in ASH 2021 update, the Chronos 3 follow-up, which was a randomized double-blind placebo-controlled phase 3 trial of copanlisib plus rituximab in relapsed recurrent indolent non-Hodgkin's lymphoma. What they showed was in the copanlisib rituximab arm, there was 81% overall response rate with 34% CR, with a duration of response 20.4 months. Updated analysis shows longer response for those remaining on therapy versus those who discontinued for toxicity. But some patients showed durable response after early discontinuation. Umbralisib, which is another oral PI3K inhibitor, has been used in recurrent indolent NHL. It is the basis of the Unity NHL phase 2b study. Umbralisib is used at a dose of 800 milligram orally daily as a continuous dosage. Overall response rate in follicular lymphoma is about 45% with 5% reaching complete response. Principal toxicities were increased creatinine, cytopenias, diarrhea, nausea, liver enzyme increased, but there has been FDA approval for this drug. There is also this study, S1608, where obinutuzumab combinations have been used in early progressive or refractory follicular lymphoma. In one arm, there is umbralisib with obinutuzumab. In the other, it is lenalidomide with obinutuzumab. And in the third arm, there is CHOP or bendamustine with obinutuzumab. And this trial is still ongoing. EZH2, it's a histone methyltransferase. In normal B-cell biology, EZH2 regulates the germinal center formation, and EZH2 mutations can lead to oncogenic transformation by locking B-cells in germinal state and preventing terminal differentiation. And EZH2 activating mutations are found in 20% of patients in follicular lymphoma. And here, tazemetostat, a selective oral first-in-class EZH2 inhibitor, comes in place. There has been studies of tazemetostat in EZH2 mutant and wild-type relapsed follicular lymphoma, where it shows that in EZH2 mutant variants of follicular lymphoma, the overall response rate is 69%. But in EZH2 wild-type follicular lymphoma, the PFS, the overall response rate is only 35%. In ASH 2021 update, tazemetostat along with lenalidomide and rituximab has been used in a study, and accrual is ongoing. There has also been use of CAR T cells. It is the basis of the ZUMA-5 trial. And the other things that are being used are the BiTE and the bispecific antibodies like blinatumomab, monsunatumab, etc. In the ASH 2021 update, bispecific antibodies like mosunetuzumab, which has been used as a single agent and in combination, and also epcoritamab. These trials are in progress. There has also been used of glofitamab and odronexatamab. These are also trials in progress. So take-home points, controversies in the management of follicular lymphoma. What will it take to dislodge wait and watch as standard option? Randomized trial with overall survival benefit, clear quality of life benefit, evidence of cure. The answer hangs in the balance. How will we ever define cure? Potentially cured patients can relapse after 15 years. Should functional cure be the goal, and how is it defined? How can we better choose individualized quality of life targeted treatment? For regimens with similar overall survival, consider value of PFS benefit versus quality of life. Can we move to risk-adapted treatment, induction, consolidation, and maintenance, depending on prognostic score, tumor and patient profiling, PET, MRD, and ctDNA? Thank you.
Thank you, Dr. Bhattacharya. You have nicely covered all the aspects of management of follicular lymphoma, the high-risk lymphoma. So I want to know, what do you think, what is the key message, or what is the best modality of treatment? Is it chemoimmunotherapy or radiotherapy or combination, or what will give an impression of own impression that this is maybe the most?
Basically, for a newly diagnosed follicular lymphoma, If it's a low tumor volume, then right now it's wait and watch, not treating with rituximab. If it's a high tumor volume, then first line should be bendamustine rituximab. There is no great role of maintenance. And if the patient relapses, which is almost inevitable because you don't cure follicular lymphoma, after about say 5-6 years, then you can give rituximab again with chemotherapy or probably add lenalidomide. And if the patient relapses early, then say 6 months, 1 year after rituximab-based chemotherapy, then you have to change this rituximab backbone to something like obinutuzumab, and obinutuzumab with something, say bendamustine. So that should be the take-home message.
So all the facilities is available in Bengal now?
Yes, yes.
Okay.
We give
Fine.
them
So
regularly.
any question from audience? Any question? Thank you, Bhattacharya, for nice lecture.
So now we'll move to the third part, that is the panel discussion. The moderator today is Dr. Arpita Bhattacharya. Please come up. And that is towards the cure of ALL, role of asparaginase. Dr. Arpita Bhattacharya. And I will ask my co-chairperson to introduce the panelists. Dr. Ashutosh Panigrahi.
I will hand over the mic to Dr. Arpita Bhattacharya to introduce here panelist. Please call your panelist.
Dr. Arpita Bhattacharya is a pediatric oncologist. She will do the introduction for the panelists.
Very good afternoon to everyone. I'm extremely grateful to the organizers for including a session on childhood ALL because childhood leukemias don't usually get much of a place in adult conferences, but I'm really grateful that we are going to be discussing this. I take great pleasure in welcoming the panelists, Dr. Ashutosh Panigrahi, who is Associate Professor in the Department of Medical Haematology and Oncology at AIIMS Bhubaneswar. Dr. Panigrahi. Dr. Prakash Kumar Mondal, I'm very pleased to welcome him. He's Associate Professor at NRS Medical College, Kolkata. Prakash, are you there? Dr. Shubham Bhattacharya, who is Associate Professor at NRS Medical College. Welcome, Shubham. And Dr. Parthasarathy Bhattacharya, who is my colleague at Tata Medical Center. He is a Senior Consultant in Pediatric Onco-Critical Care. Is Prakash not coming? Okay, I think we'll just go ahead with this because the session is already running late. So my first question is to Dr. Panigrahi. Asparaginase is quite a common drug which is used in ALL. And would you like to tell us how asparaginase works in ALL?
Good research has told that asparagine is useful for DNA and RNA synthesis. So that is an important component, but unfortunately our body do not synthesize it. So we solely depend on outside source from the diet to synthesize, to fulfill the need. So what occurs, we do not have asparagine synthesis enzyme that also is needed for autosynthesis inside the cell from glutamine. So if at all our tumor cell need asparagine for DNA synthesis, that is very active in that cell, we had to get from the diet in our body.
So in other words,
once
it's an
we are
essential
getting
amino
it,
acid.
and asparaginase, by this drug we are metabolizing the whatever available asparagine. That's why tumor cells are deficient for that, and no DNA synthesis, and that cell goes into apoptosis. So that is the basic mechanism.
Okay, you have made a slide on the very interesting history of discovery of asparaginase and how it came to be used in leukemia.
So basically that is very interesting. So research was going on. They implanted some tumor cells into mice, and from guinea pig they removed the plasma and injected to the guinea pig, and they saw that these tumors are regressing. So
they also use other animals, and that plasma was not working.
Not working. So there is something in the guinea pig serum that is working. So they identified that this asparaginase is there, which is working as an anti-tumor drug. That came into the use for other tumors, but it was not fruitful except this lymphoid group. So that's why they incorporated this L-asparaginase first in CCG. They started doing using L-asparaginase, initially synthesized from E. coli, then Iranian, now pegylated forms are available. So this is basically the history of L-asparaginase, how it was introduced. Then they try to incorporate why it has to be incorporated, because they saw that it has the potent anti-tumor activity. So why not to use where it is needed, like when the tumor burden is very high. So that's why they started introducing into the induction regimen. So suddenly from 47% to survival went up to 93%.
Yes.
So that came to the introduction of L-asparaginase use in different protocols. Now the next, where else we can use it? Now again from POG group, Silverman, then others, they try to incorporate dose frequency, increased frequency of L-asparaginase use. But that led to, in different protocols, that led to increased toxicity, but still few protocols are also using. And recent COG and our European trials also, they are incorporating extended reinduction protocols where L-asparaginase is extensively used, and now they are preferring PEG formulations.
Yes, there used to be some protocols which incorporated asparaginase quite late into treatment, well into maintenance as well. But then studies have shown that that only increases the toxicity without improving the survival. And as Dr. Panigra has already said, that you need a largest tumor burden for asparaginase to be effective. That's absolutely great. Okay, so question for Dr. Bhattacharya. So he's just said that asparaginase is produced from lots of sources, and there are different kinds of asparaginase that are now available. So what are these, and when do we use each of them?
The classical L-asparaginase is derived from E. coli. That is called native L-asparaginase. The L-asparaginase, if you don't mention or don't specify, it will come as E. coli L-asparaginase. It was used since long times. There are some adverse effects, mainly hypersensitivity. So it is seen that several patients has experienced hypersensitivity. In a study shows around 30 to 40% patients experienced hypersensitivity to L-asparaginase. So to avoid this, a second variety was introduced, that is Arvina-induced L-asparaginase. And lastly, the latest form of L-asparaginase is PEG L-asparaginase, which is used nowadays in recent ALL protocols. The PEG asparaginase is the advantage of it is a long half-life with lesser immunogenicity. That is, the hypersensitivity reaction is less with PEG L-asparaginase.
I think to understand why asparaginase is such a complex drug and why so many preparations are needed and each time you come up with a preparation, then there's a new problem. It is good to look a little bit at the structure of the asparaginase molecule. You see, there are 4 domains, and the red, orange, and the yellow and green. And so it's a tetramer. So they are all held together, and there is a lid structure. So it is actually quite difficult to manipulate this particular molecule. So what people are trying to do is trying to overcome the disadvantages, because L-asparaginase is a bacterial product, and because it is an enzyme, it is immunogenic. And as Dr. Bhattacharya has already mentioned, that it is, why is asparaginase hypersensitivity such a big deal? You know, if it is hypersensitivity to so many products, and you use anti-allergics or immunosuppressants and you overcome that. But what happens is, when there is asparaginase hypersensitivity, anti-asparaginase antibodies are produced in the patient's body, and that would just inactivate the asparaginase. So no matter what you give, how much you give, whether or not you increase the dose, or whether or not you try to ameliorate the effects of hypersensitivity, the drug just becomes inactive, the body inactivates it. So a very, very essential component of ALL treatment is just taken out by the body just removes it as soon as it is injected. So that is one of the biggest disadvantages of asparaginase, it being immunogenic. And pegylation, as Dr. Bhattacharya has said, pegylation sort of tries to eliminate that, because here the molecule of asparaginase is embedded deep inside polyethylene glycol domain, and it is not exposed to the immune processing cells of the body, and so the antibodies are not really produced. So that is what pegylated asparaginase is. May I ask you, Dr. Bhattacharya, what's the biggest disadvantage of peg asparaginase, especially in our setting?
Biggest disadvantage is the cost. It is the cost is too much compared to the conventional products.
And how costly is it?
I have no particular experience about the cost. It's very
okay,
costly.
you see, asparaginase actually, when I first started working long before, I think you were still medical students then, asparaginase was imported, and the imported asparaginase cost, the cost was in lakhs. So it was extremely difficult, and the thing is that because of the particular way in which peg asparaginase is produced, though the dose is much, much smaller, the dose is 1000 units per square meter, but the vial comes in 3750 units. So a lot of asparaginase would be wasted, and very, very few families could actually afford this particular drug. But now there are a lot of biosimilars with a lot of patient assistance programs. So because of that, asparaginase is becoming much more affordable, and especially for large volume units who have many children on treatment at the same time, that 3750 unit vial can be divided amongst different patients. So it effectively reduces the cost. And when you think of the advantage of it, that hypersensitivity, especially in our country, can be as high as 75% without it being clinically obvious. You know, the patient may not have a local reaction or a rash or a bronchospasm or anything. So you wouldn't even know there is silent inactivation of the drug. So it is now becoming really useful because of the lot of biosimilars. But again, a lot of companies are coming up with biosimilars without actual validation of how effective it is. So before you consider using pegylated asparaginase, I think it would be a good idea to look at the biological activity of this particular drug. Now, I think there is research in recombinant variants as well, isn't it? Okay, so hopefully someday recombinant asparaginase, so human recombinant asparaginase would also become available. Now, the last bit of question is the serious adverse effects of asparaginase. So whoever amongst us has used asparaginase, be it in children, be it in adults, we have had lots of severe side effects. Dr. Panigrahi, what are the worst side effects that you have encountered?
Mostly, means every type what have been described in book, we have faced everything. Like diabetic ketoacidosis, severe degree of diabetic ketoacidosis, pancreatitis, venous thrombosis, then hypersensitivity in the form of going into shock and all type of from fast dose effect. So everything we have seen, but most commonly what we see with L-asparagine use, we have very limited access to pegylation because of cost only. But most commonly we are finding pancreatitis, next is thrombosis. Hypersensitivity at par in these two. So we do not know, many trials are done how to mitigate these adverse events, serious adverse events, but we have to take precautions only.
Have you lost any child due to
madam.
these side effects?
Recently we lost one patient because of severe pancreatitis, hemorrhagic peritonitis, and that child succumbed because of severe pancreatitis.
So I'm going to ask the only non-hematologist oncologist in this crowd, and that is Dr. Partha Bhattacharya. He is the pediatric onco-critical care person. So Dr. Bhattacharya, could you tell us some of the hairier experiences that you have had with pancreatitis toxicity, and just so that we become more aware about it?
So, as rightly said, I am the odd person out in this crowd. Basically, what I believe that the outcome of the childhood leukemia has improved vastly through the innovation, the diagnostic modalities, the treatment modalities, the multi-agent chemotherapies. But I also believe it has got a huge amount of effort, like supportive care, when actually the child lands in, as you, Dr. Panigrahi rightly said, that he actually wanted to cure the child with something, with an agent which is of proven benefit, like L-asparagine, but landed the child in trouble and the child did not make it. So the most important part, that as you are advancing your diagnostic and therapeutic modalities of treating childhood leukemia, at the same time people have to invest into the supportive care. So just first look at the child, the first child. I'm just giving you the CT scan evidence, unmistakable evidence that the child came to us with pain abdomen which was ignored. Because pain abdomen in a child who was undergoing treatment with so many agents has so many causes of pain abdomen, and if the clinician's index of suspicion, particularly on those receiving asparaginase, is not high, this diagnosis can be missed and can be detected very late with very disastrous consequences. For the first child, he came back to us after receiving the PEG asparaginase, 7 days after receiving the last dose of PEG asparaginase with pain abdomen, classical pain abdomen, vomiting, amylase lipase very high, and CT scan ultrasound confirmed that he has pancreatitis.
May I just interrupt Dr. Bhattacharya just for a second? This is for everyone who's going to be using asparaginase, is that these severe side effects are not avoided if you use pegylated asparaginase. Pegylated asparaginase only decreases the frequency of hypersensitivity.
Yeah.
So the severe adverse effects can still occur if you're using the pegylated.
So this child fortunately responded quite well to the conservative management, did not require the intensive care support. But he was managed in the ward, in the high dependence unit, and he is the path of recovery and is continuing his treatment. Next place, please. So this child, as you can see, the child landed up the similar story. 12 days of last dose of PEG asparaginase, comes in with pain abdomen, vomiting, huge abdominal distension, and very toxic looking child, quickly becomes hypotensive, requiring intensive care support, intubation, ventilation, inotrope support, the albumin Lasix infusion to take care of everything. And if you can see on the extreme left-hand corner, look at the pancreas, the amount of pancreas that is completely necrosed, almost 2/3 of the pancreas is gone. And I remember one child referred from the Tata Medical Center to Apollo Hospital when I was there, and we needed to embolize one of the arteries because it was hemorrhagic pancreatitis. The necrotic thing has involved a major artery. And that child also has completed his treatment and went away. Okay. And so the supportive care, actually this child is going very well, and his last follow-up, he's doing perfectly well. Obviously, L-asparaginase cannot be given to him, I believe, according to the severity of the things. But only good supportive care has brought this child back, and he's continuing with his treatment. Next child, please.
No, may I just ask you one question? What are the chances of the patient getting pancreatic insufficiency, either in the form of exocrine or endocrine insufficiency following severe pancreatitis?
See, majority of the L-asparaginase-induced pancreatitis, what my experience is usually transient hyperamylesemia and lipemia. They usually respond very well and do not end up in complications, but not as severe as this one, where the 2/3 of the pancreas is almost gone, and the child was very hyperglycemic at some point of time, required insulin infusion, but as of now, his glycemic control is okay, and I do not know, he needs long-term follow-up to see which way is exocrine and endocrine dysfunction happens with related to the pancreas or not. That needs good long-term follow-up. The third child that you see, as you rightly said, this commonest complication that we see, this is the only 4-year-old child who started on treatment. This is standard L-asparaginase, and presented with the convulsion in the community pediatricians. They saw a Ryle's tube and asked the mother, what the child has a Ryle's tube. The mother said the child is under treatment for cancer. So they said immediately shift the child to the Tata Medical Center. Unfortunately, the child needed 30 minutes to reach the Tata Medical Center emergency, where he found the child in almost refractory status epilepticus, not responding to first, second, third line of anti-epileptic drugs. So the child needed almost 7 or 8 kinds of drugs to control the convulsion in 36 hours. And radiological evidence confirmed the child has hemorrhage, the child had cerebral edema, child had also, can you see the next bit? So you can see this, the whole sagittal sinus thrombus is almost thrombosed. And in this venogram is also showing the same thing, and there is quite a lot of edema in these things. And the child was on ventilator for 7 days. And fortunately, she is still continuing with the treatment. She came out of the ventilator support, and she's still on anti-epileptic drugs, but no neurodeficit as of now. So that is again the good supportive care that has made the difference. So L-asparaginase will be there, the mainstay of treatment for childhood leukemia. And unfortunate children will end up having very serious life-threatening adverse events. But what I'm experiencing is that with good supportive care, early detection, I think you can bring them back to the mainstream, and then you can continue the treatment to completion. Thank you.
Thank you, Dr. Bhattacharya. Just one quick question which either Dr. Panigrahi or Dr. Shubham Bhattacharya can answer. So which of these severe side effects are absolute contraindications for further use of asparaginase, and when can you re-challenge with asparaginase?
If there is hypersensitivity, it is the absolute contraindication. We should change the type of L-asparaginase, but other complications like thrombosis, pancreatitis, these are not contraindication. We should take some time to settle down this acute event, then thereafter we can re-challenge with this. But there are, regarding this thrombosis which is showing in this part, there is some prognostic markers like serum fibrinogen level, etc. So we should look at this level before attempting to restart this L-asparaginase.
That means we can re-challenge, but we have to see the degree of, grade of the adverse events. If it is definitely a life-threatening adverse event, we should not re-challenge.
Yes.
Hypersensitivity, of course,
the drug is rendered useless.
It is useless. So that we have to grade the adverse events, degree of how serious the child is and how difficult was to control it. Accordingly, we have to decide. But it is not an absolute contraindication that we cannot re-challenge. But for grade 2 toxicities also, if the same grade 2 is occurring recurrently, then also it is a consideration that should we continue with it. But once a child is off L-asparaginase, definitely we cannot think of a good remission in that child. That is very important.
That becomes a problem. And also another bit of message that I would like to give, you can switch from L-asparaginase to pegylated asparaginase, but not the other way around. If you have used pegylated asparaginase, then for the rest of the treatment, whenever asparaginase is needed, you have to give pegylated asparaginase. I thank the panelists and the organizers and the chairpersons. Thank you very much.
Thank you, madam, for the nice discussion.
Thank you, Arpita, for the panel discussion, and also the panelists for this discussion.
Thank you. चलो हेलो बोलो
Thank you, Chairperson and Speaker, for the remarkable and knowledgeable sessions. Now, moving on towards with our fourth session, topic plasma cell dyscrasia, based on the theme target the clones. For this, I would like to request our first chairperson, Dr. Siddharth Shankar Roy, Professor of Haematology, ISTM, Kolkata. And our second chairperson, Dr. Shopan Kumar Sinha, ex-professor and head department of pathology, Medical College, Kolkata. There is one reminder to everyone, we have a quiz session tomorrow, 9 a.m. I would request all the quiz participants form a team and report backstage before 5 p.m. today.
I think Dr. Sinha is there. Dr. Shopan Kumar Sinha, I think might not be here. Okay. As we are running a little late, so with the permission of the organizer, I think we should start the session, or should we wait for the co-chairperson, Dr. Shopan Kumar Sinha? Okay. So we will go to this next session on plasma cell dyscrasia, and here we have two talks on management of the high risk multiple myeloma, followed by tools for MRD in multiple myeloma. Thereafter we have one panel discussions on monoclonal gammopathy of renal significance. So without further delaying, I would like to invite Dr. Maitri Bhattacharya, Professor and Director, Institute of Haematology and Transfusion Medicine, to deliver her lecture on management of the high risk multiple myeloma. Madam, you can start.
Good afternoon, everybody. Thank you, Chairperson, for kind introduction. I don't know, this topic which has been given to me is management of high-risk myeloma. It's a highly specific topic for hematologists, though you can say this is a hematology conference, but I'll try to make it as simpler as possible. So, multiple myeloma, as you all know, it's basically a plasma cell dyscrasia which produces some monoclonal protein, what we call M protein, and this affects the bones, kidney, and hemoglobin also comes down. Can I have a pointer? No. So coming directly to the topic, so which type of myeloma, we can call it a high-risk myeloma. Actually, this re-stratification differs. Initially, it was Dury-Sulman classification, which includes creatinine, calcium, immunoglobulin, a lot of parameters. Then it was changed to international standardization stage, and this was ISS staging, which includes albumin and beta-2 microglobulin. After that, actually, we entered the molecular era. Then we started identifying the cytogenetic abnormalities and other molecular abnormalities in multiple myeloma. So during that period, ISS was changed to RISS or revised ISS, which includes two extra parameters. One was LDH and another was cytogenetics marker, which were high risk marker. These were mainly 414, 1416 and 17p deletion. So by this, they classified RISS into 1, 2 and 3 stages. But it was found that even even these three was not enough to identify all high-risk myeloma patients. What they found that only elevated LDH without the high-risk markers, other cytogenetic abnormal markers, is also a high-risk myeloma. If there is circulating plasma cell, even if it's not a plasma cell leukemia, that is a high-risk myeloma. Plasma cell leukemia, of course, we know it's high-risk myeloma. Extramedullary disease, if there are multiple PET positive bony lesions, even fertility has been considered as a risk factor for treatment of myeloma. If an elderly patient is having poor performance status, there has been some assessment scored also. One is RMCI score for myeloma, another one is IMWG score, by which the elderly patient should be initially assessed for their performance status, not by the standard ECOG or other parameters. And if this is into the advanced stage, then they should be included in this group. So this is also a high risk group. And 1Q, by this time all of us know this is a bad prognostic marker. T53 again they have included. So not only our ISS will have to consider all these parameters for defining myeloma, whether it's a high risk or not. So how we'll find out optimal management of high-risk myeloma? Because as I have shown you, this is a heterogeneous population. So it's very difficult to find out single protocol for all these patients. And you know, most of the clinical trials of myeloma, they are not specific for high-risk myeloma. They are trials for myeloma. Maybe there are high-risk patients, and it has been found that the total number of patients in those trials are only less than 15%. So statistically it was very difficult to come to a conclusion that this protocol or this drug will be effective in high risk myeloma. So these are the problem when people started formulating protocol for myeloma high risk patient. So NCCN, as we all know, it formulates protocol for different hematological malignancies, but they have not recommended different protocol for high risk myeloma. What they have done is only as transplant eligible or ineligible. IMWG recommends that proteasome inhibitor, lenalidomide and dexamethasone, these three drugs should be considered also in high risk myeloma. And MSMART said either VRD for transplant ineligible patient, or you can add daratumumab along with VRD for transplant eligible patients. So the treatment guideline of myeloma, which was there even 3-4 years back, was very simple. In a transplant eligible patient, in high risk group, carfilzomib, lenalidomide and dexamethasone 4 cycle, then ASCT, and after that maintenance either with carfilzomib or bortezomib. In other two groups, this is VRD 4 cycles followed by ASCT. But only change what was made is that maintenance therapy should be with proteasome inhibitor, either carfilzomib or bortezomib, not with lenalidomide, what is the standard drug for maintenance therapy. This is the difference in high risk protocol. In a transplant ineligible, you can see everybody was getting the same drugs. And again the difference was in the maintenance only. Here this is proteasome inhibitor, bortezomib, here this is lenalidomide for maintenance therapy only. So this was a standard protocol which everybody was following, and frankly speaking most of the cases we don't use separate protocol for high risk myeloma. We use the same protocol for all risk group, though we risk categorize. We write on our protocol this is RSS1, this is 2, this is 3, but the same drugs for all groups. That what we are doing is not the proper one. So people said like carfilzomib should be tried instead of bortezomib for this group of patients. This is not only high risk group patient, this is a general trial, but what this phase 3 trial has shown that there is no progression to survival benefit when carfilzomib was used instead of bortezomib. So what they said that carfilzomib, if you add carfilzomib, there is controversy whether it will help you in treatment of myeloma if you change bortezomib to carfilzomib. Then the new drug after carfilzomib, what came into the market is daratumumab. So people added daratumumab to the backbone protocol. Like you were using lenalidomide dexamethasone, you started using daratumumab, lenalidomide dexamethasone, or carfilzomib daratumumab. So this study, this is basically a meta-analysis where these 3 studies were analyzed, and what they found that when they have added daratumumab to the first line backbone regimen, it was associated with a PFS benefit. So if you add daratumumab, if you add carfilzomib, there was no PFS benefit. If you add daratumumab, there will be a PFS benefit if you add it in the background protocol. So this is another study which was published in NEJM in 2021. It also showed, you can see this is the daratumumab arm and this is the arm without daratumumab. There is a significant PFS benefit when daratumumab was added. This paper was published in ASH in 2020, and here they have combined both carfilzomib and daratumumab for treatment of high-risk myeloma patient. In this study, around 50% patient, you can see 49 patients were having poor cytogenetic markers. This is 1Q plus 4, 14, 14, 16. And with this 4-drug combination, around 74% patient become MRD negative. But this was analyzed as a whole. The high-risk patients' data was not analyzed separately. What I told you at the beginning, that in most of the trials, there is no separate data analysis for high-risk group. So we cannot say that this was effective for high-risk, but as such, this 4-drug protocol was very effective for myeloma patient. This is a drug when elotumumab, this is another monoclonal antibody which has come after daratumumab, and when it was added to the backbone of dexamethasone and bortezomib and lenalidomide, it again showed that there was no benefit for high-risk myeloma patient. There was no added benefit. You can see this one. This is elotumumab and VRD, and there was no added benefit with elotuzumab. But what this study showed that when they compared the data with the historic PFS data, there was a benefit. So why there was this benefit? When they have compared two arms, there was no benefit. But when they compared with the historic data, there was benefit. This benefit was basically because of the thing that they have done a maintenance therapy with the proteasome inhibitor and immunomodulatory drug. So either bortezomib plus lenalidomide. So for high-risk group patient, if you use daratumumab in the initial therapy, it will be helpful. If you use carfilzomib, there is controversy whether it will be helpful or not. But one thing was established that if you do a maintenance therapy with proteasome inhibitor plus immunomodulators, it will be helpful for high-risk group patient. This is another study which is used isatuximab and carfilzomib, lenalidomide and dexamethasone. You can see this arm is transplant eligible arm and this arm is transplant ineligible arm. MRD negativity with this 4-drug was as high as 64.5%. 20 out of 31 patients became MRD negative. So this 4-drug combination was found to be very effective in high-risk myeloma group. Compared to the other studies, this study has recruited only high-risk myeloma group. So after induction therapy, next question comes for transplant. And all of us know that ASCT is the gold standard, especially for the high-risk myeloma group. Now the question is whether to go for a single transplant or double transplant. There is again controversy. Some of the data showed that tandem transplant is going to benefit high-risk group, whereas other studies have shown that there is no benefit of tandem transplant in the high-risk group. So most of the protocol has included single transplant only, except a few. I'll show you that. Regarding maintenance therapy, that I have already told you, for high-risk group, maintenance therapy should be either bortezomib or carfilzomib, or it should be bortezomib, lenalidomide and dexamethasone. So a combined drug with proteasome inhibitor or single proteasome inhibitor. This drug is an oral proteasome inhibitor, ixazomib, but it has been found to be of no use in maintenance therapy in high-risk group patient. So ixazomib cannot be used for maintenance therapy. So this is the treatment approach. What I showed you, that was the treatment approach 4 years back, and this was published in 2021 ASHCO educational book. Here you can see that transplant ineligible patient, you can give either VRD or DRD, and after that maintenance therapy with proteasome inhibitor plus minus IMiDs. In transplant eligible patient, VRD, KRD or daratumumab plus VRD. After that transplant, you will have to assess MRD. The next talk is on MRD, so we will come to know when it's to be done. After transplant, if the patient is MRD positive, then of course you will have to give a consolidation therapy 2 to 4 cycles more, what you have given in induction. If the patient is MRD negative, then you can go to a maintenance therapy directly. And the maintenance therapy should be always a combination of proteasome and IMiD. So this is a recent guideline for treatment of multiple myeloma. This is special scenario. I told you that frail patient has been included, they have been included into the high risk group. So what is to be done for this group of patient? Because myeloma is a disease for the elderly patient, so very beginning you will have to assess the patient for their frail status, and after that you will have to decide. But always try to use triple combination, not a double combination. If the patient is on double combination, try to change it to triple regimen. And you can, maybe that you need to lower the dose. Lenalidomide, most of the aged patient, they won't be able to tolerate. Maybe you will have to give 15 milligram of lenalidomide instead of 25 milligram. And ASCT is not contraindicated in this group. You will have to assess the performance of the patient after induction again. And if the performance status improves, then of course you can go for ASCT even in this group of patient. So this is one combination, ixazomib, daratumumab and low dose dexamethasone, what they have used in this group of patient, elderly patient and frail patient. What they have shown that there was a benefit, overall response rate was 78%, and what interesting thing they found that PFS and OS was better when the status was considered with age only. These patients are more than 80 years. But when they have considered other factors other than age, they have found that PFS and OS was lower, irrespective of whether the patient was less than 80 or more than 80. So chronological age is less important compared to other factors which actually will help you to classify patient into this frail group. Whatever treatment you will give, nowadays the aim of treatment is to have a deep response. Like deep response was a specific thing for CML, now it has come into myeloma also. You will have to have a deep and sustained response. So you will should target for MRD negativity, and if the patient is MRD negative, you can see the PFS is better. Even they have shown that overall survival also is better if you have achieved a MRD negative with all these drugs. With these patients also again they will relapse. So the management of relapse high-risk myeloma is the same as the relapse standard risk and intermediate risk myeloma. And response also is same, it's not different. But this response is less deeper and less sustainable response compared to the standard risk and intermediate risk group. Drugs which can be used for high-risk relapse refractory myeloma are daratumumab, isatuximab and carfilzomib, pomalidomide, lenalidomide in various combinations. So the same drugs which were recommended for the initial treatment also recommended for the patients in time of relapse and refractory diseases. So these are some of the protocol used for relapse refractory high-risk myeloma. Here you can see carfilzomib, as I have shown you, was not beneficial for PFS when it was used as induction therapy in combination. But here you can see PFS was much better when carfilzomib was combined with lenalidomide and other drugs. This is a meta-analysis of 3 trials, and all of them has shown the PFS benefit with addition of carfilzomib in case of relapse myeloma. This is isatuximab plus pomalidomide and dexamethasone. Here also, whenever isatuximab has been added, even in patients more than 75 years of age, it showed a PFS benefit. Daratumumab, lenalidomide, dexamethasone was found to be beneficial compared to lenalidomide and dexamethasone in relapse refractory cases. So coming to novel drugs, you can say that all the drugs what you have said till now are novel except carfilzomib and daratumumab. But all these drugs are into practice for a long time. We are not using these drugs, of course, in India. So the novel drugs which are there, one drug is selinexor. This is a X-protein-1 inhibitor. This has been shown a promising result in refractory multiple myeloma patients. Another drug is a belantamab. This is also another drug which has been shown a good response. You can see the overall response rate, and most of the cases it was either a VGPR response, and all these patients has received multiple mode of drugs prior to relapse and refractoriness. So these 2-3 drugs have been found to be effective in relapse refractory myeloma cases. Coming to the recent one, the CAR T-cell therapy. B-cell maturing antigen has been extensively studied as a target for CAR T-cell therapy. BCMA targeting CAR T-cell have demonstrated a deep and sustained response, what is required for multiple myeloma. Sample size of all these trials are very small, but most of the patients are high-risk patients. So these trials will help us to come to a conclusion regarding treatment protocol of high-risk patient. One of the CAR T-cell, that is ide-cel, has been approved by FDA for use in multiple myeloma patient. This is one study which was published in NEJM. You can see these are various doses of CAR T that has been given, 150, 300, 450. Overall response rate was around 73%, and you can see some of the patient has achieved CR and even stringent CR also. All these are refractory patient. So CAR T cell is a good hope for high risk myeloma patient even after multiple relapse. To sum up, it's very difficult to identify high risk myeloma patient. As I have told you, this is not as simple only by RSS only, but this is actually the unmet need nowadays. We'll need to find out high risk patient, and we need to find out a suitable protocol for them also. Most important thing for this is basically a genomics. Genomics will help us to identify high risk patient as well as to find out a suitable treatment protocol for this group of patient. And whenever treating a high risk myeloma patient, we should target to achieve a MRD negativity, and whenever managing a patient of high risk, our target should be a response adapted. Like we should determine the response and we should change the sequences also as the response of the patient. And always we should add a combination of drugs which are having different mechanism of action. Probably then we can get some benefit in this high risk group of myeloma patient. But to find out suitable protocol for this group of patient, further studies are required, trials are required, which should include only high risk myeloma patient. Then of course we'll be able to find out suitable protocol for treatment of this high risk group patient. Thank you.
Thank you, Dr. Bhattacharya. Actually, you made it quite simple and lucid from difficult topic. Can I ask you, in your day-to-day practice, how do you use carfilzomib for maintenance?
Carfilzomib, what they have said actually, in most of the cases, they have used the same protocol continued as maintenance till the patient has achieved progression or there is intolerance. But in some of the cases, they have used alternate week, even once in a month also they have used in some of the protocols.
Once in a month, only single dose?
They have used some of the protocols. Nothing has been recommended dose.
Okay, any question? Yeah.
For patients with plasma cell leukemia, what is your initial protocol?
None of these protocols will be effective. What they have suggested that BT-PACE is one protocol which may be effective in plasma cell leukemia, but none of the, though if you see they have said that daratumumab, bortezomib, carfilzomib, but recent ASCO guideline they said none of this protocol will be helpful.
And in your practice what do you do?
They suggest that VAD, PSA, BT-PACE regimen for this plasma cell leukemia group.
Thank you.
Thank you, madam. You made our doubt very clear about high-risk myeloma. One thing came to my mind, why pomalidomide has not been given, can we use that one in high-risk myeloma? Means high-risk myeloma, upfront treatment, we are adding as a fourth drug daratumumab.
because affordability is a issue. So in contrast, pomalidomide is a cheaper drug that can be used. Does it make any help
Like
in treating
in
high risk
most of the studies, like frontline drug, one thing is very clear nowadays, none of the protocol is recommending thalidomide. They have excluded thalidomide. But in induction, none of the protocol, they have combined pomalidomide instead of lenalidomide. They have used pomalidomide in the relapse refractory setting only.
না এটা 8-10 এটা না হবে মনে হয় ওটিপি বলে আমার একবার দেখিয়ে নিন কিটনটা দেখিয়ে দিন এটা এসে গেছে বললাম তো আসছি প্রেজেন্ট স্মল না ট্রেসে তো ট্রেসই লেখে
In a patient of high risk myeloma with 17p deletion, the patient received VRD, had a partial response, then switched over to carfilzomib based therapy and again BGPR. Then the patient was given ASCT. And obviously he had poor response to bortezomib based therapy, so maintenance with carfilzomib has been started. Should this patient receive IMID with
but now they are suggesting that proteasome inhibitor should be combined with IMID. So you can combine lenalidomide with carfilzomib.
What about steroid?
What about?
Steroid. Dexamethasone.
In only 2-3 studies, they have used total VRD as a maintenance therapy. That also, most of the studies recommend proteasome inhibitor plus lenalidomide. But in some of the studies, they have used VRD combination, triple drug as a maintenance therapy also. But I don't think that will be very wise decision to continue Dexa for long term in a myeloma patient. Better option will be carfilzomib or bortezomib plus lenalidomide.
But initially this patient had poor response to bortezomib. So
then you should give carfilzomib, yeah.
Along with
because as I told you, treatment should be response based. Like as you are saying that there is poor response to bortezomib, that's why you have changed it to carfilzomib. So each and every state we will have to assess the response and we'll have to determine and find out a drug which will be effective for this patient. To some extent it will be personalized, not a general protocol for all high risk group.
But you suggest combining with IMID?
Combining with IMID.
Okay, thank you so much.
Thank you. I think we will go for the next topic. Thank you, Dr. Bhattacharya. So, our next speaker is Dr. Jasmita Das, and the topic is tools for MRD in multiple myeloma. May I request Dr. Jasmita Das to take the podium and discuss the topic. Actually, when we were students that time, we used to study about MRD in leukemia, but now with the advancement in different diagnostics, we are now going to the MRD in multiple myeloma like therapies.
Thank you, sir, for the kind introduction. And at the outset, I would like to thank the organizing team for BeSHCON to have invited me here today. It's a pleasure to be in your city, and the conference, I must say, is very well organized. So what are the tools for MRD and why do we need MRD in myeloma? So myeloma, you have, we've seen a drastic, I don't think you can see my slides. Yeah. So there have been significant improvements in myeloma survival. So survival from 25% in 1973 to 79 has increased to over 50% by the decade 2010. You, as Dr. Maitri told you, there are very good responses with novel agents. CR rates approach over 60% and stringent CR is achieved in 30 to 40% of transplant eligible patients. So because of that, there is a need for assessing which one of these patients who achieve CR and stringent CR do well and which patients relapse. So therefore, better therapy paves way for better response evaluation. So why do we assess measurable residual disease in myeloma? Because we have a higher number of patients achieving good responses. We need to identify patients who will relapse early after auto transplant. It is also being increasingly used as a measure of primary or secondary outcome in the clinical trials for myeloma. To reduce the drug approval time, because nobody would want to monitor for 10 years for survival benefit, and also to identify patients who require intensification or de-escalation of therapy. So if you look at what impact measurable residual disease assessment has had in myeloma, every study over the last 1.5 decades or so clearly states that whether MRD was assessed by flow cytometry or by ASO RT-PCR, patients who were MRD negative did far better than patients who were MRD positive. So this was also proven in the meta-analysis, and some of these slides Dr. Maitri showed. So there was an improvement in PFS as well as in the cumulative survival or the overall survival. It was interesting that MRD outperformed CR. So patients who were not in CR, so among those patients, PFS was longer for those who were MRD negative versus MRD positive patients, and corresponding improvements in overall survival were also seen. So this was the updated meta-analysis again from Dr. Munshi. So this uses 93 studies, and it basically shows that MRD is of value regardless of whether your patient is transplant eligible, ineligible, or whether you're looking at relapse refractory myeloma. So regardless of whatever myeloma you have, whatever category or type of patient you have, MRD will add value. And it is per log reduction of MRD that shows survival benefit. So nearly 1 year of survival is added as long as you get 1 log reduction in the MRD levels. So when we consider myeloma monitoring, we look at the protein values in the serum protein and the urine protein electrophoresis add on to the immunofixation as well as the FLC, which was added in 2011 response criteria. The updated criteria for 2016 incorporate MRD in a major way, so including both the next generation flow cytometry and NGS for intramedullary MRD and imaging for the assessment of extramedullary disease. So your patient can be flow MRD negative, sequencing MRD negative, or imaging plus the other two negative. So based on this, the International Myeloma Working Group defines your patient as sustained MRD negative if 2 MRD measurements 1 year apart are negative. For flow, they specifically recommend next generation flow, which means assessing 3 to 5 million cells per tube for using the Euroflow standard operating procedure. For NGS, they recommend the lymphocyte platform, and which is now called the ClonoSeq platform. And for imaging, it is the PET-CT, which has been used in the International Myeloma Working Group criteria. So when we look at MRD in myeloma, it exists in both the divisions. So there is intramedullary MRD as well as extramedullary MRD. So intramedullary we assess by flow cytometry and ASO PCR. This was the conventional part, and this has been updated now to next generation flow cytometry and next generation sequencing, which is the corresponding upgrade to the ASO PCR. For the extramedullary disease, we can do PET-CT and diffusion weighted MRI to assess this disease. So we will first look at intramedullary MRD, and this is a comparative of all the techniques. So understand that flow cytometry is available to most patients of myeloma to assess MRD. It has a sensitivity approaching 10 to the power -5 or -6 if we use the next generation flow cytometry. We do not require a diagnostic sample in all the cases, which is not the case for the molecular techniques. Both ASO PCR as well as next generation sequencing, you would require the patient's baseline diagnostic sample. The applicability of ASO PCR was only to 60 to 70% of the patients, while for next generation sequencing, it is up to 90% of patients. The turnaround time for molecular techniques is longer. The availability of flow is far wider, but the sample has to be fresh. In contrast, NGS can also be done on stored archival samples. So myeloma we all know is a patchy disease. So we primarily take samples from the iliac crest. So all the samples which we use that whether it is flow or whether it is next generation sequencing has an impact of the patchy disease, while in PET-CT you will be able to pick up lesions at other bone sites also. And as far as the cost is concerned, still the molecular MRD is more expensive than the flow MRD. So for our country, the widest value that we have is for flow cytometry. Considering the time points for MRD assessment, you would like to do MRD at every stage that the treatment changes in myeloma. So at the end of induction therapy, 100 days after the stem cell transplant, at the end of consolidation, and at the end of maintenance therapy. And if your patient is MRD positive at some time point, you may like to give some additional therapy at that time point. In addition, the NCCN guideline adds that if you are going to use NGS for further evaluation, then a baseline clone ID at the time of diagnosis should also be done in addition to the MRD assessment time points. So when we look at flow, these are the wide variety of panels that were used, and the Euroflow 2017 That tells you the two 8-color tubes, and I'll show you these tubes later. Now these are tubes which will achieve a sensitivity of 0.001% or higher. The article by Rochal et al., they evaluate essentially the same markers as a single 10-color combination tube. So what do we do when we assess measurable residual disease by flow cytometry? We gate the plasma cells. So for plasma cell gating, CD38, CD138, CD45 in combination with forward and side scatter is what is helpful. For your patients who have received daratumumab, you would require alternative gating strategies including CD229, CD319, CD54, multi-epitope 38 and VS38 antibodies. Now once the plasma cells are identified, we want to see how they are different from the normal plasma cells, and for that these are the markers that aid us. CD19, 56, 81, 27, 117 and 28 are commonly used. These are aided by clonality assessment for cytoplasmic kappa and lambda, because when there are small suspicious normal populations which may be 19 negative or 56 positive, you want to know whether the population that you are identifying as so-called abnormal, whether it is clonal also or not. In addition, flow cytometry lets you assess the sample quality and adequacy because you have normal cells available in all your samples, including mast cells, hematogones, memory B cells and myeloid precursors. So these are the gating markers. CD38 has a very high intensity of expression, usually is tagged with a weaker fluorochrome. However, it is not specific for plasma cells. In contrast, CD138 is restricted to the plasma cell compartment. It has to be tagged with a bright fluorochrome. The problem with 138 is if your lab receives shipped samples, then the intensity of 138 goes down on the cell. And the samples are preferably collected in EDTA because it's a heparan sulfate, so its expression on the surface is modulated if it is collected in heparin. So if you look at these antigens, now can I have a pointer that works please? So the antigens in blue, so CD19 is usually negative on the abnormal plasma cells, 81, 27, 45, 38 and 54 they are dimly expressed. While CD117 is positive only in aberrant plasma cells, 56 is bright positive, 28 and 200 are also positive. So based on that, the panels have been built, and I am just showing you an example here. So CD38 and 138 gating, you see plasma cells gated in red. Subsequently, when you look at them based on CD19 and 56, you see that plasma cells are in all compartments. So green represents 19 positive, 56 negative cells, blue represents the dark blue compartment represents 56 positive, 19 negative cells, and then you have double positive as well as double negative cells. This is where clonality helps us. So the clonality gates have been set on the normal B cells which are polyclonal. You look at the 19 positive, 56 negative cells, they are polyclonal as expected. The double positive cells are also polyclonal. The double negative cells are also polyclonal, and it is only the 56 positive compartment that has a residual disease. When you look at the intensity of CD38, it is dimmer than the normal plasma cells on the residual disease compartment. And when you look at CD28, it is expressed on these cells, the third plot to the right, and you can see the cells are clonal. So this is the 8-color recommended panel for next generation flow cytometry by the Euroflow consortium. If you look at it, I'm sorry, the markers have sort of moved. 6 markers are common between the two tubes. So CD138, 27, CD38 multi-epitope, 56, 45 and 19 have been kept constant. The first tube is a surface staining tube which has CD117 and CD81, and the second tube has cytoplasmic staining, and cytoplasmic kappa and lambda are used in place of these. So this is how you will see disease in this. The red population represents the malignant plasma cells which are showing dim intensity for CD45, they are positive for 56. They are negative for CD19, CD81 and CD27 is slightly dimly expressed, plus all of these are clonal for lambda. So this was at a level of 0.001% that they could detect MRD successfully in their panel. So based on their results, what you can see is patients who are in CR and stringent CR, the two graphs at the bottom, the patients who are next generation flow negative do far better than patients who are next generation flow positive. In addition, patients who were, thank you. So in addition, you see that in this plot you have conventional flow positive and negative groups. So MRD negativity by NGF, these patients did the best, and patients who were NGF positive but conventional flow was negative, they had a poor PFS. So there are certain caveats in MRD assessment when you assess by using these techniques. The biggest concern is hemodilution, because with hemodilution you may have a false negative MRD, and that false reassurance to the patient is far worse than not doing the MRD in the first place. So always take first pull marrow samples for MRD, assess the adequacy of bone marrow by presence of normal marrow elements, and I'll just show you an example. That's possible with flow but not with genomic tests. There are situations in which M protein levels may normalize, may take longer time to normalize because of its long half-life. So you may have patients who are not in CR but are MRD negative, and sometimes oligoclonal bands post autologous transplants may also interfere. So how do we assess sample adequacy? We've got multiple normal cells such as mast cells, erythroid precursors, hematogones, and the B cell compartment, in which we can look at naive and memory B cells. So this is an example of how we can look at mast cells by their CD117 high expression. Then hematogones using CD38, 45 and 81. We can look at then the myeloid precursors as well as the erythroid precursors in the 45 negative compartment. So if we don't have these in our sample, the sample should be reported as inadequate for MRD assessment rather than reporting a MRD value on it. So as I said, first pull bone marrow, 10 ml of marrow for next generation flow. You process it using a bulk-like stain wash protocol as per the Euroflow SOP, and you note values of abnormal plasma cells as a percentage of total as well as a percentage of all the nucleated cells. Event acquisition is very important. If we are planning to do NGF, 3 to 5 million events per tube need to be collected to achieve a sensitivity of 0.001%. NGF prepared by Euroflow claims a sensitivity of 10 to the power -6, but that may not be achieved in every case, but 10 to the power -5 is achievable. And you need to know what is the limit of detection and limit of quantification of your assay. And this is just a diagram to show you the effect of event acquisition. So now this compartment contains our abnormal plasma cells, and if you look at 1 lakh, 3 lakh, 1 million events, and then 2.8 million events, and the cluster is very nicely visible to you. So as you collect more events, the abnormal cells would become more apparent. In your MRD report, ask your pathologist to report the limit of detection and limit of quantification. Usually limit of detection 30 cells is reproducible. For limit of quantification 50 cells is better, because that tells you that multiple labs, if they do MRD assessment, they'll land likely at the same value. The consensus guidelines on MRD reporting in myeloma by flow say that you need 5 initial gating parameters. You report the aberrant phenotypic markers on each of the antigens assessed. Report the MRD as a percentage of total bone marrow plasma cells plus as a total of the total as a percentage of the total marrow cells, and target a LOD of 0.001% for which 3 million and LOQ of 0.001% for which 5 million cells have to be measured. There is an option of buying multiple kits, and this is a company that markets the Euroflow kit and gives you the detailed protocol. In this kit, CD38 is in the multi-epitope form, and what is the use of that? The effect is that when you use daratumumab and you try and assess flow MRD, if it's a conventional CD38, it will not bind to the plasma cells, and this is the example with 3 epitopes, and you can see that CD38 binding with the plasma cells is dramatically reduced. However, with a multi-epitope CD38, you can still distinguish plasma cells. What are the alternative ways to address this? There are alternative gating markers which can be tried. So this is CD229. Here in orange, when you look at the gating, 229 is on the y-axis and you have 38 on the x-axis. It is primarily 38 that is still pulling the cells apart and not CD229. So even using 229 alone would not be useful. The second molecule is CD319, and in 319 also, if you look at this CD138 versus 319, it is 138 that is identifying plasma cells better than 319. So we don't have a perfect molecule yet, but using 38 multi-epitope along with these two may be useful. Now with that, there was an attempt to try and see how the experts grade myeloma. So they circulated files of some 8-9 patients across to multiple experts, and when you look at this, in they did this evaluation in 3 stages. In stage 1, they could get an agreement on MRD positive samples in 89%, MRD negative samples in 68% of the patients. By the time they reached stage 3, MRD negative status improved to 74%. Now this tells you that there is a need for standardization in not just doing the procedure but also getting the final thing to get to the value of MRD. So next generation sequencing is the second method that's used for MRD, and this is done by using the clonoSEQ assay, which is marketed by Adaptive Biotechnologies. It was approved for MRD in myeloma and BALL in September 28 by FDA. It uses multiple primer sets. So these primer sets target immunoglobulin heavy chain VDJ regions, IGH DJ regions, kappa lambda, as well as translocations in IGH sequencing. So you amplify all these via PCR, label the patient's PCR products with index tags, and submit this for multiplex sequencing by synthesis using NGS, and it gives you an automated calculation after running it through the bioinformatic pipeline. The adverse points here is that it requires a baseline sample, and the samples have to be shipped to the reference lab. This is not an assay which anybody can start in their own lab. Advantage is that you can use it on archival samples also. So the impact of NGS on MRD can be seen in this IFM DFCI 2009 trial. So originally this trial did MRD by ASO PCR as well as flow cytometry. However, when they updated their data on NGS they did on samples which they had stored. So patients who were NGS negative, they did far better than patients who were positive on NGS. So now if concentrate on the MRD that is less than 10 to the power minus 4. So this is 10 to the power minus 6 negative MRD by NGS, patients doing best, minus 4 to minus 5 to minus 6 and minus 4 to minus 5. So all the patients who were termed as negative by multiparameter flow cytometry could be further divided into better and worse prognosis by using NGS. However, if you look at the arm, this blue arm above, it is seen that patients are still relapsing. What is the cause of these relapses? Possibly the extramedullary disease. So therefore, a combination of flow and functional imaging needs to be tried. So this was the total therapy trial in which they added diffusion weighted MRI and PET CT to the flow MRD, and they saw that patients, so the red is patients who are PET positive, blue is patients who are MRI positive, and these are patients who have no focal lesions. So patients with no focal lesions do very well, and patients who are MRD negative both by flow and imaging do the best, while patients who are positive for both do worst. The other two categories, they are somewhere in the middle. Interesting is that in their series also, not all patients who were positive by MRI were PET positive and vice versa. MRI detected a higher number of positive patients in comparison to PET. So to summarize, MRD is the best determinant of response, and NGS and or next generation flow are recommended. However, for next generation flow also there is still need for standardization. Assessing both the compartments is important if you want to translate this into survival benefit. There is an upcoming role of other modalities like cell-free DNA, circulating plasma cells, as well as assessment of M bands by mass spec, but that is all still being evaluated. So in the future, we may be looking at response criteria just based on MRD rather than looking at CR and VGPR like we've been used to in the past for myeloma. So with that, I thank you for attention, and I'm happy to take questions.
Thank you, Dr. Das, for very extensive and elaborative lecture. Ma'am, you have mentioned that the first sample you have to take, and actually in our practice what we usually do, first 1 ml we used to take for preparing slide, and then we take. So your advice is not to do that.
So my advice is, if you are looking to assess MRD in any of the hematological malignancies, be it ALL, be it myeloma, be it CLL, always send the first pull for MRD.
First pull for MRD.
Yes, because on morphology, if I am to report less than 5% plasma cells, your patient may still be MRD positive at a very high degree.
In that case, madam, what will happen? Because if we take later sample for preparing smear, that might get diluted. So we have to do twice.
So it does not matter.
So we have to.
Oh, so that is one possibility, to do it twice or shift the site a little. But even if your sample is reported as hemodiluted, it still does not matter.
Yeah, because MRD report you are getting.
Yeah.
And
so we look at MRD, and at the same point you can collect a bone marrow biopsy if assessing the cellularity and the rest of the components is the point.
And regarding that, for NGS, you mentioned the 10 ml of marrow sample.
Not for 10. That is for next generation flow cytometry that we need 10 ml of the marrow sample.
For
next
NGS.
generation sequencing, we
But
only need
for
about
flow
2
only
to
2
3
ml is enough. But
so for flow we need 10 ml. If
Flow
you are
10 ml.
going to do the next generation flow, that is we are going to collect 5 million cells per tube.
okay.
For that we need a higher amount of sample, but for next generation sequencing or any of the genomic approaches, even 2 to 3 ml of marrow is sufficient.
Okay. So for usual 2 to 3 ml is okay. Thank you.
One question may I ask?
Yes.
Whether the cell-free DNA in the circulating blood, is it suitable? It is much more specific for detection of MRD in case of multiple myeloma.
So sir, I had 20 minutes and I had to explain these two techniques in far greater detail. But what you're saying for cell-free DNA, there's a contradictory, so there's a contrary literature that's reported. So some people have reported that cell-free DNA performs as well as assessing marrow burden, while there are others which say that bone marrow MRD may be positive while cell-free DNA is not able to pick up the disease. So at the same point in time, the cell-free DNA, if it is positive, it tells you that there is disease and you have to treat that, but it has not reached the standardized stage that NGF and NGS are at this point in time.
Okay, so if there is no more question, we can carry on. Thank you, Dr. Das.
Thank you, sir.
So now I would like to invite Dr. Devmalla Bhattacharya, who happens to be student of our institute and now consultant hematologist in Apollo. And he is going to moderate a topic of monoclonal gammopathy of renal significance. And I will request Dr. Devmalla Bhattacharya to introduce his panelist.
Yeah, thank you, sir, and thank you the BeSHCON organizing committee for arranging this beautiful program and also inviting me as a panel moderator in the panel discussion. So without further delay, I would like to call upon on the stage Dr. Nilanjan Sinha, Assistant Professor, Department of Haematology, ISTM Medical College, Kolkata. Dr. Shilpa Bhartiya, Consultant Hemato-Oncologist, Parkview Hospital and Apollo Hospital, Kolkata. Dr. Jashoshi Chakraborty, Consultant Hematologist, Amri Hospital, Kolkata. And Dr. Malini Garg, Consultant Fellow Hematologist in BMT Center, Actrek, Mumbai. So let us start. So topic is today's topic is monoclonal gammopathy of renal significance. It is a difficult topic because we many times the patients not get proper diagnosis, or when a patient gets the diagnosis may not get timely or proper treatment because of the rarity of the diagnosis. So it's a this term was coined in 2012 or 13, that the main definition, it includes the all proliferative conditions of B cells and or plasma cells such as moldering multiple myeloma, Waldenstone macroglobulinemia and monoclonal B lymphocytosis, and associated with the production of a monoclonal immunoglobulin that is toxic to the kidneys. So there may be a non-malignant clone or a pre-malignant B cell or plasma cell clone causing kidney damage. So from the hematology aspect, the disease may not be so severe, but it is definitely toxic to the kidney. And there is a wide spectrum of kidney pathology and can be categorized according to the ultrastructural characteristics of the deposits by the electron microscopy. I am not going details of that nephrology aspect. And it is quite damaging to the kidneys, and there may be many forms like acute or subacute kidney injuries, CKD, proteinuria, nephrotic syndrome, dyselectrolytemia, like that. And many patients, they may not have any symptoms, and most of the patients will have some nephrotic to subnephrotic range proteinuria. Some may have overt CKD, or when it is very easy, then there will be coexistent multiple myeloma or Waldenström macroglobulinemia or other B non-Hodgkin's lymphoma. So I have just made a fictitious case, and I'll go along with that case. So we'll discuss a patient about 48 years of age, male, non-diabetic. He complained of lethargy, which is quite common at this age group, maybe due to the stress or due to this profession, and he went for a routine health checkup as we always do. On clinical examination, everything was normal except he was having a blood pressure of 150/92 millimeter of mercury. And CBC, it was essentially normal. Urea creatinine was also within normal limit. There is a slight hypertriglyceridemia on the lipid profile. But on the urine routine test, there was protein was 2+, RBC sugar was nil. So the patient was seen by a general physician with these reports. He was given antihypertensive amlodipine 5 mg once daily as usual, and was because of the protein 2+ in the routine microscopy, the physician advised for urine culture, and it was shown no growth, and he was put on wait and watch. So my first question to Dr. Nilanjan Sinha, that if the patient would have not gone to the general physician and come to you, because these patients usually don't come, this type of patient do not come to hematologist. So it is a fictitious scenario that if this patient comes to you, then what would you have suggest for this patient?
Thank you, Dr. Devmallo. As we see, the patient does not have any hematological abnormality on investigations, but he has a high blood pressure, he has a high triglyceride, and he has protein in urine. So in this case, I shall focus on nephrological investigation. I shall advise a 24-hour urine for protein.
Exactly.
A ultrasonography of KUB, or maybe a whole abdomen, because the patient has high triglycerides, so he may have fatty liver. So a ultrasonography of whole abdomen including KUB and prostate. And as the patient has hypertension, I shall also advise a ECG and a echocardiography.
Exactly. So these are the basic tests one should advise with the patients of proteinuria. So first most important test is 24 hours urine protein. So in this patient it was done, and the result was 1.7 gram per day, and USG whole abdomen, there is no ultrasonologically, no morphological kidney disorder, normal kidney size, and 2D echo was normal. Other test was also done, it was in the normal limit, and so the patient was referred to a nephrologist. Now nephrologist advised for workup for glomerulonephritis, serum free light chains assay, immunofixation electrophoresis, and protein electrophoresis from serum, and he also told about need of kidney biopsy in this patient, to the patient. So this diagnosis of renal diseases is usually done with combination of technologies using light microscopy with special stains after kidney biopsy, obviously, immunofluorescence microscopy and electron microscopy. This light microscopy with special stains and fluorescent microscopy with a full complement antibodies is invariably required, because this glomerulonephritis is more common than MGRS, and it is more prevalent in the children as well, but it also quite common in the adult age group. And these renal deposits are morphologically characterized in different ways. I am not going in these details. So these are the just diagram. I am just omitting it because it is not related directly. So there may be immunoglobulin disease or non-immunoglobulin disease. That non-immunoglobulin disease may be due to the complements. And this monoclonal immunoglobulin testing is very important for these patients of suspected MGRS, and it is the first step of this diagnostic skygram is the serum and urine protein electrophoresis. Small amounts of monoclonal protein can also be detected by immunoblotting. Serum free light chain assay has established itself as an important test in this clinical scenario, and the monoclonal immunoglobulin found in the patient's blood or urine, it must match the immunoglobulin deposits detected in the renal biopsy tissues. But for our problem, the many patients, they do not agree for the kidney biopsy. Most of the patients, they just go from this doctor to another doctor. So this patient are found to have increased kappa light chain above the range, normal range, no M band, but on the immunofixation electrophoresis, there is found to be IgA kappa band. So nephrologist referred him to hematologist for opinion. So now my question to Dr. Shilpa Bhartiya, so what would be your advice at this point?
Yeah, hi Bengal. So I think we are dealing with a patient who's got a very small M band and no other end organ damage. He's got a normal creatinine and he's got a proteinuria. So I think, initially before this MGRS term was coined, it would go under the MGUS category because technically we would not call it end organ damage. But I think this patient should have a kidney biopsy to prognosticate his disease. And he should also have his urine checked for electrophoresis and immunofixation, which is very important. And I think he would fit into the category of MGRS needing treatment, but because he has got evidence of nephrotic range proteinuria. So I think renal biopsy documenting the type of renal damage that he has, and I think of course you have to complete your myeloma workup, look for bony lesions. He didn't have anemia and his creatinine is normal at this stage. I think since you found an M-band, we should look for a complete bone workup as well. Myeloma workup to make sure this is not myeloma and this is MGRS. And since the damage has started, it is well worth treating him, but we would do that after the kidney biopsy.
Absolutely. So this all patients should have undergone bone marrow biopsy. Bone marrow biopsy should be done with along with immunohistochemistry and the flow cytometries for clonality for assessment of the clonality of the B cells and plasma cells. And the staining of kappa and lambda chain should be performed to demonstrate that the identified clone exhibits the same light chain restriction as the monoclonal deposit in the kidney. So there should be concurrence within the kidney biopsy, with the kidney biopsy tissue and the bone marrow biopsy. This is of utmost importance because the bone marrow may be absolutely normal or it may be involved. If it is involved, it is very easy for the hematologist to treat, but if it is not involved, then it will be a little bit tricky to treat. So for this patient, bone marrow biopsy was done, and immunohistochemistry as also. It showed 8% of the plasma cells which are non-clonal in nature. There is no light chain restrictions. And the patient did not give consent for the kidney biopsy. So in the ideal diagnostic workup, there should be they have advised for a PET scan or any CT scan to assess any presence of any lymphoid tissue aggregate or lymph nodes like that. But for this particular patient, this is not needed obviously. And also Congo stain from the bone, congruent stain from the bone marrow, it is also negative because amyloidosis may be present silently, so it should be ruled out also. Now regarding the patients are very much anxious about the kidney biopsy as well as bone marrow biopsy. In our day-to-day practice, we have seen that many patients delay their these procedures. So kidney biopsy are quite safe in these patients with monoclonal gammopathy. There is a study which published in 2010. It shows that it's a large number of patients were included. It showed that 1993 patients who underwent either native or transplant kidney biopsies, the major hemorrhagic complications were similar between those with and or without monoclonal gammopathy. Now my next question to Dr. Yashaswi Chakraborty, what is your plan to treat from hematology aspect in this particular patient?
Thank you, Dr. Bhattacharya. First of all, the diagnosis of MGRS is important, and the classification of MGRS is important, that why the MGRS has happened to this patient. If we keep aside this particular case, we should find out whether it's a case of multiple myeloma or CLL or it's a Waldenstrom macroglobulinemia. So if none of this is present, then the plan is something else. If this is a disease-specific renal deterioration, then the plan is something else.
Exactly.
Now, if we can find that there is a background of amyloidosis, we have to be very careful regarding the cardiac issues as well, like monitoring the tropi, the NT-proBNP, etc. Now it's controversial a little bit because though the renal function is deteriorating, the bone marrow plasma cells are still 8% and those are non-clonal as per this case. So it will ever remain as controversy whether to start treatment or not. But one thing we should keep in mind, so far as overall survival of multiple myeloma and MGRS is concerned, in multiple myeloma the overall survival is definitely poorer than MGRS, but so far as the progression of renal deterioration is concerned, MGRS is no less than multiple myeloma. So for me, if I get such a case, possibly I will be starting with some sort of therapy. In the earlier era, they used to start with melphalan dexa. In the bortezomib era, they started bortezomib. If the renal function deteriorates, then melphalan can be replaced by cyclophosphamide. But a triplet regime should be started, because there is evidence that some monoclonal thing is present, as evidenced by the IFE in this patient.
Exactly. So we should treat the kidney, kidney damage rather, because there may be the bone marrow, there may not be any clonal plasma cells, but there is some fictitious clone or hypothetical clone which is damaging the kidney. And if you don't treat the kidney, the kidney damage will be progressing in the nature, and ultimately the patient will land up into CKD. So the aim of the treatment is to achieve remission in proteinuria with reduction of the creatinine levels if high, and to keep the patient non-dialysis dependent, and reducing the chances of a recurrence after the renal transplantation. So these are the scenario where we this should be the aim of treatment these MGRS patients. And the treatment is based on the combination of the chemotherapy agents used to treat either non-Hodgkin's lymphoma or plasma cell disorders, and early and quick initiation of the treatment is needed, and to prevent before the irreversible kidney damage occurs.
Dr. Demalu, I have one question. Sorry, how comfortable would anybody here would to start treatment without a renal biopsy?
Yeah, that is the main point.
I think we should not accept that it's a patient's wish to do the renal biopsy, because tomorrow he gets a side effect of the chemotherapy and you don't have enough leg to stand on. You are showing we have non-clonal plasma cells and we have no other proof of clonality. Yes, this patient needs a treatment, but I would not start treatment if he does not.
Exactly.
Or even if he does, then you have to document it. The patient has refused a kidney biopsy, which is really not that big a complicated procedure, would need more counseling. I think it's dangerous to just start treatment.
In present scenario, it is very difficult. This is the controversial, this is the controversy related to MGRS, as Ashwati told, that even if there is a clone causing renal damage, but it is very difficult to initiate treatment without a proper morphological diagnosis.
Yeah, I just want to interrupt, like there are guidelines for doing a renal biopsy, like if the EGFR is more than 60, no renal biopsy. If the EGFR is 60, renal biopsy should be done if the deterioration of EGFR is more than 2. Number 2, hematuria. Number 3, proteinuria. If these are present, then definitely do a renal biopsy. You may consider renal biopsy if the EGFR is less than 60, but the deterioration is less than 2. There is no hematuria, no proteinuria. So
this is a scenario, same thing. There are many patients who are having acute leukemia or any other lymphoma. They are not any malignant disorder of hematology origin. They are not, if they don't agree for bone marrow biopsy, we cannot start treatment. The same thing applies here, as Dr. Bhartiya told. If the patient has not gone for kidney biopsy, we could not officially start a treatment. So that is the thing, and that is the same thing happened in these patients. The patient opted for wait and watch because he feels fit. He wants to wait till any symptoms develop and promise to be in close follow-up. But this is a very common scenario in our day-to-day practice, that many patients, they defer or deny treatment because the symptoms is not so severe or patient don't feel the symptoms. So this is a very common scenario we face. So my question to Dr. Malini Garg, if would you treat all already this has been discussed, Malini's question has been discussed by others, that would you treat all cases of MGRS, and the follow-up plan, what would you suggest? When I am giving you two options, because if the patient is ready for the treatment and if the patient has not opined for treatment, both scenarios.
So thank you, sir. So the first one has already been discussed, that all the cases need treatment or not. It's still a controversial topic, and yes, if there is some renal involvement is there, proteinuria is there, so definitely some anti-proteinuric therapy has to be given, and if the patient doesn't respond to that anti-proteinuric therapy, then we'll consider chemotherapy. And if there's only the kidney involvement is there's no detectable plasma cell clonality is not there, there's no detectable M band in the serum, then we can put the patient on observation. Also, these MGRS patients, when they're categorized into low risk, intermediate and high risk, accordingly also the clinicians can decide whether the treatment has to be given to the patient or not. The second is follow-up for these patients. Now a patient who is an MGRS, first we have to categorize to which risk category he belongs to. So suppose it has to be categorized on the basis of whether it is non-IgG band or the IgG level, like M band levels are, they are more than 15 gram per liter, or any organ involvement is there or not. So if the patient belongs to a low risk category, none of these risk factors are there, then they have to be followed up at 6 months, and then every 2 to 3 years, after 2 to 3 years, and after that follow-up is also not necessary. So, if the patient develops some symptoms, that time he has to be followed up. And if the patient has even one of those risk factors, then they have to be followed up at 6 months, followed by every yearly. And if there is a sign of progression or any organ damage is there, definitely they have to be started on specific treatment therapy. And then, like how we follow up in the multiple myeloma, every 3 monthly evaluation has to be done. Like when we are treating every 3 monthly, it has to be done with SFLC, IFE, like SPEP, IFE and SFLC.
Okay, exactly what Dr. Malini told, that if the patient is getting a myeloma-like treatment, then the follow-up will be easier for us to decide. And if the patient is having only proteinuria, no other clonal damage to the cells, then only telmisartan or angiotensin receptor blocker and serial follow-up to prevent or to detect progression is enough. So this is all for this part. So to remember, if there is no detectable monoclonal protein in the serum of urine in patients who have monoclonal immunoglobulin disease in the kidney, so the chemotherapy is more controversial, obviously, that we discussed right now. And in patients with normal kidney function, protein less than 1 gram per day, conservative approach should be taken. And antiproteinuric therapy and blood pressure control will be the keystone, key factors to treat the patients. And those who show no reduction in the proteinuria or improvement in the kidney function, a trial of chemotherapy is reasonable. As Dr. Shilpa Bhatia told, that before that we should document everything to start treatment. So this patient did not do kidney biopsy, he did not do any treatment, he just one wait and watch, and ultimately he lost to follow up with the hematologist as most of the normal patients. So he was again referred after 3 years in view of drop in hemoglobin this time. The creatine was raised, it was 3.4, and urine protein was also raised, 24-hour urine protein was 22.5 gram per day. Serum free light chain ratio, obviously it increased than before, and patient has also developed diabetes by this time. So my question to Dr. Nilanjan Sinha, at this point, what test would you advise? The same patient.
Thank you. Obviously, the patient who did not have any hematological problem in investigation previously now has come with anemia. His SFLC ratio has increased, and also his creatinine is increased. So certainly the patient has worsened. Now this patient, I shall begin with the usual investigations for anemia that we hematologists do. We certainly do that. That is a complete hemogram with reticulocyte count, examination of peripheral blood smear and ESR. Then the serum ferritin, iron, TIBC, serum vitamin B12, folate and LDH. And as obviously the patient was previously a known case of monoclonal gammopathy of renal significance, we shall do a bone marrow aspiration, biopsy and immunohistochemistry and a FISH panel for multiple myeloma. And also do a serum protein electrophoresis, serum immunofixation electrophoresis, and SFLC has already been done as is given in the previous slide.
Exactly. Now the workup is for anemia as well as for the CKD and multiple myeloma, because clinically the patient is showing symptoms of multiple myeloma. So the bone marrow, apart from the evaluation from anemia, a bone marrow biopsy has been done, which showed now the plasma cell of 25%, clonality present, light chains are restricted, the immunofixation band is same, IgA kappa, and the free light chain ratio is more than 100. So now the patient is having a frank myeloma. So my question to Dr. Malini Garg, that would you advise again for kidney biopsy at this moment, and what other investigations would you like to repeat or add?
I also, as the patient has high creatinine, I also refer the patient to nephrologist again for his opinion and possibly kidney biopsy if the patient has refused it previously. Thank you.
Now the patient has progressed to multiple myeloma, and definitely multiple myeloma here will be needing the treatment. Our patient had not initially also consented for kidney biopsy, and he'll be needing a treatment. So, and kidney biopsy is going to be an invasive procedure. So I think we can start the treatment without considering kidney biopsy for this patient also, because that will not change our treatment plan. So we have to start some triplet regimen for the patient. And the other investigations which we have to complete the investigations, like we have to go for a skeletal survey now. Another thing is we can consider fish for this patient for myeloma panel, which will risk categorize the patient and will help in prognostication and counseling also for the patient, and help us in deciding the further treatment plan.
Exactly. So one point is that if the patient had not developed clinical myeloma, then would you suggest for kidney biopsy?
If the patient would not have developed myeloma, yes, then we would have, definitely would have gone for kidney biopsy.
Because this patient has developed diabetes at the same time, and diabetes is very common in Indian population, and most of the patients, if they develop CKD with diabetes, we take the patients as diabetic nephropathy, but in a handful of cases it may not be the diabetic nephropathy is the causative agent. This MGRS may be the latent thing within the patient that may causing the CKD component. And now my next question to Dr. Yashashri Chakraborty, what is your treatment plan at present, and would you want to discuss with nephrologist? Again, if this is myeloma only.
Yeah, so far as the diagnosis is concerned, now it's an easier one. Now the patient is no more MGRS. So this is frank myeloma. We have to start therapy for myeloma with this kind of high creatinine, high dose DEXA with bortezomib in the first cycle. Then let the creatinine settle down. Then we can plan our therapy according to the age of the patient, the comorbidity. If we plan transplant, we can plan the treatment regime as well. Regarding discuss with nephrologist at present, I don't think that anybody will dare to proceed without a nephrologist opinion. That's
exactly. But nephrologist, if the patient is not dialysis dependent, the nephrologist role is just to give opinion for the treatment, because the main treatment will be done by the hematologist. But if the patient gets any other complications, then they will be needed much more. And if there is any dialysis, they will be sought for. But for regarding developing from MGRS to myeloma, as such as there is little role of the nephrologist. But if the patient develops complications, then they have a bigger role.
I have one question. If you speak to the nephrologist, how do you debate about the fluid that you have to give? For myeloma, you want to push fluids and they will make you give less than 1 liter fluid. So I don't know, what do you do? Do you give them fluids, or do you listen to the nephrologist and don't give them fluids?
This is always a dilemma. According to your plan, ma'am.
I have to push fluids and we just waited.
So it's a double-edged sword always. So how to my question to Dr. Yashashri again, how many cycles of if the patient does not say body as you told, so how many cycles would you suggest, and how would you monitor, and what is your target actually?
Again, we have to plan whether the patient is going for transplant or not. 4 to 6 cycles of body, check the status. If it's at least in VGPR, do a marrow, take the patient to transplant, because
yes, this is the
multiple myeloma is an incurable disease. This will definitely come back without transplant.
Exactly. So this is our main target is to take the patient, bring the patient into remission, at least VGPR, and go for transplant. So I am not going details of this. So this patient went into remission after treatment by Dr. Yashashri. So normalized free light chain, negative immunofixation, clonal plasma cells absent in repeat marrow, creatine, but creatine is persistently high at 3.0, but not dependent on dialysis yet. So now my next question, or the last question of the session, to Dr. Shilpa Bhartiya, would you counsel for autologous stem cell transplant, and reason behind your advice?
So I think, he would fall into a category of myeloma with the residual renal damage. We know that the disease has been going on for 3 years. So at the outset, we knew that, most likely his creatinine is likely to remain high. There are well-established protocols for doing a transplant with a high creatinine. But again, I think it is worth mentioning that there is a chance that patient may go into a renal failure during the transplant procedure, because the drugs we're using are all nephrotoxic. So yes, you want to try and eradicate the plasma cell clone, and autologous is the best way to try and keep that at the minimum. So you would do it, but it would fall into a high-risk transplant category.
So this time we have to take all opinions from nephrologists every day, yes. And if the patient is successful, if there is successful autologous transplant, then what will be your call for the role of kidney transplant in this patient and its timing?
So since the clone is in, that's a bit controversial, it's plus or minus. Some of for that you would need a kidney biopsy to see kind of how bad the kidney damage was, what was the pathological diagnosis, because there are certain disorders which can even affect your transplanted kidney. Currently, he is not on dialysis. Post-transplant, if he is not requiring any dialysis, he may sustain like that. So immediately there will be no need to do the kidney transplant. In fact, it works vice versa. The pathological origin is in the bone marrow and not in the kidneys. So, you know, once his plasma cell is under the control and he is not dialysis, I wouldn't go for a kidney transplant at this stage, for sure.
Okay, sure. So that is the point, that MGRS recurs very quickly in the allografted kidney. So before doing kidney transplant, you always should do bone marrow transplant. And eradication of the B cell or plasma cell clone is a must before going for kidney transplant. And the role of treating patients without detectable monoclonal gammopathy to prevent or prolong recurrent disease after kidney transplant is not known. Suppose this is a fictitious condition that the patient has got both transplants, and the patient is still in remission. What will be your call that it is not so documented, or there is no such studies to suggest? So this much. So to summarize that, MGR is apparently indolent disease, but definitely progressive and toxic to the kidney. And the series of investigations are needed to reach the diagnosis. That is the main problem, especially the part of kidney biopsy. It is often masked by other diseases like diabetes and other causes of CKD. The target of treatment is a B cell or plasma cell clone eradication, and the relapses do occur in the kidney allograft if it is not treated by, if you don't eradicate the plasma cell, which is of the most effective treatment option for this MGRS. So thank you the panelists for their time, and also the BeSHCON organizing committee. Thank you, sir.
Thank you, Dr. Bhattacharya and the panelists. I think we should conclude this session. We are already running late. Thank you. Thank you.
Thank you.
Thank you. Thank you very much, speaker, chairperson, and panelists, for sharing your profound knowledge with us. Ladies and gentlemen, now this is the time for the refreshment tea break for 20 minutes. We will be resumed here by 5:30 p.m. Before that, I would request all the delegates kindly check out our attractive stalls displayed in the next room. Thank you.
So who are doing post-graduation right now in pathology, medicine or pediatrics, who are interested for quiz tomorrow can enlist their name right now. So those who are interested for quiz tomorrow at 10 a.m. in the morning, so please enlist their name by 6 p.m. today.
Hello.
Very good evening, everyone. Welcome back. With the spirit of show must go on. Now move on with the fifth session, topic hematopathology, based on the theme behind scene wonders. Consequently, I would like to invite upon stage the first chairperson, Dr. Arnav Chattopadhyay, Associate Professor of Hematology, Department of Hematology, NRS Medical College. Welcome, sir. And our second chairperson, Dr. Atashi Basu. I would like to request our chairperson kindly invite our speakers.
So we start without delay because we are running late. Our first speaker for the session is Dr. Sudipto Rai. Dr. Rai needs no introduction. As a renowned pathologist who has served this city, has been serving this city for quite a few decades with great repute. So I would request Dr. Rai to start his talk, Bone Marrow Examination, Old is Gold.
Thank you, Arnav. Thank you very much. So at the outset, let me thank the organizers. Not much of audience is there for two reasons. One is to start the physical conference, and second, to have the guts to have a hybrid mode at this point of time. And we all felt during the tea session that meeting each other for conferences really says that old is gold. So the topic given to me was bone marrow morphology, old is gold, and I tweaked that. It should be examination and evaluation. See, examination is when you have the pathology seen, evaluation when you put all these findings to come to a diagnosis based on the clinical findings, the ancillary findings, and so on and so forth. So the first thing is, why do a marrow examination? I intend to be with the students, but none of the students are here for the DNB. So why do a marrow indication? As a pathologist, I leave it to my clinicians. I really don't make a fuss of the indications. But what's more important is, what is the problem that my clinical colleague has faced to do a marrow examination? What is the question he asks me, and what are the answers he expected? So these are very important. He might have something. Say, for example, if he's treated the person for a chemotherapy for some disease and he wants to see the presence or absence. So inclusion, exclusion, and a new finding. So you might say, yes, this is there. You might say, no, there is no metastasis, or it's not in remission. And if you have a new findings, you should be discussing it for a diagnosis. So that's the basic approach I take. So when you do a bone marrow examination, it consists basically of aspiration and biopsy. By and large, aspiration, we see cell morphology, enumeration of marrow cells. And for biopsy, you see the optimum cellularity, fibrosis, infections, or infiltrative diseases. Like this is a smear when you start off with the particle and the trails. In the biopsy, you see the architectural disposition. Here you see, like for example, in a jungle, you see the tree, and here you see the wilderness. And both together has got an advantage of diagnosing. So bone marrow aspiration has got a better cytological details, and the material that you aspirate you can use for cytochemical stains, mycobacterial culture, flow cytometry, cytogenetics, and all molecular studies. For a biopsy, the assessment of cellularity is very important. That's where you do here. You can detect lesions which are like granulomas. It's very difficult here other than doing a clot culture and clot biopsy. Assessment of plastic anemia, fibrosis, metastasis, you always need a biopsy. And archival material from biopsy is easier. So as a routine, the practice is do an aspiration and biopsy as a routine, unless contraindicated by my clinical colleagues who is treating the patients or seeing the patients or following the patients. But a 5,000 platelet count is not a contraindication. It's only an indication that you don't know the procedure. So all ancillary tests, that's very important, you know, immunophenotyping, cytogenetics, FISH, molecular studies, they need to be planned before, because you need to have the material as you draw. So this planning and triaging is important, and that's where before you do, you need to talk with your clinical colleagues. So normally the biopsy indications, I think nowadays everybody is almost doing biopsies on aspiration, but these cases where you require to biopsy is cases of hypercalcemia, lytic lesions for plasma cell neoplasms, lymphoma staging, infection, when you're looking for granuloma, PUO in our sort of setting is very common. Metastatic, here you can send it for cultures also. Metastatic workup, small cell tumors of childhood many times has been seen in biopsy, in aspiration, and biopsy can pick up with immunohistochemistry. Mast cell disease, we only diagnose mostly in biopsies. ITPs, primary amyloidosis, metabolic bone disease, and therapeutic follow-up chemotherapy, bone marrow transplantation, or treatment of isolated cytopenias is one of the preferred sites. And because I said I'm sticking to very basics, what are the sites? The site selected with aspiration depends on the age of the patient, because in the children younger than 18 months, the tibia is very important because that's where the active marrow is. And if you're looking for Gaucher or for infiltrative disorder, this is the common site, and I have been rewarded by using this site. But other than that, we use the posterior iliac crest. Sternum is almost gone nowadays because of obvious reasons. And under 12 years, we also have the iliac crest. So any site in the axial skeleton and the proximal extremities are areas, but the commonest is what we all know. So as I said, you have to do, so where do you look at? First, look at the particle, then the cell trails, then identify the morphology, going from a low power to a higher power in a gradual sense, and see every quarter. So first and foremost, you look at the cellularity, both here and here in the biopsy. So cellularity is what we are talking of. I think I'm going back, sorry. So what is cellularity of the marrow? This is expressed as a ratio of the volume of hemopoietic cells. Therefore, it means the bone marrow has also got a non-hemopoietic cells, which are your stromal cells. Very important, the fat cells, the spindle cells, and the endothelial cells lining the sinusoids. Do you consider them in your cellularity? You might have an aplastic anemia, a lot of spindle cells and fat cells. They are not. So therefore, the volume of hemopoietic cells vis-a-vis this would be an important thing for cellularity. So it's just by comparing the areas occupied by fat cells by the other nucleated cells. So what you exclude is the other nucleated cells, which are spindle cells and non-hemopoietic origin, as morphologically described. So how do you assess cellularity? You make a smear, you drain the blood containing it, and these are the particles, and you see along the trails. As I said that, for cellularity assessment, this with this, but I would prefer this, the biopsy as a better assessment. So you see the increased cellularity, the normal cellularity compared with the fat cells, and sees more of fat, less of cells, hemopoietic cells. So that's how you assess. Now cellularity, you got a rough estimation for the postgraduates is 100% minus the patient age. Say for example, the patient age is 50, so 100 minus 50, 50 plus minus 10, so around 60 to 45 or 50% would be a normal cellularity for that age. So we always mention cellularity. So if it is 80%, 80 is the patient age, so 100 minus 20% of the hemopoietic cells of the marrow becomes a normal cellular for that age. So this is how you assess in the biopsy. You see the fat cells and you see the hemopoietic cells, and this would be a normal cellular for that age of 35, 40s. This is a hypercellular for almost any age. See, the hypocellularity actually gradually contains. This would be the extreme case where you hardly find the hemopoietic cells. So you feel a lot of these spindle cells, fat cells, stromal cells, mesenchymal cells. Here you see increase in fat cells. These are megakaryocytes. And you see there is a relative paucity of the hemopoietic cells. So that's how you describe cellularity. Another important thing is your myeloid-erythroid ratio. This is very important because you see, I'll give you a concept. Wise, if you see this in hematopoiesis, this is your pluripotent cell. This is your common progenitor cell, and you're doing a myeloid is to erythroid ratio. But normally, what you do in a myelogram, you also take a lymphoid cells. So therefore, what you're doing is basically collecting this, which is a different cell group, into your thing. Similarly, do for monocytes here, which has got a thing. So in a case of plasma cell neoplasm, where there are more than 20% plasma cells, what is it? 20% of what? I would say in that case, you do a non-erythroid to erythroid ratio, where you count all these cells versus these cells to assess the amount of hematoerythropoiesis vis-a-vis other cells in a neoplastic disease of nucleated cells. Because this correctly you should not come in your hemogram. So that is how you have to tweak the myeloid-erythroid ratio in the disease status. So now we come to hematopoiesis. Now the commonest one is an anemia, is where you do a bone marrow, and the algorithm is, once you have an anemia, when you go to the bone marrow, see whether it's hypercellular or hyperproductive or it's hypoproductive. Then you see the MCV. If it is high, then you are megaloblastic, you will be qualitative changes. This is quantitative change. And you see the myelodysplastic syndromes, liver disease, thyroid. In a normocytic normochromic, where NCV is normal, is chronic inflammation, hyperplastic anemia, or infiltration. In a low MCV is the usual microcytic and microblastic. So this is the qualitative changes. Now you see in a megaloblastic, you have a nuclear changes. In an iron deficiency with a dimorphic, you have micronormoblast, fraying of cytoplasm. It's more of a cytoplasmic changes. So therefore, your morphological interpretation is important. Then you correlate with the nutritional profile of the patient. So you see erythropoiesis now. The thing is ticking, so we need to see. You know all this, the qualitative changes is very important, and this is where I think bone marrow aspiration is very important. You can see this nuclear bridging, the nuclear changes, the fuzzy of the margins, and this is a dyserythropoiesis. Similarly, you can see there are lots of changes. Just to mention one here, see this is a clover leaf type of a nucleus in the NRBC. This means an atypical mitosis. So you have an aneuploidy is a neoplastic connotation, but a diploidy is a reactive condition, may not be proliferative. So these morphological findings of a nuclear ATP, a nuclear multiplication, other than, I don't think you're going to consider CDA over here, but a morphology has to be fit into your clinical setting to come to a diagnosis. So evaluation and examination has to go at par. So the qualitative changes in erythropoiesis are very important for a myelodysplasia and a myelodysplastic syndrome. On the topic of myelodysplastic syndrome, see the megaloblastoid erythropoiesis. Then you can see dysgranulopoiesis. See here you can see a giant myelocyte. You can see a neutrophil which has got hypogranulated, doesn't have a granule. You have a metamyelocyte. So this is a pseudopellular anomaly of dysgranulopoiesis. Then when you have a myelodys, you have to look in for the blasts, because you know at various stages of blast maturation, the classification changes of MDS. Similarly, when you have the biopsy, you can see it's a hypercellular, so hyperproductive in the phase of cytopenia. You can't really assess the qualitative changes of the erythropoiesis or dysgranulopoiesis, but you are here looking for immature cells for something which is known as abnormal localization of immature precursors, the paratrabecular region, which is the morphological hallmark of MDS. So as I said, the nuclear changes are very important, and the hypogranular. And this megakaryopoiesis, I forgot to show you, is also a marker which you can identify in the biopsy segments better. So coming to granulopoiesis, here you have to understand that in this state, you can have both qualitative and quantitative changes, but up to this, you have a proliferation of the cells. After that, there's a maturation. So proliferative is the leukemic stages, and the maturation is proliferation. With maturation is your MPN, and with dysgranulopoiesis, your MDS. And all together is MDS MPN. So morphologically, you can't really come to a conclusion. One of the features in a dysgranulopoiesis sometimes, but rarely, is a round neutrophil, and you see the other qualitative changes which is happening. This would be an NRBC, this would be a myeloblast, and a dyserythropoiesis feature. So morphology does have a very important thing, and this granulopoiesis, as I said, hypersegmented, pseudopellular, this, spectacle nucleus, hypogranular forms. In the precursors also is an important qualitative feature only seen in morphology for diagnosis of MDS. But when there is a proliferation, you have all immature cells, and this is one morphological hallmark is your OR rod. But when we see this sort of a thing, we naturally, reflexly go for immunophenotyping. But you can give an early impression to your colleagues that this is a proliferative leukemia. You might not be able to subtype many a times, and just to show that various types of things. But this is one morphological hallmark of faggots and OR rods, which is promyelocytic leukemia, and this you can surely say that to start the treatment or at least plan for the DIC treatment. So morphology does help, but ancillary treatment like undifferentiated like here, you really can't say excepting saying that it's acute leukemia, and so immunophenotyping and the other ancillary treatment for prognosis becomes important. M6, this is again important for morphological diagnosis. And I think, therefore, but when it's CML is very clear-cut, you do for the cytogenetics. Thrombopoiesis, we all know the normal thrombopoiesis. This is where you can see abnormal megakaryocytes in a dyspoietic maturation of megakaryocytes, where gradually you see the nucleocytoplasmic ratio, like the other systems, goes out. And ITP, you can see the proliferation. So therefore, what are you assessing? The quantitative and the qualitative aspects of all the 3 cell lineages to come to your diagnosis based on the peripheral blood and the clinical findings. So we come to the non-hemopoietic things. So we can also, in a biopsy, having a granuloma, I don't think you can have it in others. I just finish in a minute. So histoplasma granulomas are that soft granulomas, and histoplasma can be located out here in the sinusoids. So the next is LD bodies. These days we don't see LD bodies. You can find it on trephine biopsy as well as bone marrow aspiration. Then you can, many times, as I said, storage disorders. You can't really pinpoint, but this sort of a large histiocytic cells is a helpful diagnosis for in aspiration as well as biopsy. This was Gaucher. So, and finally, to end, I would say that what I give a concept is bone marrow is a factory, and what we look at is the peripheral blood, which is the showroom. Any problem here, hypoproductive will be hyperproductive here, hyperproductive here, but hypo here has got a problem in the transport, so hemolysis, this thing, or a hypersplenism or consumption is a point. And so the bone marrow, where you see the bone marrow, you need to do everything, and you should see the peripheral smear. Without that, please don't interpret a marrow, aspiration, biopsy, peripheral smear, and all the clinical findings and things. Just few interesting pictures of lead toxicity, basophilic stippling, bone marrow, and then you have an arsenic toxicity. You see the qualitative changes of erythroid cells and the nucleus. So it's a context of arsenic toxicity. So what I'm trying to stress is morphology has to be interpreted in the context of the clinical picture for coming to a diagnosis. So we all knew about the chloramphenical age, the vacuolated thing. So thank you. I think morphology still has a role to play with all the new things, and it has, you can't really give it up. And you need to follow it in a strictest sense, even when the immunophenotypic and genetics are there. Thank you very much.
Thank you. Thank you, Dr. Roy, for your extensive talk on bone marrow morphology and assessment. And now I request the audience, any delegate or any faculty wants to ask. I allow only one question.
Comment, see, the immunohistochemistry has now become a part of the interpretation. Like the previous session where Dr. Devmalu said 8% plasma cells, no real M-band, but if you do 138, that's what the normal thing, we do a kappa lambda and a 138. We did have, Joshua would say, same sort of a picture last week only, where there was a kappa restriction. So therefore, morphology, because plasma cells are not well delineated from lymphocytes in a trephine biopsy, if it is not well preserved, do a 138 and kappa lambda to exclude monoclonality, and you are rewarded many a times. That's number one. Second point is my observation, Deepak can share also. I have never seen an amyloidosis developing on a multiple myeloma or a plasma cell neoplasm when the light chain was kappa. Light chain lambda has got a more propensity with these isotypes to form amyloid rather than kappa things. And the case which was shown is kappa, so I just wanted to share that diagnosing amyloid might be very invasive, but looking for your blood picture and morphology, it might be helpful. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. May I request Dr. D.K. Mishra? Dr. Mishra also needs no introduction to the practitioners in this city, to the dais to render his talk on digital morphology.
Very good evening to this august audience. At the outset, I must thank Professor Tufan Dolai, Subranil, and their able team to have put in place the BeSHCON 2022. And I'm delighted that after 2 long years, we are meeting people in person. So far, it has been phone calls or virtual meetings, which wasn't very exciting. And it is hope it remains this way, and we continue to have physical meetings throughout the year. So the topic that has been assigned to me is digital hematology, what is the future perspectives. There it appears as digital morphology. So in 15 minutes, I will try to take you through and give you a brief overview of what exactly this means and what is there for the future and how this technology is going to improve upon. We all know that artificial intelligence, machine learning, deep learning are the order of the day, and sooner or later you have to adopt it to your clinical practice. You have Tesla, which is a company which produces pilotless cars. Google is trying pilotless cars. Other day in the news there was a helicopter moving around without a pilot. So sooner or later you will have, I'm not saying that you will become redundant, nor the clinicians, nor the hematopathologists, but I think these will complement in our interpretation of the bone marrow and the system of hematology. Greetings from my hospital, Tata Medical Center. We have DXH 900. This is the platform that we have for CBC, which has got a automated slide maker and stainer. And the next platform that you see is a platform called CellaVision, which is a digital hematology platform. And before this came, there was a company called Bloodhound, which used to have a similar platform. And Bloodhound was taken over by CellaVision, and now CellaVision is a company which produces digital morphology. What we do is that we do about 600 CBCs a day, and we have a slide review criteria. Anything that goes into the machine, and if it fulfills this slide review criteria, it goes into the automated slide maker stainer seamlessly, and the slide is prepared. Till date, we have fellows in laboratory hematology who used to see these peripheral bloods, and they've authorized the results based on their manual assessment. Being an oncology center, thrombocytopenia, leukopenia, neutropenia, anemia is extremely common in our practice. So if we can reduce the number of slide examinations, that will go a long way in increasing the efficiency of the laboratory. And CellaVision is in that direction. I'll show you how it has helped us and what exactly is this. So we also have a DXS 800 with an automated slide maker stainer. So 3 platforms, and that distributes the workload in the day. So what is digital hematology? You know, if you see the typical workflow in a laboratory in hematology, you can find that a sample comes, you put it into the hematology analyzer, and then it goes into the LIMS or into the electronic medical records. And if slide is prepared, then it goes into the to the technologist or to the fellow for validation. But times are changing. So instead of the fellow seeing it, if it goes into the CellaVision, then 50% of it will get sorted out by the cell vision platform, and only 50% will go to the fellow for identification of cells. I'll just skip this. So what are the challenges that a hematology diagnostic facility that faces today? So you need to constantly innovate and change. So the pressure to do more with less numbers, the need for greater levels of consistency in reporting as well as standardization, shortage of skilled personnel, need for newer levels of connectivity and remote access. You know, there are places where you need expertise to be delivered from big cities. So tier 2 and tier 3 cities need attention from tier 1 cities. Demands for shorter turnaround times and faster services to physicians and clinicians. Need for greater levels of traceability and quality control so that the quality of hematology diagnostics improves. So these are some of the challenges that we face on a daily basis. So this is the objective of the cellular vision, which is a 100x objective. Oil is dispensed and the slide is examined. And this is the heart of the machine, and the principle of cell capturing I will just show you. So there are various types of relay tubes, and there are objectives which is only 100. So what happens is that when you have a 10x objective and 1x relay, it has a 10x magnification. So this cellular vision has 10x, 50x and 100x magnification. I will skip this to save time. So this is the slide, and the area of this slide that gets examined is already annotated, and you will see cells like this. So what happens to WBCs? So when you analyze WBCs, it defines the WBC monolayer, and it percolates items, and it relocates the items at 100x, and then subsequently analyzes that. It prelocates at 10x and then analyzes it at 100x. RBCs get analyzed at 50x. So it has various parameters of analysis. One is it does autofocusing, it does a segmentation analysis, it has features of extraction, it has artificial neural networking, and that classifies the cells, and there is image enhancement, and finally if you want to store these images, they are compressed and stored for future analysis. Or for remote connectivity, you have to compress it and then send it. So you have to, as I mentioned, you pre-locate, you pre-classify for characterization. And here you can see that one such cell is under the objective, and you see the hazy picture, but finally it will auto-focus. So automatic focusing is quite patented to this technology, and it takes about 10 to 20 images and then analyzes through an algorithm and then produces a very clear image that you see on the screen. So like this, you have a slide which has many neutrophils, and all the neutrophils gets assessed. So next is the segmentation. Like here there are one eosinophil and one neutrophil, and it is getting focused, and a segmentation is performed, and more than 350 features are calculated. I'll show you that. So what happens? In the feature extraction, you have the form, the color, the texture of granules, the detection of vacuoles, the Markov probability function analysis, and the wavelets that are generated in the machine. So this is the feature extraction. You can see that when a cell comes under the objective, it is analyzed in this way. You know that currently in artificial intelligence, even children are learning coding. So something like coding happens here, and you annotate the cell that this is a neutrophil, which is already in the brain of the platform. So artificial neural networking is exactly like human brain, but it massively, just like you have next generation sequencing, which Mayur is going to speak in the next talk, there is a massively parallel brain function. So Lot of data has gone into the hardware of this particular platform, and the artificial networking, which is a very powerful data mining tool, and that enables to capture and represent complex input and output signals to analyze an image. So this is artificial neural networking. You can see that there are 360 features based on 6 main groups, which you can read it from this slide. And ultimately, all these cells that are down below, they get recognized. So finally, the image processing happens. The images are normalized and enhanced after they have been pre-classified, and images are compressed after they have been pre-classified. So image formats are in JPG. So just for an example, 100 WBCs will have 3 to 4 MB space because of compression, and 100 WBCs with RBCs will have about 4 to 5 MB space after compression. So now I come to the screenshots of this particular platform. You can see that this is a classic view of WBCs. You can see that varieties of neutrophils have been captured. And on the left-hand side here, you can find that you have all the parameters. So this is again another WBC view for an example. You can find all the WBCs that has been imaged, has been captured, including the normal ones and atypical abnormal ones. These are few images that we have taken. In a patient of myelodysplastic syndrome, you can find the significantly dysgranulopoietic neutrophils. You have a ring neutrophil and you have Bijar-Sepid segmentation happening with hypogranulation. So all the features of myelodysplasia are seen in this dysgranulopoietic neutrophils. So these are the advantages of these. So here, this is another slide where you can see that there are atypical myeloid cells along with the neutrophils, and it will separate out, will take the coordinate of the cell in the slide. If you want to manually examine it, you can do that. But it will, on the screen, you can see it, and the fidelity of these images are such, it is as good as looking under the microscope. Here again, you can see that this is a WBC classification view. Another such. So here, what happens is that if you have a cell like this, which is there in the first box, it doesn't match with any of the pictures that you see on the right here. They're all blasts, which are in the brain of this particular platform, and this cell is not identified whatever number of images that this machine has. So this has to be examined manually. So the machine will annotate manual examination of this morphology. Similarly, this is a slide from a patient of acute promyelocytic leukemia. So here I have clicked promyelocytes, and all these promyelocytes have been arranged here, which are seen in the peripheral smear. So this is how you can annotate the cells, and you can analyze it within a very short time by rearranging them in one particular screen. So this is how it happens. The RBC area, the WBC area, the monolayers, and each 50x image is pre-characterized. Only non-overlapping cells are pre-characterized, which is about 90 to 95% of the cells. Decision tree used for RBC pre-characterization, and advanced RBC morphologies are characterized by the artificial neural networking. So that's RBC analysis. I'll show you the pictures. You see all these different types of RBCs can be identified in the Cell Vision platform. You can have based on morphology, based on cell types, and based on inclusions. So all these can be annotated in the screen. I'll show you that. You see, this is what exactly you can see that these RBCs are seen like this. And if you want to have the characteristics of these RBCs defined, you can click any of these. You can click target cells, you can click poikilocytes, you can click fragmented RBCs, and beautifully it shows. So here you can see that we have clicked target cells. So the entire smear will only highlight the target cells. Similarly, if you examine the teardrop poikilocytes, you can see that the teardrop poikilocytes have been highlighted in this smear. This is just one frame. You can go into multiple frames and keep selecting the teardrop poikilocytes. So frame after frame, it will show you only the teardrop poikilocytes. So this is, yes, I'll just finish. And this is fragmented cells. You can see that. I'm not able to see it. Just I think I have a couple of more and then I'll end it. So this is actually the parasite, and you can see that the parasites have been highlighted in the smear. Okay, you can see it in a higher view that the red cells have Plasmodium parasites. And this is how you can calculate what all different abnormalities are seen in a particular smear that you're examining. You are having target cells, cystocytes, helmet cells, sickle cells, spherocytes, elliptocytes, ovalocytes, all these can be characterized. And this is one where you can see that the poikilocytosis is also highlighted by selecting the poikilocyte cystocyte. This is one area in our hospital we are very fortunate. Post-transplant thrombotic microangiopathy is very important to be identified. And even we quantify the fragmented cells per microliter as part of the management of post-BMT thrombotic disorders, whether cyclosporin induced or as it is post-BMT. Target cells, you can see all the target cells annotated in this smear. So this is the teardrop cells. You can find that there are large number of teardrops. So similarly, you can have platelets. This is another important area where you do manual examination, but you can precisely count the platelets through cellular vision. It will give you a screen like this, the platelet analysis views, and you have a calculation which has been marked red. There is a calculation 3 into 3 into the high power field per square. So this is extremely important. So instead of making a visual eyeballing effect on this smear, you can quantify the platelets where your platelet histograms are erratic and you want a manual count. So that is all about my last slide, what you can do it. You can use it for remote reviews, you can use it for expert reviews as a hub and spoke model, and you can have a centralized review hub also when you have a chain of hospitals in the same group of hospitals. So the use of this platform is enormous, and it is an evolving field, and I think more and more centers will gradually use it and will take the advantage of digital morphology and digital hematology. Thank you. This slide I always show. This is the Ladakh war zone. You can find the soldiers pretty happy there. Morale is very high. And on the background you see not a blade of grass grows there, and they live for years in those environments. Thank you. So we must look into the future, and thank you very much.
Thank you, sir, for your very lucid and excellent talk on digital morphology. So, as due to short of time, I request any delegate or any faculty for only one question to Professor D.K. Mishra. Anybody from the audience can ask a single question. So, thank you, sir, once again, sir.
Thank you.
Now, I request Professor Arnab to for the next.
Thank you, Dr. Mishra. Now, I would request Dr. Mayur Porihar to deliver his talk on next generation sequencing, practical tidbits.
Good evening, everybody, and I would like to thank the organizers for having me here. Yes, it's a pleasure to be in a conference which is not virtual. So for next 15 minutes, I am just gonna teach you certain basics of NGS. And when I talk about basics of NGS, it is not possible for me to cover this topic without talking about the basics of Sanger sequencing or PCR, because you just can't make a jump straight away to NGS. So all of you know, for all this while, we've been using Sanger sequencing, and yes, we do use Sanger sequencing even today when you want to look for mutations in a single gene. There have been issues with Sanger sequencing. Yes, it's slow, it is laborious, and I'll show you what are the issues of Sanger sequencing where your next generation sequencing actually trumps it. But let me tell you, Sanger sequencing still remains the gold standard. And when you want to validate a mutation, which you've picked up by next generation sequencing, you go back to Sanger sequencing and then validate your mutation. NGS, or next generation sequencing, it's a massively parallel sequencing wherein you actually have millions of small fragments of DNA or RNA. They are immobilized on a solid surface, they are amplified, and they are sequenced simultaneously. Now, when they are being sequenced based on different platforms, signals are given which actually give you an idea what nucleotide is present. So the signal can either be a fluorescence or it can be a change in the pH based on the platform. And every time a new nucleotide is incorporated, you will get that signal, and that gives you the reading and say, okay, it is A, T, G, C, and so on. Now you must understand here, you're gonna use short reads, right? So you won't be able to actually pick up large copy number variations when you do sequencing. For that, you have to use arrays, which Saurabh is going to show next. And then what you do is you have these reads, you align them, and the analysis is computationally intense. So the brief history, well, it all started with Jay Shendure's lab, wherein they started with the multiplex Polony sequencing, and then Solexa came in, and that was sold to Illumina, and the Roche, then later the ion torrent machines came in. But before I move on to sequencing, the first thing you need to do is to isolate the part of the genome you actually want to sequence. And how do you isolate that? You isolate that there are various ways, but one of the most basic techniques of molecular pathology or molecular genetics is PCR. Now what is PCR? PCR is nothing but photocopying. So you're actually photocopying a segment of DNA or RNA, what you want to study. So if you remember, when we were students, we would take books to photocopy machines and we would ask for photocopying. So what we would do is we would put 2 paper tags on either side for the area we wanted to be photocopied. So those are your primers. So your primers are those tags which actually mark the area of the genome you want to amplify and study. Then you have the DNTPs, which are nothing but nucleotides, and these is like ink. So the ink used in the photocopy machine. And the tag polymerase is the one that actually replicates the DNA, is like the light you have on the Xerox machine. So basically you are just photocopying the area of the genome you want to study. And that is how you decide what you want to sequence. You want to sequence a single gene, you want to sequence the whole exome, the DNA, the whole genome, or the targeted genes. So I just want you to focus on one point here. When the nucleotides actually are added in a PCR reaction, you have this hydroxy here, and they actually connect through these hydroxy ions, and this is extremely important for the elongation of the nucleotide chain. If you do not have this hydroxy, the elongation of your, the sequence will just stop. So keep that in mind. So Sanger sequencing uses this very same property when you do sequencing. So what it does is, you have a deoxynucleotide and then you have a dideoxy wherein you have knocked off this OH. So every time a nucleotide without an OH comes, the synthesis stops. And that is how you run these products on a gel and you get the sequence. So every time the deoxynucleotide triphosphate comes and the synthesis stops there. And that is how you can actually get the sequence on Sanger sequencing. Today we use capillary electrophoresis, which is nothing but the same electrophoresis, but here we are using fluorescently tagged DDNTPs, And every time a DDNTP comes, it stops, gives you a fluorescent signal, and you read it. So this is how your electrophoregram looks. Now what are the problems of Sanger sequencing? Now look at this DNA. This one gene is mutated and the other gene is normal. So when you do PCR, you have duplication of both the copies, the normal gene as well as the mutated gene. And when you do Sanger sequencing, if the mutation is less than 20% or 30%, it is going to be very difficult for you to read here. So you see this is the mutation. Suppose they were both, less than 20%, you wouldn't get this, you would get a very small one. And then it becomes extremely difficult to interpret a Sanger sequence. And this is where you have the advantage of next generation sequencing. What we do in next generation sequencing is you take the genome, you break it down into small fragments, you sequence these small fragments simultaneously. You use bioinformatics, computational methods, and you realign the whole sequences, and then you read the sequences. It sounds simple, but it is not. So what are the basic NGS workflows? You do a nucleic acid extraction, you prepare a library. So what is a library here? A library is actually enriching the part of the genome you want to study. You add adapters. Now every platform has adapters which are specific to that platform. So you add adapters so that this DNAs could go and actually hybridize or sit on the platforms, and then you add barcodes. Barcodes are to identify samples. So those are barcodes. Suppose you are sequencing 50 patient samples in one go. Each patient will have a different barcode. A barcode is nothing but a sequence of nucleotide which is specific for that patient. And you keep, say ATCG is patient A, ADDG is patient B, and so on. And then you can put those barcodes, and that helps you to identify the patients. You sequence them, and then you analyze them. So it's, as I said, you amplify the targets, you partially digest them, you ligate them to the adapters, create a library pool, and run it in your sequencing machine. Now there are many types of NGS libraries: entire genome, whole genome sequencing. All coding genes is exome sequencing. RNA is full transcriptome, and using a selected area of genome is targeted sequencing. Now there are different NGS platforms, as I said. How do they differ? They differ in the design. They differ in the chemistries. Basically, the way the DNA is sequenced and also the signal what they give differs. So it all started with pyrosequencing. Then you have fluorescence sequence by ligation. Ion torrent uses a change in the pH. So the amount of pH that changes for each nucleotide is different, and that is how you get your reads in an ion torrent. So these are the tech specifics of common NGS platforms. I won't go into the detail, but I want you to know that the runtime is different, the accuracies are different. Each sequencing platform has its own error rates, and the amount of data it can generate is different, right? So depending on what question you are asking, you could go for a smaller sequencing platform, or you could go for a bigger one. I want you to understand certain practical terminologies. Read is nothing but a sequencing part of DNA fragment. A read length is number of base pairs sequenced from the DNA fragment. So you have short reads, long reads. Now coverage. Coverage is the number of reads that span a particular locus. For example, when we were students, so we had to read a chapter. So the question was, have you covered your syllabus, right? So you would have said, no, I have left this part, right? So when you talk about coverage, for example, you are aiming to cover 50 genes. Are all the 50 genes covered? Or there are areas in those genes that may not be covered properly, right? So that is coverage. Depth is average number of times a base is covered. So how many times have you read your chapter? You've read it 10 times, 20 times, 50 times. The more number of times you read it, the better you will remember, the less will be error rate, right? So this is what is the depth of an NGS. So depending on question you're asking, for example, if you're asking for a germline mutation, you do 30x. That should be enough. But if you're looking for a somatic mutations, because you also have normal cells, you will have to increase the depth of sequencing to at least 1000x to actually pick up a mutation that is being caused by a cancer. Uniformity, how uniformly it has been covered. because there would be areas in the genome where the coverage will not be present. There would be certain areas which will be covered. So sometimes when we report our NGS, we say, okay, that say exon 2 was not uniformly covered. We haven't found any mutation, but we give a disclaimer that in this run, the exon 2 of say TP53 gene was not covered uniformly. So we don't know if there are mutations in that area. And variant allele frequency is the fraction of reads that are containing the mutations. So for example, you have 10 reads, out of which 5 are normal and 5 show mutation, 50% is your variant allele frequency. So the advantage of NGS is you get individual molecules, and you can sequence every single DNA fragment separately. So unlike Sanger's, you get a readout of every single molecule of DNA here. So you see these are the normal sequences, and these are showing the mutations. So the same case on Sanger's, you cannot identify the mutation, but on NGS, you can actually identify this because you're getting reads coming from individual DNA molecules. This is an example. So you see C was the reference expected, and there is a mutation here, and these are the normal reads. So reads with normal sequence, reads with mutation, you count the total number of reads, you take the reads with mutation divided by the total number of reads, you will get the variant allele frequency. Now you need an informatic pipelines. You actually identify the variants, but just identifying the variants is not enough. You need to look at it whether it is pathogenic. And how do you do that? You look at different databases. You look whether is it a polymorphism. Then you look, you put predicting tools and see whether this would cause a change in the protein. And then you take a call whether this mutation is pathogenic or not. This is the pipeline we created for my project, and I must tell you it was quite a task. Initially, my informatic guys would talk in technical jargon and take me for a walk. But then I attended courses so that then I knew what they are saying, I understand, and then I can catch them when they are, just bluffing. So if you want to get into this area, you would have to learn informatics, at least the basics. You may not know to code, you may not know to write the scripts, but you should know the principles. Otherwise, the informatic guys will take you for a walk. So there are errors, as I said, every NGS platform has errors, so about 1%. And you must understand one thing is, any NGS today, without error correction, you will get a mutation up to 5%, 5. Less than 5%, if they have not done error-corrected sequencing, it could be a mistake, it could be a false positive. And that is why when you see an NGS report saying 1%, you must ask the person, have you done error correction? If they have not done error correction, don't believe that report. So there are different ways, a computational and physical approach. Usually, they put unique molecular probes into this, and then you can run a computational program to identify these errors. I'll give you an example. Now look at this. Now there was one error here that gets amplified during PCR, and then you will call it a mutation. But here, in error correction, what you do is you add another molecular barcodes, and then, see, this is green, right? So all this are PCR duplicates. So when you do your analysis, you take this as one read. And only when you get a mutation from different molecular probes, barcodes, then you say, yes, there is a true mutation. And that is how, when you really go up to more than 1,000, 5,000 depths, there will be a lot of errors, and you have to use error correction to identify these mutations. Now there is NGS variant reporting. There are guidelines in diagnostics. So we have lower tires which are less likely to be pathogenic. They could be polymorphisms. Then you have variants of unknown significance where there is a mutation, but you don't know it is pathogenic or no. And then you have higher tires where it is more likely to be pathogenic or actionable. So tier 1 is when you have variants of strong clinical significance. There's therapeutic, prognostic, and diagnostic connotation. Then you have a level A and level B evidence, variants of potential clinical significance, and variants of unknown clinical significance where you don't know what is the significance of this variant. And then you have benign or likely benign variants. So this is our NGS lab at Tata Medical Center. We do have an Ion Terran PGM and Ion Studio S5. We usually use that for most of our panels in diagnostics because this is a little cheaper. and you can run, the run time is less compared to the Illumina. We do have an Illumina MySeq. We are running some panels on it. And we have a Illumina NextSeq 550, which we use for only research, because we do RNA sequencing or, the whole exome sequencing for our research purposes. So it's good to be working here. For hematology, we have an oncomine myeloid panel. Yeah, this is the last slide. And wherein in this one panel, we actually are able to identify both mutations as well as fusions. So we just run this one panel and you can identify, and because it was only 15 minutes, some other day I would show you interesting cases where the fusions were so cryptic, not picked up by cytogenetics, not picked up by PCRs also, but was identified on NGS. So I would like to thank Tata Medical Center. I'm lucky to be working there, acknowledge all the patients and families and all my colleagues from Department Cytogenetics and Molecular Genetics. Thank you.
So thank you, Dr. Mayur, for your very nice and lucid talk on next-gen sequencing. So for shortage of time, I would request any delegate or any faculty for only a single question, if they have. If not, then I will ask one single question, sir, if you have that patience.
Yeah.
So regarding NGS, we are getting bombarded with so many genes, pathways, and that the last slide which shows which are of potential significance. And so my question to you is, in a resource constrained country like India, where are we currently placed regarding NGS?
Okay, so that's an interesting question. See, actually it all depends what question you are asking in terms of resource. Yes, the cost of sequencing has come down, right? And in order to meet economics of scale, it's good to have more of central labs which can actually handle more and more samples. So then what happens is your economic of scales really come down and you can actually meet the cost of other molecular techniques. So it is very essential, I think, for India at least, to have centrally placed centers of excellence who can run, who can have big platforms and they can run multiple samples, and that will really bring down the cost, because a sequencing run costs 1.5 lakhs, right? And based on the question you are asking, suppose you are sequencing 50 samples, you want to sequence there, but if you don't have 50, you still have to run 20 samples. So it becomes very expensive per sample when you run that. But when you have a large number of samples and you have large platforms, the costs can really come down and actually match the others.
So it should be in the initial protocols to go for NGS for all malignancy patient, myeloid malignancy or lymphoid malignancy patient.
Sorry?
It should be in the protocol then, so that we can...
Yeah, so I mean, it's like that, I always say that. For example, I'll give you an example of myelodysplastic syndrome, you need a good karyotype, yes, but instead of spending money on massive fish panels, right, a fish panel would cost 15,000-20,000, right? In that, you could actually do a targeted myeloid gene panel NGS, right? And you get enough additional data for risk stratifying your myelodysplastic patient. So it is all about putting the resources in the right place and understanding the importance of tests. And I always say the most important thing is you will get right answers if you ask the right question. So what is the question you are asking? If you want to take the patient for a transplant, of course, go for this tests, and because those will help you make a more informed decision. If the patient can't afford any treatment, then no point of risk stratifying. So it's all a clinical decision end of the day.
Sir, once again for your explanation, lucid explanation. Now I request Dr. Arnab to call the next speaker.
May I request the last speaker of this session, Dr. Saurabh Bhattacharya, to deliver his talk on the topic application of chromosome microarray in hematological malignancies.
Thank you, sir. And thank you very much for the organizer to invite us here and inviting me in this eminent panel, because I'm standing in between a very, very important people here, including Dr. Mishra has spoken here, Dr. Mayur, and even Dr. Rai, Sudipta Rai has spoken here. I'll be taking you to a journey of advanced cytogenetics, what we say, yes, microarray. And microarray was known to be playing very important role in constitutional abnormalities. We know, like babies who have developmental delay or any kind of neurodevelopmental disorders, microarrays should be considered as a first test, not karyotyping. So the time has changed. So microarray was considered as a first-tier test in constitutional abnormalities. But why microarray is playing a very important role in hematological malignancies, that's what we are going to discuss here, and I'll take you to a journey. And it is very important to choose a platform designed for multiple indications. Even we are running a cancer samples, the array platform what we are using should be good, broad enough to cover entire genome. Because we don't want to miss anything, because this is something, again, like next-gen sequencing, microarray is also a costly thing. We should not take a chance, and we should have enough coverage of a genome. We'll be able to run other samples as well with constitutional abnormalities and hematological malignancies, so that we can batch, as Dr. Mayur has already mentioned, that running a batch of samples will bring down the cost. So same thing applies here also. If you run the batch, it will bring down the cost. And cancer is mosaic, or it is very, very highly clonal. That's why we should choose a platform which has a good mosaicism detection capability. So microarray should not be considered the test in all cancer samples. This is also very important. When I'm talking about microarray, it should not be considered for all cancer samples. Why? Because if we have a patient with CML, we have to see BCR-ABL translocation or fusion, which can be done by either karyotyping or FISH or PCR. And same as PML-RARA translocation in acute promyelocytic leukemia, the same thing can be done in this test. So we need not to consider microarray for that, because microarray cannot detect balanced translocation. So that is a limitation. And microarray which cannot detect less than, the cancer sample which has mosaicism detection is not reliable under 20 to 30%. So it is also not recommended for the MRD cases. We should consider microarray in which copy number variation or a changes in a chromosomes or a structure and absence of loss of heterozygosity is informative, like CLL, MDS, ALL, multiple myeloma or renal cell carcinoma, and wherever supplement as needed for other tests. This is a screenshot of our validation study where we have done same sample in 5 multiple runs, and we have found that it is highly reproducible. The platform what we are using in our lab is Affymetrix platform, and the chip what we are recommending for cancer is high density chip, which has 1.68 million markers, which includes all the important cancer genes and OMM related genes. So that same chip can be used for constitutional and cancer. So this is what it is. So you can see the peaks, which is being reproduced in all the 5 samples altogether, and this is highly, highly reproducible. Okay, so allele pattern can distinguish true origin of copy number. So it is very critical in acute lymphoblastic leukemia and multiple myeloma. I'll take you through one example. A case of acute lymphoblastic leukemia, 45 years male. There was no chromosome analysis done. FISH has come to us for evaluation, so we ran the FISH panel, and what you can see, there are multiple copies of all these genes. So MYC has 4 copies, then ABL has 2, but BCR has 3, MLL has 4. So what it indicates that FISH results were reported as consistent with hyperdiploidy, and which is a good prognosis, we know, in ALL. But when we took this sample for validation for microarray, what we found that yes, chromosome 4 has, this is just an example of 2 chromosomes. So chromosome 4 has allele pattern consistent with both homologs, whereas in chromosome 2, there was mosaic loss of heterozygosity. So what is loss of heterozygosity? So one allele is present, another allele is lost, so one allele is actually copying. And that is what we see in a FISH. What we can say that yes, it is a hyperdiploid, although it is actually not hyperdiploid, it is hypodiploidy. So this is consistent with severe hypodiploid ALL with doubling of the hypodiploidy clone. The single allele was actually keep on copying. The pattern of allele difference is necessary for correct interpretation. And now the prognosis has changed from hyperdiploidy to hypodiploidy, which is actually a very poor prognosis. We may have aberrations within aberrations as well. So this is another example where 3-year-old female with acute lymphoblastic leukemia, cytogenetics have showed a loss of chromosome X. It was not constitutional because we have confirmed through peripheral blood. So this was actually acquired abnormality, loss of chromosome X in 90% of cells. What we found, when we went inside and we just do deep analysis, we found mosaic biallelic deletion in PAR1 gene. So we have certain annotable bed files. These bed files are actually kind of, we can say, data files what we create, and we can use it for analysis. When we find abnormality, this automatically shows that there is some problem, and we have identified it earlier. So we went back, and what is happening here? So in that notation, we found that this is actually a position where CRLF2 gene is also located, and that was actually deleted. So within that chromosome X which is present, there is a deletion here. And when we went back for analysis, and we found that yes, it is very important gene. There is a dysregulation reported in ALL patient. The deletion results in a fusion, and deletion itself not causative. So we have to look at the genes in a flanking copy number variation as well. So doing analysis is very important, not only looking at the clear picture, what we are looking at. So we can straight away say that there is a loss of chromosome X, but if we go inside, we can see other changes which is very important for a patient. This is another case where there is a Philadelphia chromosome. There is extra Philadelphia chromosome found in this patient, and there was a deletion on chromosome 9. Fish has confirmed those abnormalities. We have taken this case for our validation. What we have found, that there is a gain in ABL gene. So this is straight away Philadelphia chromosome, but there was a gain found in ABL gene here through this peak. And if you see the, so we can on the basis of fish, we can say, yes, there is a Philadelphia chromosome. There is a deletion on chromosome 9p, but actually there is a gain of ABL gene within translocation. And that is where, there is a dosage compensation and all plays here, and then we can actually report it in a better way. This is another case of acute lymphoblastic leukemia, where you can see this is a karyotype. We have found 3 copies of chromosome 8. There is a chromosome 9 abnormal here, which has a Philadelphia chromosome. There is a 922 translocation. Another clone has abnormal 7. There is some added material here. Again, there is a Philadelphia chromosome with extra copy, and then 20 was lost. So on the language of cytogenetics, we can directly report it as, okay, there is a PH Philadelphia present, extra copy is chromosome 8, and there is a derivative chromosome 7, which has added material. But actually, we are not giving you full information through only conventional cytogenetics. So we took this case for a microarray, and we found that there is actually a dicentric chromosome 9 and 20, which is very important and which was missed by cytogenetics, but which is a very, very recurrent abnormality found in ALL. So that is where, microarray is important. So we have to do microarray on those cases where there is a complex abnormality and when we are actually stuck somewhere that we don't know what to do next. It is also important to focus on a subtle copy number and or allele pattern in a transition point. So you can see here, just to show you some example. So this is allele peaks, and what you see here, these allele peaks are merging here. This merging of allele peaks are showing something, and then we have to go inside and see what is happening here. So there may be some kind of clonality happens here, and we have to analyze those cases. So this is a case where, this is a case where karyotyping has shown trisomy 8, but it was not only mosaic trisomy 8, because looking at the karyotype, we can say that there is 3 copies of chromosome 8, and there is some problem in chromosome 22, but we are not sure looking at only chromosome 8. But when we did microarray, we found that there is a derivative 8 which has happened due to translocation 822, and the gene involved here is MYC and IgK, which is very, very important fusion, which we should not miss. Another case with 15-year-old male with BALL. And in this karyotype, you can see there is a 13 and 14 abnormality. Then there is something happened here in chromosome 14. And what we could report that there is a 14-17 translocation, which is actually not recurrent abnormality we see in a patient in ALL. But when we did microarray, we found that because of this fusion, low-level gain of 14q and 17q, this gene is actually abrupted. And we did FISH also in IGH. We found that IGH was positive. So there is a IGH involvement. When we went back to a literature, we found that there is a 14-17 translocation reported in B cell precursor acute lymphoblastic leukemia, and this gene is actually shown to have expression in BALL patients. So that is where, microarray is helping us. And due to this, so we did some kind of small pilot study in ALL, and what we have found that ETV6 deletion can be indicator of translocation also. So in this pattern, you can see there is a deletion of 150 kb, which is a very small deletion which we cannot detect through karyotyping. Anyways, we cannot detect 1221 translocation in ALL through karyotyping because that is very cryptic abnormality and FISH is suggested. So in microarray, we have found just deletion, but in those analyses, what we found that the deletion were actually leading to a unbalanced translocation. Only deletion 12p was found in 2 patients, and there was a clear translocation in 4 patients when we did FISH and confirmed it. So in MPN, myeloproliferative neoplasm, LOH plays a very, very important role. LOH, as I mentioned, loss of heterozygosity. So you can see this is a heat map of MPN patient published in 2011 with the group in blood. So the blue lines indicates LOH pattern. So chromosome 9 has a very, very important role here. And we know that in MPN, JAK2 is very, very important gene. And that is where, the LOH is shown in a very, very high number than chromosome 14, where IgA gene is there. Chromosome 1 has shown something, chromosome 7, and few in chromosome 19 and 22. Same thing happened in MDS and AML. So the blue pattern shows loss of heterozygosity. So chromosome 1, chromosome 4, and so on. I mean, there are multiple chromosomes which are involved, and that is where, microarray can only detect this loss of heterozygosity. And we know that loss of heterozygosity is actually leading to uniparental disomy. So uniparental disomy is one parent is actually giving its allele, which is actually carrying in a generation, other allele from either of the parent is lost. So which is also called as uniparental disomy. So these are the pattern, chromosome 1, chromosome 4, 9, 11, these all uniparental disomy is actually having the mutated gene. And these genes are, we know that these are very important genes, and which has been described in MPN, GMML, CMML, ALL, AML, and lots of myeloid and lymphoid neoplasms. Mosaic LOH is also resulting in mosaic nullisomy for deletion of CDKN2 gene, which is very important gene present in chromosome 9, and this is what we can detect through microarray. This is just to show a flow chart and an algorithm. I'm not sure whether it is visible, but I just quickly run through that if we have a suspicion of BLL, we can classify it in 2 parts, pediatric BLL or adult BLL. If it is pediatric BLL, then FISH or chromosome analysis, it must be done, karyotyping or FISH analysis. If FISH or chromosome analysis, I'm sorry, this is actually a normal, which is missing here. So this is normal. If this analysis is normal, then we have to consider important genes like ERG or PAX5 gene, which may play a role. And for that, microarray can be done. So microarray can be done, and then if microarray has shown this deletion, then report can be released. If it is abnormal, then we have to check for other atypical rearrangement. If there is a concern for hypodiploid clone, this hypodiploid clone, as I've shown in one case study, we can do microarray to confirm it, and then report can be released. And if it is not diagnostic in adult, then of course follow-up testing can be done. If it is a relapse case also, then we can do simple translocations through FISH or RT-PCR like BCR-ABL and see. If it is normal, then of course it can be given to a patient and final report can be released. So this is the test details what we offer in our lab. These are the details. I'm sure this price should not be a concern because the price for Kolkata will be different. This is a common price for all the clients here. And thank you very much for your attention.
Thank you, Dr. Saurabh, for your excellent talk on cytogenetics. So if any audience, if any delegate, if any faculty wants to ask a single question, the session is open for a question. So no questions. So I thank all the speakers on this hematopathology session.
Thank you.
So we went on with the next session. Next session will be a virtual session, and I request the anchor to come and invite the speaker.
Thank you very much, chairpersons and speakers, for sharing your reflective knowledge with us. Now this is the time for a special session on topic improving outcomes in myelofibrosis. For this, I would like to request on stage Dr. Shantanu Basu, Senior Hematologist, Peerless Hospital.
Thank you, ma'am, and good evening to everybody, and good evening, Dr. Bhave.
Good evening.
Hope you can. Fine, thank you. So we are going to start our next session, and Dr. Bhave will take the stage. But before Dr. Bhave starts, I'll give him a short introduction. Of course, he needs to introduction with me, but some of you who are new to this place wouldn't really know. Dr. Bhave is a consultant hematologist in Lavati Hospital, Mumbai. He has been around for 29 years in hematology, and he has gained experience in range of complex cases. In Department of Hematology, he worked in Sultan Qaboos University Hospital in Muscat, Oman, and the Department of Hematology at Westmead Hospital, Sydney, Australia. He has been part of many organizations like Mumbai Hematology Group, Indian Society of Hematology and Blood Transfusion, and of course, he has always graciously accepted our invitation to attend our lectures. I wish he was here physically, but nonetheless, you're most welcome, Dr. Bhave, and the session is yours.
Thank you. I'm going to now share my screen. Dr. Basu, I hope my slide can be seen and I'm audible.
Yes, your slides can be seen. Yes.
Thank you very much for the kind introduction. And yes, it would have been a pleasure to be physically there. I must also tell you that one of the reasons I'm in hematology is because I actually studied under Professor Mamin Chandy in CMC Vellore. That was my starting point when I actually was exposed to hematology. So I profusely thank Professor Chandy for getting me into the field of hematology. The task for me today is improving outcomes in myelofibrosis, and I'm going to try to impress this audience of the early usage of ruxolitinib in myelofibrosis, and to use this as a survival as a treatment goal, that is overall survival. Now, it is well known that myelofibrosis reduces the duration of life and as well as the quality of life. Therefore, I think it's important that we realize that the earlier we diagnose myelofibrosis and treat it, the better it's going to be. I thank the organizers of the BeSHCON, this conference, for giving me the opportunity to actually speak on this topic. So myelofibrosis comes because of the naughty interaction of the JAK-STAT pathway, where as part of the JAK-STAT mutation, there is ineffective erythropoiesis giving rise to cytopenias, and then there is extramedullary hematopoiesis, which causes the splenomegaly, which is one of the hallmarks of myelofibrosis. And it also results in alteration of the microenvironment, causing inflammation and therefore the bone marrow fibrosis. And unfortunately, if undiagnosed and allowed to go on, it does go into cytopenias and then blastic transformation. Now, we all know myelofibrosis as a Philadelphia chromosome negative myeloproliferative neoplasm, which is a heterogeneous disease, multiple clones. Its hallmark is bone marrow fibrosis, splenomegaly, a high symptom burden, and it ends up with a poor prognosis, more often in India because it's not diagnosed in time. As of now, the risk-adapted guidelines tell us that the treatment is based on what's going to be the ultimate desire. If it's going to be cure, then it is allogeneic stem cell transplant. I don't see many of them happening in our country when I last did a search on this topic. More often than not, it's a drug-based therapy for patients with higher risk or more advanced disease. More often than not, it's hydroxyurea, which is used sometimes IMIDs and sometimes IMIDs with steroids. Many times when it's an stage disease, which is very rare in our country to pick up, but there is a wait and watch or observation strategy when it is a low risk or early stage myelofibrosis. And it's here that I want to bring out a point that if we pick up in early stage and instead of the wait and watch observation, can we intervene with any drug therapy? So JAK2 inhibitors have shown that we can make a difference to the manifestations of myelofibrosis in terms of the fibrosis, splenomegaly, the symptoms that the patient has, and change their prognosis from poor to better. And this is all because these inhibitors reduce inflammation, reduce debilitation, and reduce the fibrosis. And therefore, we feel that with the use of these agents, we might get a perceivably better overall survival, which means that this raises a possibility that patients who are in the earlier phase might actually benefit from this targeted therapy, supporting the treatment of patients with less advanced disease so that they don't go into that conundrum of overt myelofibrosis. Therefore, the potential benefits of this should be kept in mind, but then select your patient carefully so that you see that you don't get any adverse events to the targeted therapy in the patient, who otherwise is then early stage and less symptomatic. Of the various meetings that I've attended in the past, one thing came out is that there are patients who we feel are clinically very early stage disease, but they may have a lot of symptomatology or symptom burden for several hours in a day, affecting their quality of life. So even those who are early stage and have symptomatology, and there are a few like this in your and my practice, they should be offered the chance of going on to a targeted therapy. Unfortunately, in India, by the time patients come to us with myelofibrosis, they are in the overt MF, and or they have come from PV to MF, that is secondary MF. They are already symptomatic. They've already got a splenomegaly. They've already got cytopenias, and more often than not, a year or 2 years down the line, they face some terminal events, which are shown in the slide over here, especially bone marrow insufficiency, transformation to leukemia, thrombotic events, and because of the immune status, infections and bleeding. We also notice that if you look at this table, the later diagnosis we make, all the adverse events of cytopenias, transformation, constitutional symptoms, splenomegaly, all get magnified if we delay the diagnosis or delay the treatment. So the same events 1 year down the line are almost twice the number, and we may have missed the bus in the management of that patient. So early diagnosis is extremely important, which doesn't happen very often in our country. And irrespective of which risk category the patient belongs to, whether it's low, intermediate, 1, 2, or high risk, you will see that the patients of myelofibrosis tend to have a lesser overall survival as compared to the normal population. Therefore, it's and we learned in CML that those who receive or achieve MMR can be at 1 year, can be at par with those who have no CML of the same age. So we can make a huge impact. I'm not saying that we can be at par like CML, but we can make a difference in the early stage. If you look at two time frames between last decade and the decade before that, we noticed that something made a difference in the last decade, and suddenly the survival improved in our patients with myelofibrosis. And if we look at the further details, those patients in this decade, 2010 to 20, whether they had a lower IPSS or they had a higher IPSS, there was something which made an impact and improved their survival, and it was nothing but the JAK2 inhibitor, which is ruxolitinib. So, if you were to look at when JAK2 inhibitor like ruxolitinib was not there versus when it was approved and the patient started taking it, look at the difference in the overall survival, which meant irrespective of what the stage was, if you were to use a JAK2 inhibitor like ruxolitinib, the impact can be significant in the general population in terms of survival and durability of survival. And this we learned from the Comfort 1 and Comfort 2 pooled analysis, where the use of ruxolitinib, albeit in the later stage, can also impact the survival as compared to the best of care. And wherever there was a correction for crossover, that means patients who were on best of care crossed over to ruxolitinib, also there was a benefit to them, indicating that ruxolitinib made a difference to these patients of myelofibrosis. And again, from the comfort 2 trial, we realized that even for the low molecular risk or mutational risk patients who received ruxolitinib, they did very well. But even those who had high mutational risks or molecular risk, they did also rather well when they were given ruxolitinib in as soon as was possible. And what does this myelofibrosis patient come with? I mean, the commonest thing that we pick up is cytopenias, a peripheral smear showing leukoerythroblastic picture, and the splenomegaly, which goes undiagnosed for a long period of time, mainly going to physicians and to gastroenterologists, and then they come to us because there is no answer after having done multiple scopies and ultrasounds and investigations such as those. But what we realize that with ruxolitinib, for each 10% reduction of spleen from the baseline, there was a similar increase, a similar reduction in the risk of death. That means the survival improved as the spleen came down. And that was one very prominent fact that came out from this Comfort 1 and Comfort 2 trials, that the patients who received ruxolitinib reduced their spleen size. It took 6 months, about somewhere between 6 months to 8 months for that to happen. But if they persisted with that drug therapy appropriately, then we are seeing benefits over here. And for those who got at 6 months the benefit of spleen response, they had a better overall survival than those who did not have while on the drug. And those who got it, their durability or persistence or sustainability of survival was seen when they continued to have a splenic response. So the size reduction of the spleen was not only associated with improvement of quality of life, but also with survival. But then why did they not do well? Why did some spleens not do well? So those who had a low spleen response were the ones who had a higher stage of the disease, a spleen size which was very large, indicating a late diagnosis, a high WBC count, again indicating a high tumor burden, and a delay in starting the ruxolitinib, maybe 1 to 2 years later than they should have, for whatever reasons it might be. In our country, it's also financial. And when the doses that were given to them, even at the time of proper diagnosis, was less than 10 milligrams twice a day. And these were the ones which led to lesser splenic response and therefore lesser survival. Therefore, picking it up early and treating with the appropriate dose might make a huge impact in terms of survival. Now, if you look in the trials of Comfort 1 and Comfort 2 for the higher risk, and these three trials for the lower risk patients, what you'll notice straight away is that the splenic response at a timeline of 24 weeks was excellent for the lower risk. And all the other adverse events, such as the cytopenias, risk of infection, or discontinuation rates, were much lesser in those who had a lesser risk or a lower risk or a lower IPSS score at the time of going in for the therapy. So IPSS intermediate 1 patients may possibly achieve a higher response rate and experience lower toxicities than patients with higher risk, which means they are able to continue the drug for a longer period of time, indicating that all the side effects being lesser, patient is likely to take this drug longer, and therefore responses will be far better. Now, from this retrospective Italian study it's a small number, 408, but for myelofibrosis, it's a good number. If the interval from the time of diagnosis to treatment was long, especially 2 years, large spleen, or there's already a transfusion dependency both for hemoglobin and platelets, and the higher risk of the stage, they influence the response to the therapy such that the disease response was much lesser, which was a corollary that for those who had a early myelofibrosis, because they tolerate ruxolitinib better, and we start them in time, they have a better response of the spleen, and which might result in better efficacy and more durability. Now, if you look quickly at the other things, bone marrow fibrosis at the end of 2 years, there is reduction in the bone marrow fibrosis if they persist to take the therapy and this remains stable or reduction continues to occur over a period of time. We don't look at the allele burden in real world, but in trials they've shown that with continued use of ruxolitinib, the JAK2 allele burden does reduce, and therefore this is correlated with better symptom-free survival, and I don't know whether it correlates with the overall survival. As a result of the spleen reduction, the patient's appetite improves, and this has resulted in increase in the albumin levels. And obviously, because the patient starts eating better, the weight goes up and the patient feels much better. This improves the well-being and the quality of life, which is a huge impact. When you look at the questionnaire on myelofibrosis to a patient, one of the commonest things they say is fatigue and inability to eat adequately and a very low appetite for a reason which is beyond their comprehension. It's actually the spleen which is the problem. Interestingly, it also has an improvement of the renal function. And if you'll see in the red, ruxolitinib has a renal improvement over match controls. And this renal improvement is associated with a better failure-free survival, which indicates that the patient's overall status has improved significantly while they are on ruxolitinib. I'm going to end by saying that ruxolitinib or a JAK2 inhibitor availability has changed the routine clinical practice, changed the algorithm or the way we have managed myelofibrosis. Otherwise, in the past, we did not have a proper algorithm for the management, and it used to be just steroids or IMEDs. Today, things are different. Ruxolitinib is able to improve several risk factors which are linked to survival, namely reduction of spleen, which results in a better survival, improvement of symptoms, which not only happens in the first 4 to 6 months, but it sustains once they continue to take the therapy. It improves the cachexia because they start eating better, and this leads to a much better quality of life and survival. And at the end of the day, because of all the spleen reduction and because of the reduction in the fibrosis, improvement of the renal status, better appetite, nutrition, they have a better quality of life. Can I then say that if we were to start the patients early, we might have a situation where we might have fewer adverse events, fewer discontinuations, and this will result in the patient able to take treatment for a longer period of time. So if that treatment remains for a longer period of time, then their ability to achieve a control is better with better overall symptom control and scores and reduction in the spleen size. Therefore, it would appear that early myelofibrosis patients would be expected to survive longer, and if they were to be treated early enough, and they would have much better outcomes because their toxicities and the ability to take treatment for a longer term is much better. Yes, there are certain adverse events which will take place, which we have to be monitored in the patient, but overall, it might make a huge impact in our management. Just my last thought is, it sounds very good, and of course, we are all in favor of doing this, but many times we are unable to do this because of the financial reasons that the patient has. And despite a patient-assisted program, many times we are not able to give the best therapy to our patients of myelofibrosis. And many times we actually not picking up myelofibrosis in the early stage, and therefore I think awareness has to increase, and we should be doing more aggressive, probably bone marrow examinations early in patients with myeloproliferative neoplasm. With that, I thank you very much for your time, and I thank the organizer once again for the opportunity to interact over here on a virtual platform. Thanks.
Thank you, Dr. Bhave, for your very brief and to-the-point presentation for ruxolitinib as a very good drug and spleen as a surrogate marker which improves and the quality of life improves. The session is open for one or two quick questions. I'll start with one asking Dr. Bhave, when will you not give ruxolitinib in a myelofibrotic patient?
It's a tough question to answer. I mean, we all itch to give it because we know that it has a huge impact. But when there are already significant cytopenias, especially the platelet count being less than 50, which is one of the commonest reasons for not being able to use ruxolitinib regularly, because our patients come to us late, then giving it to them becomes a problem. There is a thought process that those who are already immunocompromised and have infections, we may not be able to start therapy immediately. We'll have to wait till those infections come under control. I've had patients of tuberculosis where initially I would think that I should not use ruxolitinib, but I've given AKT along with ruxolitinib, and my tuberculosis in my patients hasn't worsened. Herpetic infections are common. I give acyclovir prophylaxis to them and I get on with treatment. But the reason for not giving is possibly when they're too late, they can't afford, and the platelets are too low, they're transfusion dependent, that becomes a problem then.
Thank you. Thank you very much. Any quick questions from the audience? Well, if there are no questions, thank you, Dr. Bhave, once again. I hope we come someday to Calcutta and we meet. And thank you, the audience, for this. And so let's close this session and go to the next one. Thank you all.
Thank you. Thank you. Bye.
Thank you, sir, for the informative session. Let's resume towards our next session with the topic of great debate on the theme of everyone wants to know. It's my privilege to introduce our first chairperson for this topic, Dr. Tufan Kanti Dolai, Professor and Head, Department of Haematology, NRS Medical College, Kolkata. And our second chairperson, Dr. Bilkish Begum, ex-professor and Head Department of Haematology, School of Tropical Medicine, Kolkata. Welcome to the stage, ma'am and sir. Now I would like to request our chairperson kindly introduce our speakers.
So thank you very much. So now the interesting session of the debate. So the topic is very important. There is a recurrent venous thromboembolism. The indefinite anticoagulation is always a dictum. And the theme is everyone wants to know, because this is very important, because the DVT is not only treated by the physician, but also hematologist, the CTVS surgeon, general surgeon. A lot of the people is taking care for the thrombosis, particularly into the lower limbs. So it is a concern that the recurrent thrombosis sometimes in the old era needs the indefinite anticoagulation. But due to advent of the lot of other advances for the diagnosis and lot of the other drugs, the scenario might change or might not change. So for that, our debate. So for the motion, Dr. Ankita Sen, she will be in the for the motion of this debate, means there is a recurrent thromboembolism needs indefinite anticoagulation. Dr. Ankita is very bright student. Not only that, now she is a consultant hematologist and hemato-oncologist, and also presently in NRS Medical College and also the AMRA Hospital. Over to Dr. Ankita, please.
Thank you, sir. Good evening, everyone. At the outset, thank you for the opportunity to come and meet everyone in person. So the topic today is recurrent venous thromboembolism, and like we all want to know whether the answer is indefinite anticoagulation. So I'll firstly begin by discussing what is meant by recurrent venous thromboembolism and which patients are at risk. So as is evident from the topic itself that not all patients are eligible for indefinite anticoagulation. So next we'll move on to the management and what are the guidelines saying. So deep venous thrombosis, that is a clot in the veins, mainly in the lower limb, or the pulmonary embolism when the clot dislodges and goes higher up. And these are the two main things which constitute the thromboembolism. So why are we doing this? Because as is evident from this figure, that fatal pulmonary emboli, or thromboembolism again, constitutes a much higher rate of mortality and morbidity than most of the common causes like accidents or any other cancerous condition. And okay, so this is showing you that all DVT including PE has a very high incidence and that increases with age. Again, it is more common in male, and it is also a common problem in the Asian and the Indian population, unlike previously thought. So this is just to give you an idea. Why are we dealing about this? Why are we talking about it? So it has been extrapolated in some papers and some literature that the incidence now might double by 2050. So we should be well prepared. A brief about the pathogenesis. So we all know about the Virchow's triad, which leads to coagulation, stasis, and the clot formation. So there are certain factors which contribute to it, hereditary, acquired, or probable. I'll not go into the details right now, but I want to highlight that venous thromboembolism may be provoked by factors which I have previously shown you, or it may be unprovoked, where the specific factor for the coagulation is absent. Then again, the provoked factors may be transient or persistent. I will not go into the fine print, but these terms are important for us when we are going to decide which patient will be needed for indefinite anticoagulation therapy. So according to the ISTH, or the International Society of Thrombosis and Hemostasis, VT is defined as an unprovoked thrombosis if any of the provoking risk factors are absent, and they have given us a list. So now the main topic today is not venous thromboembolism. We have added one more word in front of it, that is recurrent venous thromboembolism. So what do you mean by that? Venous thrombosis of a site that was either previously uninvolved or had interval documentation of incident DVT or pulmonary embolus resolution, again had it, that is known as recurrent. So usually the USG is used and the D-dimers as per certain literature. This is what we will use to track the recurrence of the thrombus. And coming back to the baseline, what is the importance of properly treating recurrent venous thromboembolism? Because it might not only lead to anxiety, stress, etc., but it will lead to dyspnea, pain, and at the end of the day, reduce quality of life. So moving on to the percentage, or what is the actual incidence. So if it is unprovoked, then the recurrence rate is something around 7.4%, and the recurrence rate in case of transient risk factors are 3.3%. So it is not absent, it is there. And in certain European guidelines, the term unprovoked has been negated by them. They just prefer to use a descriptive term. Okay, I will not go into this. I just want to highlight the number of studies. Again, the importance of this. So the number of studies which are currently studying and working on recurrent VTE and the management. So as you can see here, the provoked factors, moving on from major, minor, unprovoked to provoked major, which includes cancer. That means the persistent. So if you remember the terms, persistent, transient. So the persistent cancer has a higher risk of recurrence, whereas the transient factors, which is on the left side of the spectrum, that has a very low risk of recurrence. And accordingly, the duration of anticoagulation, it has been advocated, the more persistent, the more unprovoked, the more longer the factor is there, the duration should be prolonged. Similarly, in case of pregnant females also, it has been said that if it is recurrent, then they should have a longer duration of anticoagulation, not just the gestation and perigestational area. So, which particular presentations, when will you suspect that this patient might go on to have a recurrence? It has been seen in different literature that distal calf venous thrombosis, they have a lower risk of recurrence, and more proximal, more the risk. Again, pulmonary embolism increases the risk. And just to give the statistics, but I'll not go into that. Now, here we'll see that nearly 50% people with a first episode of venous thromboembolism have no identifiable cause. That means they are at risk. And the risk is increasing 10, 25, 36 exponentially with time. Another meta-analysis has given a percentage of 23.7. Again, the recurrence rates are not significantly different for patients who have inherited thrombophilia. So why am I highlighting this? I have shown you the figures previously regarding the causes. So not all patients who have inherited thrombophilia, they automatically do not qualify for a prolonged anticoagulation. And the increased risk of recurrent VT has been reported with certain types of coagulation defects. Now, I'll not cover that for the sake of time. But in case of antiphospholipid syndrome, they should undergo a prolonged anticoagulation. This is again showing you that cancer patients are more at risk. And for predictions, we have certain objective ways. So there are certain scores, such as the HER-2 score, the Vienna prediction model, and the DASH score. Vienna's model is most commonly used, and HER-2 score is also very commonly used. There certain parameters are used for all. Most commonly, the common parameters include age and obesity, D-dimer, and the preceding causes. And they will give us an idea. So for instance, all of them here, if you see the low risk of recurrence, so they have managed to find a particular level that, okay, if the patient has this much level, that means they are at a lower risk and we may not continue the anticoagulation indefinitely. So this is again an external validation of the DASH model which I've shown you previously, which is saying that this score evaluation performed better for younger patients rather than the elderly, and it again reiterates the same fact. So a new score has also come in the pipeline, and it has been conducted by Moreno et al.'s group. So it's called the Damove score. It's basically a nomogram type, which you can see here. It deals with age, sex, obesity, D-dimer, factor VIII, genetic thrombophilia, and the varicose veins. Accordingly, they are also aiming towards a prediction model. So why are there so many models? So once again, you can see that we are still not clear about one particular model, and much more studies are required before we can actually say that, okay, this cutoff is enough for a patient. So it's still very personalized, and you have to deal with person to person basis. Okay. Regarding the long-term recurrence and D-dimer levels, so here we can see that the overall recurrence in this particular study, they found 21.5%, but it was not involved with D-dimer. So even if it was a negative D-dimer, it was not low enough to stop anticoagulation. So D-dimer is negative, it doesn't give me the license to stop anticoagulation. You have to take all the other features in account. So this again is a meta-analysis. I will not go into the percentages here. I'll just say that all the patients here had completed their initial mandatory thromboembolism, okay, regarding the treatment, and then they found out that it increased like 16%, 25% with time once the anticoagulation was stopped. So overall rate of 7% was seen in another study. This is the famous RITE registry. Here also they found a lower incidence, but the outcome is the same. So a patient with risk factors, you stop the anticoagulation, they are bound to recur at some point of time. And this, I have kept this because this is highlighting rivaroxaban. So now, nowadays the newer anticoagulation agents are also being used. And in this particular study, they have seen that recurrent VTE patients, they were on rivaroxaban, and even then they have also developed it to some extent once they were stopped of rivaroxaban. And so high recurrence risk, once again, active cancer, and certain non-malignant conditions which are associated with at least a twofold risk of recurrent VTE after stopping anticoagulant therapy. That includes inflammatory bowel disease. So like sir rightly said, that this particular disease not only deals with hematology, it deals with every other faculty of medicine which is there, you know, including surgery, pulmonology, everything else. So this is one such disease where again this is of utmost importance. So now coming to the important question, what should drive our decision to treat? Recurrent VTE be, like I said, mortality, long-term morbidity, but you have to judge wisely. So if a patient is elderly, or if a patient has active cancer, so they might have other comorbidities, they might have other problems, low platelet counts, so then naturally you cannot anticoagulate that patient you know, indefinitely. And so in that case, you have to be rational and you have to decide regarding the dose or when to restart the therapy. So again, which patients are at highest risk? So the risk-benefit ratio. Can I allow this much of bleeding risk because I am able to prevent pulmonary embolism in the long run? So are the risk factors present and are they persistent? Can I treat the risk factor so that I can negate the risk factor and the patient may not have a repeat thrombosis? So this is, in very simplified way, this is the treatment plan. So for all patients, mostly with thrombosis, so it's like 3 to 6 months, and the treatment starts within 5 to 21 days of diagnosis. Then after you complete 3 to 6 months, depending on whatever duration you have treated, then you have to take a call regarding indefinite anticoagulation. So this shows it in a more simplified pattern regarding what I was saying for personalized or shared decision making and certain personalized risk factors. So accordingly, whether you extend anticoagulation or you stop anticoagulation. Coming to the guidelines. So this is the CHEST guideline and expert panel report. So they are talking about if it is an unprovoked
Dr. Ankita, you have 1 minute.
Right, sir. So, okay, so here they are talking about aspirin to prevent recurrent VTE and anticoagulation in any case if the risk of VTE is high. And okay, regarding the ASH 2020 guidelines, DVT and or PE, if there are chronic persistent, in that case you have to continue. For the ASCO guidelines, again for cancer patients, they are talking about continuing it. In the Daltecan study, here they have used the newer agents dalteparin, and they have talked about, even though it's not more than 6 months, but they have talked about the use and benefit of dalteparin. Few more trials, clot and catch trial, where they have used dalteparin and tinzaparin. But even then, still now, low molecular weight heparin and VKs are more preferred, both from the use point of view as well as from the monetary point of view. In Europe, more than 90% patients get LMWH or VK. Later on, they shift to rivaroxaban. ACCP also recommends for long-term therapy. And like I mentioned initially, quality of life is very important. So you have to discuss with the patient, with the risk factors, his age, and what does the patient expect regarding, you know, you have to continue it for a long time. So Okay, so this is my last slide. So what I'm trying to give the message throughout is the recurrence risk should be determined by the personalized risk factors, assess the patient. Unprovoked VT should be looked at closely. But not only that, those which are provoked and they have minor persistent or transient risk factors, they should also be assessed for the risk of recurrence, and you have to treat accordingly. So just because it is provoked or transient does not mean that the patient may be a candidate for repeat recurrence. And not all inherited thrombophilia patients will require indefinite anticoagulation. And in addition to low molecular weight and low molecular weight heparin and the vitamin K antagonists, newer agents like rivaroxaban have also been studied, and further studies are going on for other newer agents. And quality of life and discussion with the patient are vital. So with that, I'll end. Thank you very much.
So thank you, Dr. Ankita, you said. So for against the motion, Dr. Abhijit Fukan is there. Abhijit Fukan is the consultant hematologist. He is working in the Excel Care Hospital, Guwahati, Assam. So Dr. Abhijit will be speaking on the against the motion, that is there is indefinite anticoagulation is not required.
Good evening, everyone. First of all, I'd like to thank Tufan sir and the organizing committee for considering me and giving me the honor. So I'll be talking against the motion. So, and I think almost against the belief of most of the people who are sitting here. So all of us feel that recurrent venous thromboembolism that needs indefinite anticoagulant. And I personally believe that anticoagulant is the backbone of thrombosis treatment. But my problem is with these two terms. One is indefinite and always the dictum. So indefinite, we have to be very much careful while giving the message to the patient that it's indefinite, because it carries lots of problems along with that. And second thing, it's not the always treatment. We have to rely on other treatment options while offering a patient with anticoagulant. Let's see the picture. What can we see? A patient get driven away by a car. So whose fault is this? In case of India, definitely the driver. But if we see in a broader sense, these risk factors are always present in your life. We do not get hit by car every day. So these risk factors will be present. We have to be careful. We have to modify our behavior. We have to be careful. And that actually determines the proper outcome. So if we see recurrent thromboembolism, by definition, you will see it's more than one episode. But more than means more than one, what? More than one. It's 2, it's 3, it's 4, or more than that. So under one umbrella, do you want to consider all these patients? So one patient having second episode of thrombosis, and another patient having 5th or 6th episode of thrombosis. All the patients are same, or you will like to treat the patient indifferently. So we'll start with the diagnostic prospect. So in diagnosis, definitely we take help of two investigation. One is D-dimer and ultrasound. So D-dimer, the D-dimer problem is that whenever we ask for D-dimer, it remains higher for a longer time period. So a patient, suppose I give you an example, a patient is having a DVT in the right leg, and suddenly we treated him for 3 months, and again he complains of pain. It could be due to various factors. So in those conditions, we cannot rely on the D-dimer because it will be high. So based on D-dimer, we will not treat the patient as a recurrent thromboembolism. So we'll take help of ultrasound. So in case of ultrasound, definitely sensitivity is very high, 90% in proximal, 60% in distal, and accuracy is almost 100%. But the problem comes whenever there is a recurrent thrombosis in the same leg. Because as we know, after thrombosis anticoagulant therapy, all the time the thrombus do not get dissolved. So there may be some residual thrombus, or there may be some fibrosis also left over. So we need a serial ultrasound. And according to the definition, if there should be more than 4 millimeter increase in the size to term as progression of the thrombus. So in those conditions only, you can term it as a recurrent thrombosis and put the patient on anticoagulant. Otherwise, falsely, we may be putting lots of patients on indefinite anticoagulant. So it is rightly pointed out the recurrent venous thromboembolism. What is most important thing? One is that we have to prove whether it's a provoked or unprovoked. That is the main question. But even if we see Austrian study, they have found that 10% of the recurrent VTs are provoked. So not all the 100%, but there are some patients, few patients who are actually put on anticoagulant, lifelong anticoagulant, without any proper counseling. So this should not be done. And causes of thrombosis already has been mentioned. There are lots of factors, but if you see closely, the factors like smoking, hypertension, then surgery, trauma, immobility, pregnancy, oral contraceptive, all are modifiable factors. If you do not remove these factors and put the patient in lifelong anticoagulant, I think it's not justified for this patient. And if you see the prevalence-wise also, the most common things comes hormonal therapy, long stay, rather than the cancer. So prevalence-wise, the first things are first come. These are the most common factors. We always have to consider these things. So I'll not go into the study, the anticoagulant therapy management, but if we go through this chart, okay. So if you see the most common cause of thrombosis, the upfront thrombosis is that prolonged immobility, surgery along with cancer. Definitely cancer is there. But in case of recurrent thrombosis also, what I can see, the most common causes are non-adherence, subtherapeutic level, catheter along with cancer. So there are some modifiable factors. So we have to consider these factors before putting a patient to anticoagulant for lifelong. So my question is, second question is, if anticoagulant is always the answer to a question, so why do patients have thrombosis even after they are on anticoagulant? So there are lots of studies who try to prove why patient has thrombosis and what are the best treatment options for this patient. So, but my point is, even they are on anticoagulant, there are 11% chance that patient will have repeat thrombosis within the first 3 months. So I think anticoagulant are not always the choice. We have to think otherwise also. And the management is like they try to change the medicine or they try to increase the dose of the medicine, whatever the cause. But even after you do the changes, do the modification, in case of medications, there will be again repeat thrombosis. The chances are 8.6% after 3 months. So even after changing the anticoagulant also, there may be chances of thrombosis. So the major two findings, the driver factors that leads us to cause for an indefinite anticoagulant. One is the thrombophilia, second is the cancer. I think most of will agree to it. And the limitation of these two, there are some limitations of these two factors. So one is thrombophilia, because we are having now different various investigations, and upfront investigation, we are able to detect around in 50% of the cases in different type of thrombophilic defects. But if we go by the Cochrane study that was done for thrombophilia testing to prevent recurrent venous thromboembolism, and the primary objective is to know the recurrent VT, and secondary objective is to determine the major bleeding quality of life. But interestingly, there is currently no information available from any randomized controlled trial, RCT, on the benefit of thrombophilia testing to reduce the risk of recurrent VT. So basically there is no study. I'm not going to tell you that it's not advisable to start an anticoagulant, but there is no definite study to prove that it's going to help in case with recurrent, to prevent recurrent thrombosis with this thrombophilia testing. But why do we know thrombophilia testing? Definitely we need thrombophilia testing to manage further, because a pregnant lady with APLA, definitely she will need therapy. So patient with repeated thrombosis, like 5 or 6 episodes of thrombosis, definitely we need to put the patient on lifelong anticoagulant. Second is the timing of the test. The problem with thrombophilia testing is the timing. Whenever the patient has thrombosis, immediately we cannot ask for the test, because there will be going a coagulation cascade. False report as possible. Again, if we put the patient on anticoagulant, we cannot do the test. So these are the limitations. So we cannot do the thrombophilia testing in most of the patients. Yes, there is exceptions like factor V lead-in and prothrombin mutation that can be done at any point of time. But except this, there are the other factors we cannot test in this patient while patient is either on anticoagulant or when he is in ongoing thrombosis. So cancer, definitely we need to rule out whether there is a cancer or not. But the most important question is how far do you want to go? So if a patient has an uneventful, unprovoked thrombosis, so will you advise lots of investigation like CT scan, PET scan for all of the patients? Definitely not. First incident, it has been shown that increased detection through extensive screening in idiopathic DVT. I'm talking about the first incident. That is not neither cost effective, it does not reduces mortality, morbidity, or no survival advantage. So cancer diagnosis, even we are telling that underlying cancer is the main cause, but most of the time we fail to diagnose the underlying cancer at the earliest part, even after with extensive testing. And the common mistake we generally do is that recurrent, if there is a thrombosis, we put the patient on, a cancer patient, he had thrombosis, we put the patient on lifelong anticoagulant. It's not the normal dictum. So normally it says until the disease is active. So AML patient during therapy, ALL patient during therapy, they may have thrombosis, but once the disease is clear, so after a completion of the anticoagulant, we are going to stop the anticoagulant. Now, another important thing in your life is the maintaining the equilibrium. So here we are going to maintain a balance between thrombosis and the bleeding. So this is the most important thing we have to balance. And if we see how we are going to maintain the balance by seeing what are the chances of recurrence if we stop the anticoagulant and what are the chances of bleeding if we keep on giving the anticoagulant to a patient. So in your practice, we generally what we see, the patient coming to us are elderly patient. They have hypertension, they have some kidney disease, they have some CLD. So already the patients generally we get, they are in the high risk group. If we hemorrhage score, they are already in group 3 or 4. So with a chance of bleeding is 10.4 to 12. So it's a high risk of bleeding. So we are going to put the patients on long-term anticoagulant based on this data. So let me simplify this with an example. So I have a patient, 58 years female, so who is diagnosed case of CLD with portal hypertension, and incidentally, we have diagnosed her as myeloproliferative neoplasm. Precisely, it's myelofibrosis. And the patient presented with DVT and portal vein thrombosis. We treated her with blood thinner for 3 months. The thrombus has resolved. And after 4 months, suddenly she came to us one day in the ICU with severe hematomesis and melena. So I have not get clearance from the gastro people to continue the anticoagulant. So what should we do? So are you going to risk the patient with anticoagulant, or you are going to wait and watch? So always anticoagulant is not the answer. Yes, we have some difficult cases, like already I have mentioned the patients with CLD and portal hypertension, you have to think twice before continuing the anticoagulant for lifelong. CKD patients, they have high tendency of thrombosis, but they have, along with that, they have platelet functional defect. So if you are giving anticoagulant to these patients, definitely the chances of bleeding is also high. They will end up with GI bleed. And another things, that other options, what do we have except that anticoagulant? Difficult to say. Obviously, we can take help of thrombolysis in very selected cases. Vena cava filter, they have been recommended for those patients who are contraindication to anticoagulant or repeated pulmonary embolism, even after they are put on anticoagulant. So what my take-home message would be, anticoagulant is definitely the backbone of VTE management, but it is not the only tool to prevent a thrombosis. And we have to accept few things, like there will be some contraindication of lifelong anticoagulant to some of the patients, and recurrent VTE will happen, thrombosis will happen even if you put the patients on anticoagulant. And last not the least, that lifestyle modification. There are some factors that are modifiable. We have to focus. We have to focus, and we have to try to modify these factors. As there's a great saying, you cannot prepare and prevent for war at the same time. So either you prevent or you prepare. So if you want to prevent it, so put the patient on lifelong anticoagulant, or if you want to prevent it, then be observation, look carefully, and when needed, you just put the patient on anticoagulant at that point of time. Thank you.
Thank you, Dr. Abhijit, for wonderful lecture and against the motion. Dr. Ankita, anything you want to say? So I think both the yes.
No, sir, I don't have, I would just like to make a comment that it is a difficult call, and like he rightly pointed out, so we have to be careful regarding when making a decision of indefinite anticoagulation, that's all.
So I think, I think the Abhijit is the winner. So both the Dr. Ankita and Dr. Abhijit has been nicely deliberated there for the motion and against the motion. So with this, any comment from the floor?
So as far as indefinite anticoagulation is concerned, there is no doubt we have to give indefinite anticoagulation in case of recurrent DVT, cancer associated DVT till the cancer malignancy is active. Then if there is inherited thrombophilia, few inherited thrombophilia, so I am asking this question, if anybody can clarify, what are the inherited thrombophilia? Those require indefinite anticoagulation. Suppose a patient is having APLA profiles, APLA antibody positivity, or antithrombin 3, these are high risk thrombophilias, or homozygous factor 5 lead mutation, or combined homozygous factor 5 with protein C. but isolated protein C or protein S deficiency, if we encounter in our clinical practice, whether that mandates indefinite lifelong anticoagulation?
Yes, Ankita, please.
And should we go for this protein C as antithrombin C testing in a routine clinical practice?
Dr. Ankita will give the answer, otherwise I will give.
Yeah, so basically, like I already showed, for lack of time, I didn't go into the details of it. So for certain things such as deficiency of TAFI or other tissue factors or the APS, antiphospholipid syndrome, for that it is indicated. But for the other things such as, like you said, protein C, protein S, it's not really indicated that you have to give indefinite. So for that, you need to have the risk-benefit assessment and once again, all the other factors to be taken into account.
Yes, actually what I want to say that it's not like one size fit to all, and we have to take consideration of everything. Protein C, protein S deficiency, if you are doing at the phase of the thrombotic storm, then it's not going to give a good result. That's the problem. And second thing, we have to consider other things also, like whether the patient is elderly, whether other bleeding risk factors are there. So as I have mentioned, CLD patients, so what can you do? I know it's a MPN, he will have a related bleed, but considering the clinically and balancing everything, so we just have to observe the patient for right now and not try to kill the patient by bleeding. That's it. Thank you.
Yes, yes. So thank you, Dr. Ankita and Dr. Abhijit, for this wonderful debate.
Thank
so,
you,
ma'am, you can please conclude the session.
Now, we are concluding this session.
So, thank you very much.
Thank you very much, sir and ma'am and speakers. Your sessions, for the spectacular sessions by all the delegates. Now moving forward with the great events of knowledge and information with the J.V. Chatterjee oration, facilitation and inauguration. For this, I am going to hand over the stage to Dr. Sipla.
Good evening, everyone. Now we are going to proceed for Professor J.B. Chatterjee Memorial Oration Ceremony. First, we welcome our chairpersons for the Professor J.B. Chatterjee Memorial Oration. We invite Dr. Shantanu Basu sir, who needs no introduction for this August gathering. He is the Senior Consultant of Haematology Department, currently attached in Peerless Hospital, Kolkata. Please, sir, come to the dais. Now we request Professor Dr. Utpal Choudhury sir. ex-director of Institute of Haematology and Blood Transfusion Department, Medical College, Kolkata, to come to the dais. Now, sir, please invite Dr. Pradeep Kumar Mitra, sir, for the oration.
Good evening, everybody. Now, today we have at an August moment where we have a lecture in memory of Professor J.B. Chatterjee. Those who are young might be that they are not aware about the works of Professor J.B. Chatterjee. He was the first recognized, internationally recognized hematologist, and he has almost 380 publications. Almost 380 publications in that area. He had an untimely demise, otherwise we could have many more works. His sphere of works spanned from iron deficiency to malignancy, coagulation, hemoglobinopathy, everything. And so, in memory of his, in this Bengal Society has started this oration, and this year we have none other as the orator, Professor Pradeep Kumar Mitra. I don't know whether Pradeep needs any introduction. It doesn't have. Yes, please come to the dais. Please come to the dais. Pradeep, just a few minutes. Please sit here.
Now, Professor Pradeep Kumar Mitra, sir, will garland the photograph of Professor J.B. Chatterjee. We now request our chairpersons to felicitate Dr. Pradeep Kumar Mitra, sir. Now, Professor J.B. Chatterjee Memorial Oration will be delivered by Dr. Pradeep Kumar Mitra, sir.
Very good evening. Actually, at the outset, I must say, I feel myself honored and also fortunate to present in front of you as lecture in whatever I will say. It will be a humble submission to Professor J.B. Chatterjee, because we are nothing in consideration of Professor J.B. Chatterjee. So I think I am very much fortunate. And in this platform, I also I remember my teacher, Professor Subir Kumar Datta, because without him, I couldn't reach up to this level without his guidance, support, constant support. So definitely, to give something about the background about the topic, ineffective hematopoiesis and apoptosis in myelodysplastic syndrome, actually Dr. Shantanu Basu came in the meeting with a souvenir of almost 23 years back in the first state conference of our association. There I found that I delivered the same topic, delivered on almost, it is mostly this particular same topic. So about 23, 24 years back. So now the still topic is kept. So you see, over the 2 decades, many things have changed. And okay, I accepted that. Let me talk on the same topic again. And it is let me revisit the things, what is there. So this is the background of this particular topic. Here, you see 3 terms are there: ineffective hematopoiesis, another is apoptosis, and another is myelodysplastic syndrome. So let us see what these 3 terms mean. And I have given only 20 minutes time, so you see it is not possible or it is not desirable to speak on the MDS, myelodysplastic syndrome as a whole. So we'll have to pick up these areas and let us see what is what. So first you see, if you see the ineffective hematopoiesis, you see it's a dysfunction, actually dysfunction in the production of the blood cells, mostly all the lines of the blood cells, resulting in decreased number of mature cells in the peripheral blood and in the mature functioning blood cells in the peripheral blood. It may be single lineage, multi-lineage, but mostly tri-lineage. You see, if you consider some diseases, this slide I will describe later on. If you see the myelodysplastic syndrome, what is that? By definition, it is a clonal stem cell disorder with relatively heterogeneous spectrum. Heterogeneous spectrum, it has got morphological dysplasia of the hematopoietic stem cells and also some amount of bone marrow failure and varying degree of peripheral blood cytopenias. You know, myelodysplastic syndrome is not new, but not very old also. It is, in 1982, the name has been coined, but since 1900, this type of scenario was there in the blood, where it differently it was named as refractory anemia or pre-leukemia, whatever maybe different terms were there, dysplasia. But ultimately, MDS, myelodysplastic syndrome, the name has come in 1982. And here you see the 2 things happen. One is the morphological changes in the cell due to some defect in the maturation, some arrest in the maturation. At the same time, sometimes what will be evident later on, that there is sometimes the clonal expansion also, which leads to increase. So in this particular is a unique situation where actually sometimes you get hyperplasia of the bone marrow. Mostly in some of the cases of MDS you can get hypoplastic marrow, and sometimes that may be sometimes difficult to differentiate with the aplastic anemia or paroxysmal nocturnal hemoglobinuria or like that. But mostly these are hypercellular marrow and along with the cytopenias. So if you go back to previous slide, so there are some conditions where you see some pre-MDS, not fully developed MDS, but different cytopenias are there. One condition may be called as a ICUS, that is idiopathic cytopenia of undetermined significance. You can see CCUS or clonal proliferations, or CPUS, clonal proliferation or clonal expansion with undetermined significance, or CHIP, there is a clonal hematopoiesis of indeterminate potentials. So these similar terms are there. It may be caused that. So what I want to stress you, that MDS doesn't develop all on fine morning you find MDS. So MDS may be a long-standing process, and there are some changes in the cell and the cellular precursors of the cells and the morphological changes, and ultimately MDS develops. MDS may be, it may be, what should I say, de novo. It can start de novo in some of the cases, like say some viral infections or benzene, structure poisoning or like that. But mostly it is sometimes therapy related, that is a MDS, TMDS, or some therapy alkylating agents when we used to give in some of the diseases, and then ultimately it may turn to MDS. So myelodysplastic syndrome, so you see primary neoplastic and pluripotential stem cells are changed, severe cytopenias and maturation abnormality or dysplasia in one or more cell line, and sometimes 30 to 40% cases of this myelodysplastic syndrome may turn into AML, mostly in elderly. Actually, disease is usually prevalent in mostly elderly. 65 years is the mean average age of the subjects. Of course, in some of the patients, younger patients may be seen before the age of 50, but mostly it is around 65 years of age. And some colony formation, impaired colony formation, there I'll describe what is that colony called. So this. Now coming to terminology wise another topic. So we have discussed a little bit of ineffective hematopoiesis, a little bit of MDS, and now coming to apoptosis. Because the apoptosis, you all know, that is the natural biological process of programmed cell death. So its cells destroy themselves for maintaining a smooth functioning of the body. Actually, the apoptosis are needed during even embryological life, during development period. This type of apoptosis or physiological cell death is needed. But in pathological conditions also, apoptosis take a major role, and what is very important in the case of MDS or myelodysplastic syndrome. So if we see some of the mechanism of the apoptosis, or it is called apoptosis, P is silent. So initiators, there are some initiators for the apoptosis. Initiators we divide into transmembranous and then extracellular, intracellular mechanisms. So 3 stage, one transmembranous, absence of hormones, growth factor or cytokines, they can cause apoptosis. Intracellular means mitochondrial. I'll describe in some details about the mitochondrial mechanism of damage. And extracellular like FAS, FAS receptor activations like that. Then comes the second stage, as process of programmed cell death. There is the activation of through caspases, activation of DAPE receptors, that is CD95 on the cell surface, and also activation of the growth controlling genes, BCL2 and P53. These are growth controlling genes. Actually, you see, CB and the BCL2, these are opposing genes, always controlling. One is just trying to destroy, one is trying to promote. So some balance is going on between these 3 for the proper cell development and growth. And then ultimately phagocytosis, where the surface phosphatidyl serine expression or thrombospondin which are expressed. So this is the ultimate. So you see the mechanism, the different types of injury may lead to some extrinsic pathways. So you can see one mitochondrial damage mechanism through the intrinsic pathways, and extrinsic pathways also the cell surface activations and CD95 activations like. So this. So if you see one dynamine related protein 1, DRP1, this dependent excessive mitochondrial fragmentation in hematopoietic stem cells or pluripotential cell or progenitor cells, which lead to excess reactive oxygen species production and induced inflammatory signaling activation and promoted subsequent dysplasia formation. And also it leads to impairment of the granulopoiesis. So mitochondrial fragmentation was generally observed in most of the patients of the MDS. So this is the best mechanism of the damage by the mitochondria. You see, I'm not going to the details of the FAB classification. Even mostly we are concerned with the MDS FAB classification. It was there, and later on the WHO classification of MDS, where you can see nowadays clearly you see the single lineage dysplasia, multilineage dysplasia with ring sideroblast, with excess blast. So just I want to say mostly FAB classification what is there here and the WHO classification, mostly they are not dissimilar, but they are difficult. Their excess blast was there. Here MDS with excess blast has been subtyped into 1 and 2 in WHO classification. Like that are more detailed. And nowadays mostly you see chromosomal abnormalities are there in the MDS. You know, de novo MDS, mostly 50% chromosomal abnormalities in 50% cases. And in T-MDS, means therapy-related MDS, you see 100%, almost 100% cases you find categorically there are some form of chromosomal abnormalities. So you see molecular pathogenesis is very important. And you see say early mutation in the stem cells, they call differentiation arrest. But later on, where subsequent mutations, that they cause clonal expansion. So you see early the mutation cause differentiation arrest. So you see ineffective erythropoiesis. But later on, clonal expansion develops in subsequent anomalies. And you see common chromosomal abnormalities here you see 5q, 7q, 11q, like that, even the 17q, 5q deletion or say loss results in what? Probably the postgraduate senior, the junior, there no 5q, this is the site for the, hematopoietic growth factors and some receptors like interleukin 3, 4, interleukin 5 or GM-CSF or MCSF, all these are located in the Q arm of the fifth chromosome. So if it is lost, so definitely you can understand what will be the effect. In 7q, there what lies, one of the important thing, that is some glycoprotein loss is there, GP130, and GP130 is related to what? The deficient functioning of the neutrophils. So what happens if the MDS patients suffer from recurrent infections? So see in 11q, you see there are some loss. Here you see in the long arm Q, there are some changes in the H subunit of the ferritin molecule. So you see in this condition mostly the MDS with ring sideroblast and like this. Similarly, I have not written here 17q. 17q, there, P53, there. So if there is loss or less function of the P53 gene, what happens? Definitely there will be clonal expansion because it is a tumor suppressor gene. So naturally there may be clonal expansion. So in this way we can elaborate their different chromosomal abnormalities and their loci. So rightly, so and it will be interesting. Now, karyotype, so why this is important is definitely karyotyping in MDS cases is very important for the proper classification of the MDS. It is important for the presentations, how the cases will progress, or it is important for the prognosis, because IPSS, International Prognostic Scoring System, they are dependent on few things, that is the presence of blast or the karyotypic changes or cytopenias. All these are taken into account in the scoring system. So naturally, this is also important. Now, I have taken into account this particular thing because in the bone marrow examination is one of the important thing in the MDS. MDS is not easy to diagnose like that. Even the hematopathologists, those who are dealing with the hematology specifically, this ALIP or abnormal localization of immature progenitor cells has to be found out in MDS, and if they are found, it is very suggestive of MDS. So abnormal localization of clusters of immature progenitor cell, that is in short ALIP. Now, I am going in quickly to some of the changes which may develop in the blood and blood cells. Like all the three lines may be affected, I told you, the trilineage, not maybe in a single cell line, but mostly these are trilineage, and of these, erythropoiesis, dyserythropoiesis is one of the most important thing. And you see series of changes in the RBCs, and anemia is there, maybe macrovalocytes may be present in the blood, there may be low retic count, nucleated RBCs are there, so all dysmorphic. Megaloblastoid changes are sometimes there, ring sideroblasts, Pappenheimer bodies may be present, basophilic stripling may be present in the as a part of the dyserythropoiesis. Now, these are some of the picture. You see the picture RBC. These are changes, and this is one bizarre one nucleated RBC is there, and also you see these are sideroblasts, ring sideroblasts, and you see. Now, about the dysmyelopoiesis, this is also important, neutropenia, monocytosis, Pelger-Hewitt abnormalities, and what is most important is the hypogranular promyelocyte, polymorphonuclear neutrophils, and also definitely less than 20% blast in bone marrow, and type 1 and type, I'll describe what is type 1 blast and type 2 blast later on. So, you see blast cells, you see some, this type of neutrophils which are bilobed and hypogranular in character. This is one dysmorphic cells. This is also one bizarre cell. So, dysgranulopoiesis, they are not looking like that, 4 or 5 lobes neutrophil. These are dysmorphic neutrophils. Similarly, blast, I told you that the different types of blast will happen. Type 1 blast is very easy. Their granules are absent, very prominent nucleoli are there, and nucleus is central. This is different from the promyelocyte, where some granules will be there, and less prominent nucleoli and eccentric nucleus in the promyelocyte. But in type 3 blast and type 2 and 3 both, there are some granules are there, prominent nucleoli. But here also central nucleus, but most important thing is that you will find some ore rods, which is very diagnostic of myeloblast. Anyway, ore rods are there. So this is the picture of the type 1 blast and type 2 blast. You can clearly see the difference. In the type 1 is more premature type, granules are absent, no ore rods are there. Here the granules are present. And nucleoli also inconspicuous. You cannot see the nucleoli prominently. But here you see the nucleoli is very prominent. Right? So you see, this is also another picture. I showed in the lower side, you see chronic myelomonocytic leukemia and NSC stain, non-specific esterase, they are stained better. These are all dysplastic cells, you see. So with some pictures I have been able to show you. And this megakaryopoiesis, that there is another third line. Here also low platelet count. Sometimes giant, is both the size. Sometimes giant platelets are found, and sometimes very dwarf or micro megakaryocytes are found. And platelets, these are specially, this can be identified by CD markers. That means some of the CD41 or CD61, they can detect this type of megakaryocytes. So this is there. So you see, these are micro megakaryocytes, and abnormal platelets or giant platelets or microplatelets may be there in the MDS. So this is a very short time. I just tried to highlight some of the areas of the myelodysplastic syndrome. It's not possible in 20 minutes, and I probably have done justice to the time.
Thank you, Dr. Mitro. Thank you. Now I know why you are such a great teacher in so many colleges. Excellent, very clear. Yes, very short time, I understand that. And I'm sorry that we couldn't provide you with more time for teaching, but sometimes we'll be taking the master classes where you'll be able to teach. Right. So, I mean, traditionally on a oration, the questions are not permitted. So, I would like to close the session here, but if you have any questions, I am sure Dr. Mitro will be ready to answer that in private. Thank you, Dr. Mitro.
Thank you.
And over to the organizers.
Thank you, sir. Sir, please. Now we will proceed for our felicitation ceremony of Dr. Bilkis Begum, Madam. May I request our chairpersons to invite Dr. Bilkis Begum, Ma'am, to the dais.
Dr. Begum, may we please have your presence? She was a very senior hematologist from School of Tropical Medicine. Many of you who wouldn't know, she was there for a very long time in School of Tropical Medicine. Yes, Dr. Begum.
Now the summary of the life of Madam and her contribution to the field of hematology department in West Bengal as well as our country will be presented by Dr. Ishu Vidatri, President of Hematology of NRS Medical College and Hospital, Kolkata.
Professor Bilkis Begum was born on 23rd of August 1950. She did her MBBS from Calcutta University and subsequently she did her post-graduation in Diploma in Childhood, Diploma in Clinical Pathology and MD Pathology. She joined West Bengal Health Services in 1978 and was transferred to Department of Haematology at Calcutta School of Tropical Medicine, Kolkata in October 1982. She served hematology department in her long professional journey as demonstrator to professor till date of superannuation on 38 August 2012. She was teacher of not only hematology but was also actively involved in the following postgraduate teaching programs such as MD Tropical Medicine, Diploma in Tropical Medicine and Hygiene, Diploma in Lab Techniques, DM in Clinical Hematology. She was also an examiner of DM Clinical Hematology in year 2010 and 2011. Her outstanding service in the field of hematology even included diagnosis of hematological disease such as lymphoma, leukemia, thalassemia, hemophilia and other bleeding disorders. She catered clinical and outpatient service to the hematological patient when the specialty was not having sophisticated treatment guidelines or targeted therapy as of today. To mention one among many of her achievements in the field of hematology was that she was a core team member of the first autologous transplant, bone marrow transplantation done at Hematology Department, NRS Medical College, Kolkata in the month of January 2009. To add to her ongoing long academic endeavor, she has published 25 papers in different national and international journals. We are lucky to have you today among us today, ma'am. Your enormous knowledge over the years acquired through your long teaching and clinical practice in the field of hematology not only enriched us but also a generation of students in the field of hematology subsequently. Madam, we the members of Bengal Society of Haematology are proud to have you here. Thank you.
Now, Dr. Bilkis Begum Madam will be felicitated by Dr. Utpal Chaudhuri sir. Please. May I request Dr. Shantanu Basu sir to felicitate Madam. Now we request Dr. Bilkis Begum Madam to address the audience, please.
I am thankful to the organizing committee members who have selected me for this honor. I am feeling very much honored for this felicitation. Thank you very much.
Now I request Dr. Utpal Chaudhuri sir and Shantanu Basu sir to give the medal for securing the highest marks in DM Clinical Hematology University exam of 2021, and the award goes to Dr. Malini Garg. Please come to the dais. Now, I request to the chairperson to stay on the stage for receiving a small token of our gratitude by Dr. Tufan Kanti Dolai sir. Thank you, sir. Thank you, ma'am. Now we are going to start the inauguration ceremony of Professor J.B. Chatterjee Memorial Celebration and BeSHCON 2022. First of all, we request Dr. First, we request Dr. Pradeep Mitra sir, Senior Consultant of Hematology and Vice President of Bengal Society of Hematology, to come to the dais. Now we invite Dr. Tufan Kanti Dolai sir, Secretary of Bengal Society of Hematology. We invite Professor Dr. Siddhartha Shankar Rai, Organizing Chairperson of BeSHCON 2022, to kindly come to the dais. We invite Dr. Shantanu Basu sir, Scientific Chairperson of BeSHCON 2022. And last of all, we invite Dr. Shubhranil Baul sir, Organizing Secretary of BeSHCON 2022, to come to the dais kindly. Now felicitation will be done by Dr. Rishu, Dr. Kushumita, and Mrs. Rama Roy Shamal. Mo Mukherjee and Chakraborty and Pinky Maji. Now we will listen the welcome song, and it is Rabindra Sangeet, will be sung by Miss Sharupa Bhattacharya, Shoma Sen, Mo Mukherjee Chakraborty, and Mrs. Rama Roy Shamal.
দিয়ে দিন হালকা ওনাকে এখানে লাগিয়ে দাঁড়া আমাদেরকে লাগিয়ে দিই তাড়াতাড়ি করুন চলে এসো আগে সমাধি চাও আমি লাস্টে দাঁড়াবো তাহলে এদিকে এসো কিছু দেখা যাবে না ডায়াসে বারণ করছি আরেকজন আছে দাঁড় রমাডি একটু সরো রমাডি হারাতে পারবে না তুমি চলে যাও স্বরূপাদির পাশে তুমি চলে যাও স্বরূপাদির পাশে হ্যালো
अग्नि स्पर्शमणि लगया प्राणे जीवनं पावया जीवनं पावया जीवनं पावया जीवनं पावया दहनदानै আগুনের পরশমণি ছোঁয়াও প্রাণে এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো দহন দানে আগুনের পরশমণি ছোঁয়াও প্রাণে আমারে দেহ খানি তুলে ধরো তোমার ওই দেবালয়ের প্রদীপ করো আমারে দেহ খানি তুলে ধরো তোমার ওই দেবালয়ের প্রদীপ করো নিশিদিন আলোক শিখা জ্বলুক প্রাণে নিশিদিন আলোক শিখা জ্বলুক প্রাণে আগুনের পরশমণি ছোঁয়াও প্রাণে আধারের গায়ে গায়ে পরশতব সারা রাত ফোটাও তারা নব নব আধারের গায়ে গায়ে পরশতব সারা রাত ফোটাক তারা নব নব নয়নের দৃষ্টি হতে ঘুচবে কালো যেখানে পড়বে সেথায় দেখবে আলো নয়নের দৃষ্টি হতে ঘুচবে কালো যেখানে পড়বে সেথায় দেখবে আলো ব্যথা মোর উঠবে জ্বলে ঊর্ধ্বপানে ব্যথা মোর উঠবে জ্বলে ঊর্ধ্বপানে আগুনের পরশমণি ছোঁয়াও প্রাণে এ জীবন পূর্ণ করো এ জীবন পূর্ণ করো, এ জীবন পূর্ণ করো দহন দানে, অগ্নি স্পর্শমণি लगाया प्राणे, जीवनं पावया, जीवनं पावया, जीवनं पावया, जीवनं पावया दहनदानै, अग्नि स्पर्शमणि लगाया प्राणे। नमस्कार।
Thank you so much. Now, welcome address will be delivered by Dr. Siddhartha Shankar Rai sir to the audience.
Good evening, everybody. So actually, it's my great pleasure that I was given this duty of welcoming you all in this August gathering, actually where our younger brother, Dr. Subronil Baul, very enthusiastic organizing secretary, has organized very well conference where we have learned quite a few lot of things about the hematology, hematopathology, and there was actually it is made a very good platform to interact between each other. And it was very difficult actually. At the beginning I was also doubtful whether it will be possible to organize this attendance where everybody can come and meet physically, but he has, and we, under the able guidance of Tufan, he made it possible and quite successful, because today during lunch we found that we are short of lunch because so much attendance. We didn't expect that much actually. So I congratulate Subronil, Tufan and all the organizing person who are working with us. I welcome you all to this grand academic event, and I expect tomorrow also you will be with us and you will interact with each of the speaker to make it more interactive and more interesting. So thanks for coming and spending 2 evening, not only the evening, 2 whole days with us. Thanks again. I welcome you all.
May I request Dr. Pradip Kumar Mitra sir, Vice President of Bengal Society of Haematology, and other dignitaries to light the inaugural lamp. May I request Dr. Shantanu Basu sir, Scientific Chairman of BeSHCON 2022, to release the conference souvenir and address the audience a few words. Please, sir, few words for the audience.
Good evening, everybody. I don't want to stand between you and the lunch and the dinner, sorry. But still, traditionally, it is my proud privilege to welcome you all to this conference. We have been meeting after a very long time and certainly enjoying the activities. Though I am nominally the scientific secretary, but I really didn't have much to do with Shubhronil doing all the work for me. And they have really had a very wonderful menu of academics. Tomorrow will be another very good day. Today was a very good day, and I hope you all enjoy it thoroughly. Thank you very much.
Now I kindly request Dr. Tufan Kante Dolai sir for address the audience.
Good evening, respected dignitaries, ladies and gentlemen. On behalf of the Bengal Society of the Haematology, we welcome you all, because you know the hematology is born in Calcutta. You know the Professor J.B. Chatterjee, who is the pioneer in the field of hematology, and the hematology started in India from the Kolkata only. So we are the generations of the J.B. Chatterjee. We are doing the activity under the banner of the Bengal Society of the Haematology. Not only that, our previous society, they have been actively worked together. That's why we are able to reach in certain extent. Especially Professor Utpal Chaudhary sir, Dr. Shantanu Basu sir, and the other also the seniors, they have been do very work related to the hematology in the West Bengal. And if we come to the Bengal Society of the Haematology, this is the very vibrant society and acting not only into the different CME and also the conference, and lot of the other NGO activity we are doing on behalf of the Bengal Society of the Haematology across the poor people. Apart from that, we are the only society, we have a registered official address, we have an office, and this is really grateful to us, particularly our senior. Again, I am Dr. Utpal Chaudhary sir and the Shantanu Basu sir for their vision. And after that, we are the only society of the India, the state society into the hematology. We are able to initiate our journal. Our journal name is the Hematology and the Allied Sciences. So this journal is in process. So I invite every people should submit their article to fruitful our success into the journal. Coming to the BeSHCON 2022, when we plan for this conference, we have several meetings with our seniors, and really we are very afraid that there will be corona wave into the third wave. That have been already predicted from the long time back, and our conference is the second week of the February. So we are very afraid during the design of our therapy, but fortunately we are able to do the first physical conferences in this year. And this year we have been choosing the the organizing chairperson, Dr. Siddhartha Shankar Rai, and also the young, energetic, the budding hematologist practicing in the field of hematology in Kolkata, Dr. Subranil Baul. With his hard work, we are really able to conduct this 2-day program, the full 2-day program, the physical conferences, and involving all the aspects of the hematology, starting from this, the oral presentation, the postal presentation, the scientific seminar, the orations, and also not only that, there is a cultural night. So I really thank Dr. Subranil and Dr. Siddhartha Shankar Rai. And lastly, I thank all the audience for giving us the valuable time with us. With this, thank you very much and good night to everybody.
Thank you so much, sir. Now I invite Dr. Subranil Baul, sir, Organizing Secretary of BeSHCON 2022, to give vote of thanks.
So, respected dignitaries on dais and all the audiences, I say good evening to you, and already my seniors here have already welcomed you for the conference. But the point is that have you noticed the tagline that the more you connect and more you learn? I hope that not only that this is the place to learn, you can learn outside also by discussing among yourself any interesting cases in hematology. Besides that, there are so many things to learn. One and second most important point, I won't take much time, that I was very sure that it is very difficult to organize this BeSHCON 6th annual conference this year because of COVID related issues, and I'm thankful to all that I could make it with the blessings of my seniors and with the help of all the faculties who have come from different parts of India and also from my state. Thank you all, and I hope you enjoyed the dinner now. Good night.
Thank you, sir. Now it is beautifully concluded our inauguration ceremony of BeSHCON 2022. Thank you.
Thank you very much for the spectacular performance and the fascinating knowledges by delegates. Now we are going to have the dinner. I request all the guests and ladies and gentlemen, please go forward with the dinner. Thank you.